Good morning, everybody. So a very warm welcome to all of you to Tata Memorial Center. So Tata Memorial Hospital was founded in 1941. So we are now completed 84 years of service taking care of patients with cancer, with our mandate being mainly for providing high value evidence-based care, impart training to cancer personnel across the country, as well as education. To start off the program, I would now like to welcome Dr. Sripad Banavali, Director Academics, who will now welcome the gathering. Dr. Banavali.
Yeah, good morning, everyone. And on behalf of the administration of Tata Memorial Center, I welcome you all to this EBM. And, this is, I think, the third time we are doing pediatrics. But, there's a lot of new things that's happening in our field. And right from basically the cancer predisposition to the latest thing of precision oncology, immunotherapy, and most importantly, survivorship, which is becoming more and more important. I think that the pediatric unit, Girish and his colleagues have really done a great job to have a lot of talks included in this meeting. And as we were just discussing, there's a parallel track going on in infectious diseases, which also is very, very interesting and important. But I think we cannot be at two places at one time. We'll have to, Mukesh, we'll have to clone ourselves to be present at two places at the same time. But really, some really good talks in the other track also. Some of you may want to attend those also in between. But thank you for coming here. Actually, we keep this the inauguration very short and sweet. So without wasting much of your time, I welcome you all once again, and I have a great 3 days of deliberations in the, and even basically see if you can attend the other one. Also, there's another interesting thing going on in interventional radiology in pediatrics, related to pediatrics up. So there are some other thing also, workshops going on there. So a lot of interesting things happening, and I know, see what all you can attend and what all you can take away from here. So thank you, Girish and team, and welcome once again. Thank you.
Thank you, sir. Dr. Banavali, as you all know, has really spearheaded the pediatric oncology services at our hospital. I now request Dr. Sudeep Gupta, Director, Tata Memorial Center, and a very senior medical oncologist in the field of breast and gynae oncology, to address the gathering.
Good morning, ladies and gentlemen. On behalf of Tata Memorial Center, it is my privilege to welcome you all to the evidence-based management of cancers. Girish has already said that we were founded in 1941 by the House of Tatas. Since 1962, we are an institution under the Department of Atomic Energy, the Government of India. We are currently the largest cancer hospital in India. We have 11 hospitals in 7 states of India, 2 of which are, of course, under construction. And in the most recent calendar year, we registered about 129,000 new cancer patients in all our hospitals. This meeting is not just an update meeting. As its title suggests, everything is evaluated on the yardstick of evidence-based management principles. It started in 2002. And the other very unique thing about this meeting is that we try to evaluate what is applicable, implementable, including in resource-constrained settings. The previous year's deliberations have been captured in what we call the EBM textbooks, and since last year, they are also published in peer-reviewed journals. So I hope that you will appraise the evidence not only with respect to what is cutting edge and what is possible, but also what is doable and implementable throughout a country like India in similar situations. I would also like to take this opportunity to urge and request and invite all of you to 2 further events within this EBM meeting. One is the inauguration and oration ceremony, which is scheduled for tomorrow, Saturday, beginning at 11 a.m. Professor Soumya Swaminathan, the former Director General of ICMR, is scheduled to deliver this year's oration, and Professor Mahesh Parmar from the Clinical Trials Unit of UK is scheduled to deliver the keynote address. And I would also invite all of you to the hospital day dinner tomorrow evening at the Taj Lands End Hotel. So I wish all of you great deliberations. Pediatric oncology is not my forte, but I understand that it is one of the poster childs of oncology with high cure rates and ever better quality of life for survivors. Thank you very much and wish you all the best.
Thank you, Dr. Gupta. So we'll now start off with the first session. To conduct the proceedings, I now invite Badira to take over and conduct the first session of the day.
Thank you. Very warm welcome to all of you again. As you all know, as the title goes, one of the changing paradigms in pediatric oncology care has been the recognition and incorporation of germline genetics into routine clinical care. As much as this is pronounced in the Western world, implementation of this is very challenging in the low middle income countries, including India. So this is going to be the opening session of this day. And to chair the session, I would like to invite Dr. Mukesh Desai. No, he needs no introduction to this crowd. And also we have Dr. Ratna Sharma. Dr. Mukesh Desai practices immunology and is affiliated to the Jarbai Wadia Hospital. And we have Ratna Sharma. She's a consultant hemato-oncologist and a BMT physician in the CTC Borivali. So over to you, the chairpersons.
Good morning, everybody. We welcome you to this EBM meeting. And I'm reminded of my mentor who taught us that a child is a growing organism, while an adult is a degenerating organism. And we are so glad that the focus is on pediatrics. So over to Ratna for inviting the first speaker.
Thank you and a very good morning to everyone. It's a pleasure to invite Dr. Deepak Bansal for his, the first talk of the day and of the whole program, Cancer Predisposition Syndromes, Overview and Therapeutic Implications. Dr. Deepak Bansal needs no introduction to the audience. He's at PGI Chandigarh, a known consultant pediatric hematologist oncologist, and also into BMTs. Over to you, sir.
Thank you so much, Ratna. Always a pleasure to be in Tata. So can I have my first slide, please? So I'll be speaking on overview and therapeutic implications of cancer predisposition syndromes. And I think I'm the best person to speak on this because I'm not an expert on it. And I have to do this in 15 minutes. So an expert could never do this in 15 minutes because he would be overwhelmed. So I think I'll try my best. So cancer predisposition syndromes are responsible for 7 to 15% of childhood cancers. And this prevalence is increasing over the decades because genetic sequencing technologies are improving. And at least in research settings, whole genome sequencing is being done in preference to whole exome sequencing. More than 100 CPS have been described to date. Majority are autosomal dominant with incomplete penetrance. So can one suspect these syndromes clinically? And the answer is sometimes yes. If there is a family history of cancers occurring in relatively young individuals, or if there is an overt clinical phenotype, like Cafeolus spots in the skin, disorders of growth, neurodevelopment, which is delayed, dysmorphism, problems with eye, ear, heart, thyroid, or genitourinary, like typical examples of Fanconi, hemihypertrophy, or ataxia telangiectasia. So in these cases, the diagnosis precedes the diagnosis of cancer. But often there are no clinical clues, the monogenic causes, examples being Leaf-Romany, von Hippel-Lindau, and several others. So what are the implications for diagnosis? Why, as pediatric oncologists, we really need to diagnose them? So one may have to adapt treatment because they are more prone to higher toxicities. And some of them may be at higher risk of relapse, although not all of them. And more important, we need to do surveillance, which is early detection of neoplasms, either primary or second cancers. And then one needs to counsel the family again for surveillance and sometimes offer antenatal diagnosis. So most of the cancer predisposition syndromes have a higher mortality, either because of toxicity of treatments or because of second cancers. So in the papers, it's just some of them are described as classic cancer predisposition syndromes. So all of these, which you can eyeball, have been described for several decades and have been well described, although there are a large number of CPCs, as I said earlier. So I'll take you through several pictorial examples of these syndromes. So a girl with acute spots, scoliosis, which is seen in up to 25% cases of neurofibromatosis, and a neurofibroma encircling the spine. So some more NF1 cases, which are easy to diagnose clinically if they are a little older, multiple Caffiolus spots, scoliosis, and neurofibromas in the shoulder areas and the back, and another girl with a tumor here in the shoulder. So the NF1 is the pathogenic variant, autosomal dominant, although 50% are de novo, but great variability in clinical expression even within the same family. So the tumors are optic pathway gliomas, benign or malignant peripheral nerve sheath tumors, brain tumors, and JMML. So what is important is that there is a strict surveillance protocol for all these patients of physical examination, exactly what needs to be examined, and eye exam starting from birth till 8 years. So we see this randomly in the clinic, hemihypertrophy, and it may represent a part of Beckwith-Wiedemann syndrome because they have a similar genetic etiology and predisposed to Wilms tumor and hepatoblastoma. So again, there are screening protocols every 3 months, abdominal ultrasound until 7 years, and serum AFP until 4 years of age. So another child with hemihypertrophy with hepatoblastoma. So these are siblings with xeroderma pigmentosa and another child. So the sun-exposed areas have these black hyperpigmented areas, and the areas which do not have sun exposure are spared. And eye damage is well described in this condition. So they have defective nucleotide excision repair and predisposed to cancers of the skin, basal cells, squamous cell carcinoma, and other organs. They have to be followed up by dermatologist for UV protected environment, no exposure to sun, sunscreens, and surveillance for tumors. So Fanconi anemia, of course, we are all exposed in our everyday clinics. A child with Fanconi with a tumor in the chest. So how can we forget retinoblastoma? 40% have germline pathogenic variant in the RB1 tumor suppressor gene. And we know that tumors which are bilateral or trilateral are hereditary, and it could be there in the father, in the parent and the child. So a father with a prosthesis and the child has retinoblastoma as well. So a treated case of retinoblastoma has had an enucleation presenting with osteosarcoma. So they are predisposed to second cancers. So what is the practical use of retinoblastoma genetic testing? So if RB1 is positive, one has to have the siblings under regular examination under anesthesia for vision preservation and to avoid enucleation. Again, if the RB1 gene mutation is negative, the important thing is one can avoid surveillance because doing EUA is not that easy. And certain cases, one can offer antenatal diagnosis and MTP if the family so desires. So chest masses. So pleuropulmonary blastoma, association with Dicer-1 syndrome, they are predisposed to multinodular goiter and thyroid cancers, lung cysts, ovarian neoplasm, cystic nephroma, and genitourinary RMS. So I mean, cancer predisposition syndrome does not mean malignant, but it could be benign tumors as well. Again, in the articles, there are strict surveillance protocols of clinical exam, 6 monthly chest X-rays, ultrasound of the kidney and the thyroid at defined intervals. A boy with ataxia telangiectasia presenting with a lymph node mass, which was a TNHL, so lifetime cancer risk of 10 to 25%. Predisposed to NHL, Hodgkin's, leukemia, and breast cancer. So therapeutic implications: avoid alkylating agents, etoposide, and radiation, reduce the dose of methotrexate, limited experience with transplant, but typically reduced intensity conditioning is recommended. It's hard to treat these patients because the median age at death is even otherwise 25 years. So however, clinical clues are often lacking in many patients. So what does one do? How does one diagnose? So for this, we have clinical screening tools. So this is the most important. So whenever you have a child with the cancer, one is supposed to run that child through a clinical screening tool to decide whether he's predisposed to cancer predisposition syndrome. And the next talk is based on this, but very briefly. So there are 3 of them: childhood cancer screening checklist, Jongman's criteria, and the recent modified one, and this one called as McGill Interactive Pediatric Oncogenetic Guidelines. So the last one actually comes as an app which one can download. So let's say one chooses the tumor type, and if it is ALL, it will ask you 8 questions. The first of them is there evidence of low hypodiploid ALL? Yes or no, and then go on to the next question. So at the end of the whole exercise, it will tell you whether the CPS genetic analysis needs to be done or not, because it is just impossible to remember all these things while sitting in the clinic. So these screening tools typically have 5 components. So number 1 is family history, typically goes up to 3 generations, largely looking at whether there have been cancers at relatively younger age or if there is consanguineous marriage. But remember, 50% of children with cancer predisposition syndrome do not have a positive family history. So the second component is a list of malignancies which require direct genetic referral. So if you have the tumor, you have to do the test. So I'll spend some time on this: CNS and ocular tumors like ATRT, choroid plexus carcinoma, hemangioblastoma, optic pathway glioma, retinoblastoma, looking at some kidney tumors, cystic nephroma, benign one, RCC, soft tissue tumors, fibromatosis, rhabdoid tumor, MPNST for NF1, and some other specific tumors like adenocortical carcinoma. If you have it, I mean, if a patient has it, one has to do the test. And then adult cancers occurring in children like colorectal carcinomas, then carcinoma of breast, lung, cervix, all cases of hepatoblastoma, and then GIST, pheochromocytoma, pleuropulmonary blastoma. One has to test them for CPS. Third, previous history. Any child with 2 or more malignancies, which is not that common. And then, which is more common, is if they have any clinical phenotypical examination findings, like congenital anomalies, facial dysmorphism, mental impairment or developmental delay, skin anomalies, or immune deficiencies. And finally, some of the scores have patients, this criteria, patients which suffer from excessive toxicity of cancer therapy. So the clinical screening tool, when you apply to them, let's say if you run it on 100 patients, about 1/3, 33 will be positive, in whom a targeted analysis can be done to identify the CPS. So high sensitivity, more than 90% of those with CPS can be identified, but will miss a few. So the other alternative is to go for universal sequencing, which means to test every child with cancer. So to do whole exome sequencing or whole genome sequencing with multiple genes. No diagnosis will be lost, and you can even make new discoveries. But of course, it's expensive. Interpretation of variant of unknown significance is always a problem, leads to anxiety, typically done under research setting. So in LMICs, it's the clinical screening tool which is typically advised for. Always remember that our survivors run the clinical screening tool. If it is positive, test them for NGS. So when should surveillance be done for early diagnosis of tumor? And the threshold for this is cumulative childhood cancer incidence is 5% or more by the age of 20 years. So I'll talk now on some particular cancers and the risk of cancer predisposition syndrome. So a bit busy, but I'll go through this. So embryonal RMS, because we see them frequently associated with Li-Fraumeni, Dyson, and a few other. Risk is 10%, and genetic testing is directly recommended if it is anaplastic embryonal or thoracic genitourinary embryonal. Alveolar, associated with Li-Fraumeni, but the risk is not too high. ATRT and rhabdoid, associated with SMARC-C, 1/3, all are to be tested. Fibromatosis, all need to be tested. MPNST, we have discussed this with NF1, so either tested or clinically screened. Osteosarcoma, associated with several, high risk but no formal recommendation. Ewing sarcoma, 10%, no formal recommendation. So what are the therapeutic implications of knowing once you have the diagnosis? So there is paucity of data and insufficient guidelines. So although we keep on saying avoid RT, avoid alkylating agents, but if the best chance for cure requires utilization of radiation or alkylating chemo, one can discuss the risk with the family, but do not omit these modalities. I guess, you need to have the patient to have a second cancer. But if there are alternative treatment options that yield equivalent survival rates, choose them. So that's common sense. So let's say if an ALL has TP53, then maybe one could consider giving blina over the conventional chemo. So talking about Li-Fraumeni syndrome, because that's the star of the show. So the TP53 tumor suppressor gene is the germline variant, and the loss of TP53 results in cells containing damaged DNA that proliferate, resulting in development of neoplasms. So high incidence of lifetime cancer risk, as you can read here. So no phenotypic manifestation. If you do not test, you'll miss it. So autosomal dominant, high penetrance, and unusually wide spectrum of cancer types. So although it leads to many cancers, but there are some core cancers like adrenocortical carcinoma, breast, choroid plexus carcinoma, osteosarcoma, and soft tissue sarcomas. So when should one test for TP53? So I've already gone over the screening tools. So one can run over that screening tool and see if it yields positive, one can test for it. But because it's so important, it's got its own score called as the Chomprey diagnostic criteria. So one of them has to be positive. So one can go through these, either if it's an adrenocortical carcinoma, choroid plexus tumor, multiple tumors, or specific tumors occurring at younger age. So what kind of cancer surveillance needs to be done? So something called as a Toronto protocol, which has well-defined, investigations that you can read at regular specific intervals. And once the patient is above 18, breast MRI, colonoscopy, skin exams. In the future, maybe liquid biopsies will be done for early diagnosis of cancers. So what are the cancer preventive interventions that one can do for patients with Li-Fraumeni? So this is what is described. Bilateral mastectomies, colonoscopies to remove benign polyps, resection of low-grade gliomas, reduce exposure to sun, tobacco, alcohol, radiation, and chemicals. And in the future, these drugs are being tried, which may delay or eliminate tumor development. Just a few more slides. So I was reading about this whole body MRI, and it's something which we don't do on a regular basis. So I was just curious about this. So the advantage, it's got a large field of view, and of course,
Can you wind up your talk?
Sure.
You have a minute.
Sure, just 2-3 slides. So in resource limited settings, one can go for clinical exam, ultrasound, and brain MRI instead of a whole body MRI. So these are those fearful terms, but again, it's one of the most aggressive one. And again, there are screening protocols. Once you diagnose CMMRD, the neuro-oncologists particularly are involved with this. And these are the other ones. Just last few slides. So once the CPS is diagnosed, how to ensure that one adheres to surveillance protocols? Again, there are apps for this, which will tell which investigation is to be done at what time. So, all of us do not have access to these investigations. Thankfully, private labs are doing them. This is one which I could see, 143 gene panel costing about 17,000. So it's not cheap, but at least it's available now. So this I will ignore. So this is my last slide. So, as pediatric oncologists, we deal every day with clinical oncology. Some of us also do benign hematology. one is never happy if one is not doing transplants. And then one is reminded to do palliative care and survivor clinic as well. And how can you forget fertility preservation? And now cellular therapy is chasing you. And among all this, Maya sends an email saying you have to prepare a talk on cancer predisposition syndrome. So something which is again, it's like one feels like one has to be like an octopus. But if I have to summarize, one has to run the clinical screening tool in all children with cancers. If it is positive, go for the molecular test, family screening, surveillance of early detection of cancers in patient and family, and offer prenatal counseling. Thank you so much.
Thank you, Dr. Deepak. And with this, we'll move on to the next talk. We have question and answers in the end. So we'll move on to the next talk, which is an online talk by Dr. Sharon, Cancer Predisposition Syndromes, How to Test, Screen, and Interpret Results. So Dr. Sharon will be available for the Q&A session at 10:45. We have a recorded talk by her for 15 minutes now.
This is Dr. Sharon Plon. I was asked to talk today on cancer predisposition syndromes, how to test, screen, and interpret results. I'm a medical geneticist from the Baylor College of Medicine, Department of Pediatrics, and Texas Children's Hospital in Houston, Texas. On the first slide, I like to give a general overview on current approaches to hereditary cancer testing. Although we often talk about things like exomes and genomes in research, there are still many circumstances where a single gene is the most appropriate test. When I see a baby with retinoblastoma, I order the RB1 gene. If a child has a very specific phenotype, has multiple capillae spots, and axillary freckling and a plexiform neurofibroma, I order the NF1 gene. Similarly, there are genes that are highly related to each other, such as the two genes TSC1 and TSC2 that are responsible for tuberous sclerosis. The most common type of genetic testing currently done for hereditary cancer in both adults and children are multiple gene panels. These can be highly variable in size, from 5 to 50 to 100 genes, and they include the genes that are responsible for specific cancers. So for example, a hereditary leukemia panel or a hereditary brain tumor cancer panel include the genes that are associated with many different genetic causes for those cancers. In terms of whole exome or whole genome, they are sometimes done as part of a paired test with tumor testing, or they are sometimes very useful if a child, for example, may have a very rare recessive disorder where knowledge is rapidly accumulating and there is not a good gene panel, such as Fanconi anemia, or a child that has a very complex phenotype where it is hard to know what the gene might be. To give you an example of the type of results you might find, I want to talk about a study we recently completed and published called the Texas Kids Can Seek study, where we directly compared exome versus panel results. My colleagues who were also co-leaders of the study are shown here. We used 6 different centers in the state of Texas, a diversity of size of our clinical sites and of patients, and children were enrolled who were newly diagnosed or had recurrent solid tumors, lymphomas, or rare histiocytic disorders, and 80% of the parents who were approached agreed to participate. All children in the study had hereditary panel and exome testing of a blood sample done in parallel, so we had the results of both for each child. As we published earlier this year in JCO Precision Oncology, overall, about 18% of the children had some type of pathogenic or likely pathogenic mutation in a hereditary cancer gene. About a quarter were negative, and about a half had only uncertain variants that we'll talk about later in the talk. So there were 103 different cancer variants in this group of about 600 patients. We looked directly at the diagnostic result for exome versus panel. And this was a pediatric cancer panel that was designed with treatment more in mind than hereditary cancer, but focused on genes most likely found in pediatric cancers. And you can see that the exome had about twice the diagnostic yield, shown by these Venn diagrams, where there were 54 patients with exome-only findings. Or if you look at the overall diagnostic rate, it was 16.5% with exome, 8.5% with panel. However, if you focused in on those genes that we know cause pediatric cancer, or for which there are recommendations in childhood for surveillance, there the findings were about 8% in both, with significant overlap. So these were not statistically different. And the panel picked up some complex mutations, rearrangements that the exome missed, and the exome picked up some rare recessive and newly described cancer genes that the panel missed. So again, this result is the reason why a lot of hereditary cancer testing relies on panels. So what are the advantages of panels? Certainly compared to one gene at a time, it simplifies the genetic testing process. You have to have less family history and pathology information because you're not being as specific as testing only one or two genes. You can more rapidly identify the variants across the genes on the panel than doing a whole exome or a genome. But the larger the panel gets, the more likely you are to have uncertain variants, as we'll discuss. You can get surprising results. So you can find pathogenic variants in genes that were not associated with the patient's history. So this should be SMARC A4. We found a pathogenic variant in a patient with neuroblastoma several years ago, and that was not thought to be associated with neuroblastoma. Now there have actually been many such cases reported. Panels can be large. Labs like to compete with each other, and they like to say they have the largest panel. So they may include genes of uncertain significance where there's not enough data yet to say whether that gene causes hereditary cancer, even though that's not recommended by guidelines. Or it could be a newly described gene where we don't yet have surveillance guidelines. So how do labs decide what to report? This is a schematic. You start with the lab, they do the sequencing, often using next generation methods. They do bring in whatever clinical data you provided, patient with retinoblastoma, patient with a sarcoma. Custom knowledge may be the information they have from having tested other children in that region or in that type of disease. They also bring in large amounts of published information. Has this variant ever been described in the literature? Is it in any population databases? There are computer programs to predict how likely a variant is to be disease causing. And the laboratory, using guidelines first published in 2015, do a variant classification. What is on the report are variants that are considered variants of uncertain significance, likely pathogenic, or pathogenic variants. Most laboratories do not report benign or likely benign variants. Clinically, that is what you see on the report, and guidelines recommend you do surveillance for patients with likely pathogenic and pathogenic variants. But what's the meaning of likely? So it turns out that likely actually means 90% likelihood of being pathogenic. So if you see a likely pathogenic variant on a report, it means it has 90 to a 99% likelihood of being disease associated. Pathogenic is greater than that. Likely benign is 10% and benign is 1%. That means that the variant of uncertain significance has a very wide range from essentially 11 to 89% likelihood of pathogenicity. And what I try to show here with the colors are the ones that are close to 90%. There's some good data. They could be disease associated, just not enough. but there are many of them for which there's almost no data, and they're really close to the likely benign border. So if we think about them, what are variants of uncertain significance? They're often missense mutations, so changes of a single amino acid in regions of the protein where we may or may not know if there's a known function. Labs use many different methods to determine their significance. As I talked about, they look at functional studies, they look at segregation with cancer. Is it in population databases to decide whether it is more on that likely benign or pathogenic end? Particularly in adult studies, studies show that the vast majority of uncertain variants over time are eventually found to be benign. And therefore, physicians really need to avoid over-interpretation of uncertain result reports. The lack of population data for certain populations can result in a higher proportion. So for example, in the United States, we and others have shown that you're much more likely to have an uncertain variant result in African-American populations and in Asian populations. So what does that mean for you here in India? There are increasingly large sequence data sets of reference populations. However, none of these databases are globally representative. So this is from my colleague Heidi Rehm at the Broad Institute. And you can see here for you folks that all of South Asia is orange. So that, of course, is many populations, including India. And you can see here as we get larger in databases that are hosted in the United States, we start to have a reasonable proportion of individuals from South Asia, but this still represents probably 20 or 30,000 individuals out of 800,000. And you can see the Regeneron Almost Million Project has similar proportions. So again, we don't have the type of data from your part of the world that we need in order to better understand what variants are common. Similarly, as panels get bigger, the likelihood of finding a VUS result goes up. So again, this is another paper that Heidi led, looking at almost 1 million hereditary panel reports, not just cancer, all types of disease, heart disease. And you can see as the panel gets bigger, the likelihood that you have an uncertain result goes up substantially. Overall, across all of the different panels she looked at, about 30% had an uncertain result. So again, highlighting how common these are and not to make medical decisions based on them without a lot of additional information. So what are the harms of returning a VUS to patients? First, they may create patient anxiety, especially if the patient didn't think they had a genetic problem. And you may generate increased healthcare resources to manage those VUSs. This could be because of mismanagement of the clinical care, if you make a diagnosis falsely, or you can even do harm if, for example, you do prophylactic surgery, which we can certainly see in adult populations. The other thing I've noticed is that physicians really don't like variants of uncertain significance, and over time, they may decide not to do genetic testing or to do a smaller genetic test due to their negative experience with VUS results. The community is trying to do many things that I won't go through in detail. We try to use standard ways of classifying variants, as I mentioned. We feel strongly that data sharing, a lab has seen a variant and called it something, they should submit that to ClinVar, which currently has data on over 4 million submissions from 90 countries, although it's still true that the bulk of the data comes from the United States. There are other ways to share evidence, obviously publishing papers, but putting them into other databases. And then I'm one of the leaders of the ClinGen resource, where we have developed expert consensus on how to curate variants. So the clinical genome resource was developed in 2013, so we're now on our 12th year, to create a central authoritative resource for the clinical relevance of genes and variants for precision medicine. This is a paper that we published earlier this year that highlights our first 10 years and showed that we have had substantial growth in the number of expert panels. Now we have over 120 different disease areas represented. And these panels then provide guidance on how to classify variants. And the panels are often international in their makeup. So I co-chair the hereditary cancer efforts for ClinGen. And this is just a snapshot. You can see many of the genes where we have expert panels relate to pediatric cancer, P10, TP53, BHL. We have new genes coming online, tuberous sclerosis, RB1. And each of these panels present guidance for laboratories on how to classify variants. And they also submit classified variants to public databases. So this is an example from the TP53 expert panel. This is a particular missense variant that they called pathogenic. On our website, we provide all of the evidence and all of the evidence codes that were selected to make that decision. Plus, we provide the guidelines for classification. So to summarize childhood cancer genetic testing, approximately 10 to 15% of pediatric cancer patients have a monogenic cancer predisposition. Guidelines can miss these findings when germline variants are de novo, so for example, new in the child, or a rare recessive disorder where the parents are healthy. So if you don't do the testing, you may not know a genetic disease is there. The most appropriate genetic test ranges from a single gene to an exome, and most often relies on a pediatric cancer panel. Variant interpretation relies on different types of evidence, but still leaves many variants of uncertain significance. Data sharing is critical to reducing the VUS rate, and it's important to avoid overinterpretation of uncertain variants when caring for patients, as most do turn out to be benign. I'm happy to take questions during the panel discussion. Thank you.
Thank you, Dr. Sharon, for this lovely talk. Now, may I invite Dr. Rajiv Sareen for his next talk. He's going to talk to us on germline screening and surveillance for childhood cancers, current status, scope, and gaps in India. And this will be a very interesting talk because he'll be talking more about data from India. Dr. Sareen.
Can I have my slides, please? So thank you very much. I'm very happy to be in the pediatric oncology hereditary aspect because mostly we talk about HBOC, Lynch syndrome. Can I have the slides, please? Yeah. So today I'll talk about some of our results and what my own viewpoints are about these aspects. Oh, sorry. Yeah, no, it wasn't working. So we know in unlike the adult cancer, we know there are risk factors. In children, there are really no risk factors or environmental risk factors. So a large majority of pediatric cancers are because of some genetic determinants, which growth, development, cell death, but we don't know. So there's a large component of missing heritability in childhood cancer as compared to adult cancer. And I think we only know some bit of it. So you have to understand there is heritability, but we do not know about it. And there are two landmark studies which I will talk about it. They also have some lacunae which do not address this question of missing heritability. From our subcontinent, there are only few case report or case series. And this is a group of patients where there would be a maximum impact in terms of preventing second cancers and gains in quality of life and years life. So this is the North American study published some years ago. And what they found, about 1 in 12 patients had an underlying germline mutation. Only 40% had a family history. But their cohort excluded patients, many of the pediatric cancer types. And even in the types, they included leukemia and brain tumors. There was overrepresentation of hypodiploid leukemia and diffuse pontine glioma. And the approach they used was basically to look at about 565 panels. So even the panel, the genes in the panel are also biased towards some cancer types. This is the ICGC pan-cancer working group. So I work in the head neck cancer. So this is another group, mostly from Germany and all. What they look at, see, half of these cases were brain tumors. And the ALLs and AML, all they say that none of the patient with TALL or AML had a germline mutation, but their cohort size was so small, only 19 TALL and AML, and they didn't find a mutation. That was not at all surprising at all. So this is what these are the two major studies, but these are the issues based on which we cannot say that we know the landscape of childhood cancer predisposition. So that's the reality. So I'm showing this for our textbook. We have this Knutson's hypothesis. All pediatricians know it. All oncologists also know it. So over 50 years ago, the foundation of modern cancer genetics was laid by pediatric cancer research. Alfred Knutson and then Dr. Lees and Dr. Fromeni, they are the ones who essentially, much before HBOC, BRCA1, Lynch syndrome, MR genes, it was there. But then it was very soon taken over by adult cancer predisposition syndromes, HBOC, Lynch. So we have cohorts of 20,000, 50,000 for BRCA carriers and MMR. But for these childhood cancers, you have cohorts. If you take individual cancer, not even a few hundred. So that is the rarity. And even though in children, the missing heritability component is much bigger and it is much more relevant for children to ascertain that. So the set of the genes that predispose for these, I have put these three broad groups, hematolymphoid, solid tumors, and CNS. And if we include all the genes, including the long tail of rare genes, we include, the panel becomes too big. And that would affect the cost, depth, and CNV analysis. And Dr. Sharon just said, you will have more VUS only. So it's basically a trade-off between using whole exome or whole genome, short panel of say 40 to 100 genes, or larger panels of 200 to 500 genes. So I predict that maybe in 10, 15 years time, when we will know how to analyze and report data, everyone will be having whole genome, because a lot of structural variants and distal regulatory, variants, which are not picked up even by whole exome. But as of now, I think our intellectual capability to handle and analyze and report that data beyond research in the clinical context is limited. So I think with more data and collation of data and phenotype-genotype correlation, we'll do it. Why I have put this box of CNS tumors, because I think this is one set of tumors where within few years, we will have a really composite set of genes, because there are separate alliances which are working on brain tumors. But for solid tumors, pediatric solid tumors and hematolymphoid, I think it's a very mixed bag, and each tumor type I may not be able to have answers. What are the practical challenges for us? So first of all, referring for genetic counseling access. Very few hospitals in the country have cancer genetics clinic. And even those cancer genetics clinic may be catering only to the HBOC and Lynch syndrome, not to the rare pediatric disorders. Then even if the patient is referred to that, sorry, it's not moving. So the comprehensive genetic testing. So most of the labs have a mixed panel, mostly adult onset and some pediatric cancers. But as I said, there are three distinct groups. So you would find that there are very few comprehensive panels which will deal with the relevant genes for that particular group of pediatric cancer. Then cascade testing. If you found a mutation, the sibling, the parents, the family, it's not just the cost, but there are social barriers to that. Then lifelong screening for those who are found to have it. So today I find someone with a RB1 mutation or a P53 mutation. That is a challenge. And then rehab for the late effects and other syndromic, not just the cancers. Many of them may have other syndromic manifestation, tuberous sclerosis, many other, where you require lifelong screening and rehab for them. So we started as a registry. Many years ago, I set it up as a registry, then a weekly clinic, then daily. And so far we have, helped or counseled and tested more than 18,000 families, but this is predominantly adult cancers. I'm very happy in the last 10 years, more so in the last 5 years, we are seeing that the pediatric cancers are also being referred. We are also testing them and counseling them. So I would say we are in the middle of developing expertise in pediatric cancer genetics. We don't have that level of expertise as we have for adult onset cancers. So this I'm showing the data of the last 10 years for 560 pediatric cancers on whom we have completed and analyzed NGS for about 465. And if you see, even in whether you have family history or not, there's a referral bias because they've been referred to the genetics clinic because of syndromic feature or the particular tumor type or a family history, you find around 40% of cases have underlying germline mutation, and all these are high penetrance mutations. So this is the rate of, you also see we have got VUSD. I will talk about the VUSDs later. So this is a spectrum of gene variation, but before we started doing NGS in-house routinely, earlier, some of my PhD students in my lab, I run a research lab also in addition to the genomics lab. P53 was one PhD student, APC was another PhD student. So this was Muket, this was, Nikhat and Anuja. XP was one of our own research interests. CMMRD, my student who's doing postdoc in Luxembourg, CMMRD, she did Anuja. RB, because these children, they wanted prenatal testing for them. And VHL, it's a small gene, just 3 amplicons and simple MLPA, so we could do it. So after that, when we started doing germline NGS panel, then this is what we found. In addition to the 96, we added 53 more, 49 more, P53, RB1, NF1, PMS2. So NF1, I'll talk about it because earlier we used to, it's a big gene. So doing by Sanger, it really used to struggle to do that. And there are no particular hotspots also in NF1. So once we have the in-house and outside, many patients can't afford testing. And even if they can afford testing, if they have funds through charity funds, it can be done for in-house. Sending outside becomes a challenge. So that we could do in-house. So now we are doing all this in-house. PMS to MSS6 gene, I will talk about. CMMRD. So CMRD, we have one of the largest single center series of 35 families now of CMMRD. And that these two genes, especially PMS2 has a pseudo gene, so you might miss, and they have MSH2 and EBCAM, they could have a large deletion, so which the panel that we use along with CNV analysis that can pick up. So that is very important for the CMRD evaluation, it is. And of course, there's a long list of genes which could have just 1 case, 2 case, but for that 1 case who has that mutation, it is very important that we know about that germline mutation, the treatment, the follow-up, and the family members are screened according to that. Red are very few here, but we have a large series of 130, 140 red mutation carriers, but they start as adult cancer, and very rarely the presenting case is a child that happens with a particular mutation for MEN2B. So then what happens when we find a mutation? This tells about, this is our earlier cohort of 136 families with P53 mutation. Now we have more than 150. That cascade testing. So we tested first degree relatives, and as expected, close to half of them had the germline mutation, same, then second degree and third and fourth degree. So this will not happen just on its own, requires a lot of counseling. I'm very lucky, fortunate that now we have a set of 15 genetic counselors. One of them focuses on pediatrics, and they were sitting in the pediatrics, OPD. Actually, I personally feel we need 3 genetic counselors just to cater to the pediatric population between TMH and ACTRIC, but that's all we can spare. And that's not a nice place. Our genetics clinic has become so busy that these children come there, they need a dedicated place where they could be counseled. But because of this, we would hopefully would have prevented many cancers. This is another red gene germline mutation in which, although most of the cancers occur, medullary thyroid cancer, few at an older age, but the start happens in the infancy or within the first 5 years. So it is recommended they have prophylactic thyroidectomy as early before the age of 5 years. And through a lot of counseling, that's the magic of counseling, a lot of counseling and hand learning, supporting, taking them through this, we could do many prophylactic thyroidectomy. And that's the only way of preventing death from medullary thyroid cancer if you get it out before it has metastasized. Another rare condition, XP. Now I'm talking about how to handle that. Of course, it is curiosity. You find the mutation. They come first time when they come. Most of these cases, they are around 8 or 10 or 12-year-old, mostly boys, because they go out in the sun and they get sun-exposed cancers. And this is the end. You see, they are wearing prosthetic noses. It's very sad. By the age of 15, 20 years, because of recurrent cancers, multiple surgeries and excisions, most of them have lost their nose. Of course, there are a lot of eye problems also. So they require a lot of rehab. And it's a very rare condition, so there are no programs for it, but that is what really it is required. Now I'll show some cases of, like this is a case of choroid plexus carcinoma. Those who treat brain tumors know it's a rare tumor. And previous germline testing, they had found a variant, but the classification was not really there. We confirmed the variant and classified it. and we called it pathogenic, although just the same time, it's a very large and reputed lab in US called Invitae. They had called it uncertain significance. And they said, although they had found it in a case of LFS, called it uncertain significance, very rare in the healthy population, 1 in 16 million. We called it likely pathogenic, considering the rarity of this variant in population databases, in silico prediction, previous report in a suspected LFS case by Invitae, and the present case with choroid plexus carcinoma, which is a characteristic LFS tumor. We classified it as a likely pathogenic variant. And because choroid plexus carcinoma, half of them have an underlying germline mutation in this. So that variant classification becomes very important for that one patient. Based on that, the whole family and this child would have screening. Now here the mother came with bilateral breast cancer, early onset HER2 positive, and her daughter as a child had adrenocortical. Again, it was called as a VUS. So this term I'm introducing, VUS, likely deleterious, or a VUSD or a hot VUS. Going by ACMG criteria, it will be VUS. And as Dr. Sharon said, there's a lot of miscommunication. Sometimes we tend to ignore what is a VUS, and we classified it as, on reclassification, we found daughter also had the same thing. And again, adrenocortical is a rare tumor, and half of them, if not half, many of them would have germline. So we reclassified it as a likely pathogenic. So this is a VUS in TP53 gene. So it's an acute lymphoblastic leukemia. On somatic NGS, basically for hematolymphoid, what is done, one of them was at a VAF of 46.9, and we found that on the mouthwash derived also. So in ClinVar, there are 31 submissions. Most of 8 of them were germline, and 7 of them had called it a VUS, not pathogenic. But all the other amino acid changes at the same position were actually pathogenic. So we called it a VUS, so that it is under the radar and it is not missed. Intronic variants, I'll just quickly show that this one was an intronic variant, and we called it, this was a case of medulloblastoma and no syndromic features. We found in SMART-CE1 plus 3. And SMART-CE1, although functional RNA, so what we said, that if we have RNA study shows aberrant splicing, we will reclassify. And SMART-CE1 either causes Clearson meningioma. We have other cases of Coffin-Siris syndrome. This case did not have any syndromic phenotype. Then we found a case report of Coffin-Siris, which had an anaplastic astrocytoma. So many of these rare conditions really do not know how they manifest. I'll just very quickly show one, like juvenile polyposis. We found a mutation in BMPR1A. Although this variant was not reported, but because of the classic genotype-phenotype correlation, we called it pathogenic. VUS D in WT1, again, this one was really going by the ACMG criteria. It was VUS, but because there was a classic correlation, it was a Wilms tumor with nephrotic syndrome, so we have kept it under this thing. And this patient, again, did not have any syndromic features. I think this is the last slide of mine. So this is just to show that for patients, individual case, it sometimes takes us half a day just to decide what to call this variant, whether to put it in the report or not, whether to just call it VUS and everyone forgets about it and the child develops second cancer and the sibling also develops, or you put it in alert. And I think that's where we require, I'm very fortunate that our clinicians are so good. They keep telling, they refer the patient and they call me and tell me, we have sent this patient, have you seen, what did you find? And if I write something which doesn't sort of matches the phenotype, they call back again. So I think any lab which reports, you have to have, don't feel bad if the clinician tells you something, because they're seeing the patient. So with this, I would like to thank the organizers for giving me this chance. Thank you.
Thank you, Dr. Rajiv Sarin, for a lovely talk. We go on to the next presentation. This is once again an online presentation, and this will be by Dr. Sharon Plon. Impact and feasibility of surveillance program for carrier of cancer predisposition syndrome.
This is Dr. Sharon Plon. In this session, I will be talking about the impact and feasibility of surveillance programs for individuals with cancer predisposition syndromes. Let's just start with Li-Fraumeni syndrome as an example, which results from germline pathogenic variants in the TP53 gene. It's autosomal dominant inheritance of cancer susceptibility to many tumor types. The penetrance is nearly 85% for the lifetime of developing a tumor sometime in either childhood or adulthood. Cancers, however, can begin to develop in infancy and continue throughout the child's life. And 15% of individuals with Li-Fraumeni syndrome develop more than one cancer. So once they've recuperated from a first malignancy, they still need surveillance for subsequent cancers. And the most common types of cancers are shown on the right. Because there are so many different cancer types, for many years there was no surveillance. But then the group led by David Malkin at Toronto Hospital for Sick Children developed an intensive cancer surveillance protocol, which they went on to demonstrate improves cancer morbidity and mortality among those who are TP53 positive. It includes very intensive evaluations every 3 to 4 months, starting at infancy, including physical exam, imaging, and blood work, annual brain MRI, annual whole body MRI, if available at the center, abdominal ultrasounds, and in adults, we add things like breast MRI and colonoscopy. Many hospitals in the US and Canada now have specialized clinics where individuals with Li-Fraumeni syndrome undergo this screening. The excitement came from this paper, which was actually the second of 2 in a series from this group on the left, showing an improvement in survival for those individuals who underwent surveillance versus those that did not. Li-Fraumeni syndrome is not the only disorder to show this. On the right is a more recent paper from Journal of Clinical Oncology, where they showed that surveillance for constitutional mismatch repair deficiency using a similar protocol also improved survival, particularly for those who followed the entire protocol. But even those who did partial surveillance still did much better. Of course, it's important to remember that imaging is not the only types of preventive measures that may improve outcomes. So for example, total thyroidectomy is recommended in children with a pathogenic variant in Rett who have multiple endocrine neoplasia type 2 to prevent medullary thyroid cancer from developing. Colectomy is still performed in adolescents or young adults with pathogenic variants in APC and familial adenomatous polyposis to prevent future colon cancer. And even rarely in a child with WT1 disorders who develops end-stage renal disease and requires renal transplant, they recommend bilateral nephrectomies in those children. Importantly, currently, there are no effective methods of chemoprevention that have been identified and shown to prevent cancer in these groups. Because of the growing interest in genetic testing for children with cancer and for the need for surveillance, in 2016, the American Association of Cancer Research developed the Childhood Cancer Predisposition Workshops. They were co-chaired by Garrett Berdur and David Malkin. I had the honor of being on the organizing committee. And for our first event, we had 65 different pediatric oncologists, geneticists, counselors, other specialists from 11 different countries. And the goal was to develop expert opinion for surveillance for cancer predisposition syndromes in children. So the work of these workshops resulted in a large series of papers. We actually had expert-driven recommendations for tumor surveillance for more than 50 syndromes. There were 17 publications in Clinical Cancer Research in 2017, and we've updated almost all of them in 2024 and a few in 2025. I want to emphasize the articles are all open access. And therefore, please take a picture of this slide. These are just examples of some of what the papers look like. The QR code will take you there, as well as this website if the QR code doesn't work. If you Google Pediatric Oncology Series and AACR, it should take you there as well. It did actually provide an opportunity for additional collaboration across experts, because many of these recommendations still lack robust supporting data. And for newly described syndromes, the natural history is not fully understood. So there was recognition that we need some type of collaborative structure for studying children, particularly those without cancer who are at risk for cancer predisposition. One of the things that has been developed in the US and Canada is the Consortium for Childhood Cancer Predisposition. This is being funded by a foundation based in the US that funds a lot of childhood cancer research. And we're certainly hoping to expand it over time. I wanted to give a couple of examples from my colleagues. These slides are from Kim Nichols at St. Jude's Children's Research Hospital. Using those surveillance guidelines, they recently published a paper in JCO where they went back and looked at hundreds of children they had seen at St. Jude that have a cancer predisposition syndrome. Many of these are kids who had one malignancy who've now recuperated and are ready for surveillance. Included 345 that were mutation positive, and 274 were undergoing surveillance for 35 different syndromes. You can see familial adenomatous polyposis, Lee-Fraumeni, neurofibromatosis type 1, and Dicer-1 were the four most common, as well as Beckwith-Wiedemann. But there are patients with a variety of different disorders for which we provide recommendations. This is some of the data from that paper. They did over 1,700 scans or lab results that they reviewed. 53 lesions were identified, 35 of which were confirmed to be tumors in 27 patients. So that's actually about 10% of this cohort had a tumor diagnosed during surveillance. And the majority of these were malignant. 11 were benign. About a third were diagnosed at the first surveillance scan. So the first time you diagnose a child with a cancer predisposition syndrome and you do all the scans, you can find a tumor. But then they did, almost 2/3 were diagnosed within the first 2 years of scanning. And the point they make in the paper is that this seems to work. The tumors detected through surveillance were more likely to be localized than tumors diagnosed symptomatically, and 70% of them were able to be completely resected. However, the story is not all simple. Certainly, kids can still be diagnosed with tumors between surveillance visits. It's very important for parents to be aware of that. 5 of the patients were diagnosed based on clinical symptoms and findings in between surveillance visits. Some of these lesions are indeterminate. 10 patients, it was unclear whether they were malignant or benign. And then sometimes you can have a biochemical positive, for example, 2 patients with Beckwith-Wiedemann and AFP, but you can't find a tumor on imaging and you just have to follow the patient. I wanted to describe what we do at my hospital. So Surya Rednam, a pediatric oncologist, developed the Childhood Cancer Prevention and Screening Clinic at Texas Children's Hospital. He works with a nurse practitioner, a nurse coordinator that helps follow the families and make sure they keep up with their surveillance, often provides psychology input, given the anxiety that can occur. And most of the children that Dr. Rednam sees are screened either every 3 months, things like Beckwith-Wiedemann, or annually, things like Gorlin syndrome. The clinic intersects with a variety of other specialty clinics. So my clinic is where we often make the diagnosis and we refer to Dr. Rednam. We have specialty NF and tuberous sclerosis clinics. The thyroid center sees a number of patients at risk for these disorders. And of course, it's important to work with the child's pediatrician who you're sharing the care of the patient with. Again, Dr. Rednam's grid is similar to what you saw at St. Jude. There are a number of patients at risk for Wilms tumor. This quartile are patients with neurocutaneous disorders, NF1, NF2. Whole body refers to things like Lee-Fraumeni syndrome, von Hippel-Lindau syndrome, where you can have tumors elsewhere, anywhere in the body. And then there are a significant number of patients at risk for endocrine disorders and GI disorders. One of the things that they've learned is that adhering to the recommended frequency of surveillance evaluations is important. This is an example of a boy who was diagnosed with Beckwith-Wiedemann as a neonate based on physical features, estimated cancer risk of about 7.5%, Wilms tumor more likely than hepatoblastoma. The family was adherent with guidelines for doing scans every 3 months to age 7. And at 3 years of age, his ultrasounds showed a small right renal lesion. The prior ultrasound 3 months before was normal, even upon re-review. And the CT scan showed multiple lesions, and the one that's circled was confirmed to be a Wilms tumor. He was able to have treatment that spared renal function because the tumor was picked up in a smaller size. Of course, screening is not without issues, and it certainly may create a psychosocial burden for patients and families. Anticipating the screening, oh my God, my MRIs are coming up, can provoke anxiety. Certainly waiting for the results can definitely induce anxiety. And I know Dr. Rednam tries to time the imaging so that he sees the patient that afternoon or the next day. Having serial medical visits and screening evaluations continuing indefinitely, every 3 months until age 7, that's 28 visits, is definitely tough. Can be stressful, it can be disruptive to families, parents can lose wages, kids can be absent from school. And some patients may need to follow not just with Dr. Rednam, but with multiple other subspecialists. For example, in FAP, they see the gastroenterologist and Dr. Rednam. And then an issue that has come up frequently is if there are other members of the family with the same syndrome, one of them may have cancer and be under treatment, and that can interfere with surveillance for the healthier sibling. So to just conclude, increasing data suggests that surveillance can improve survival and decrease intensity of needed cancer treatment. Centralized clinics with staff familiar with guidelines are needed to ensure that up-to-date care is provided. There are still many challenges implementing surveillance, particularly for disorders like Li-Fraumeni syndrome that have highly complex recommendations. Again, we've recently updated our guidelines. They're available here or at the QR code. I do just want to thank my many colleagues who provided slides, Chris Porter from Emory University and Children's Hospital Atlanta, who helps to lead the St. Baldrick's Consortium, my colleague at Texas Children's and Baylor, Surya Rednam, and my colleague Kim Nichols at St. Jude's Children's Research Hospital. Happy to take questions at the panel. Thank you.
Thank you, Dr. Sharon. And with this, we'll move on to the panel discussion, implementation of clinical CPS service program. Dr. Badira, kindly take over to moderate the session. I think you can invite the panelists and we will sit down.
Sure. Yeah. Thanks, Dr. Ratna Sharma and Dr. Mukesh Desai for chairing the session. We would like to invite the panel onto the stage. I would first of all like to thank Dr. Sharon Plon. She has been live with us since the beginning of this session, and so it's morning to all of us here. It's late in the evening at Houston, Texas, and thank you for those 2 wonderful talks. She has been kind enough to provide us with the recordings so that there be no glitch during the live session. And it has been wonderful, the whole session. I would like to thank all the speakers for the same, and we'll now proceed with the panel discussion. So I have to say there would be some overlap in the questions which are being addressed in the panel discussion, but this is mainly to drive home the key points with respect to the implementation of a cancer predisposition syndrome screening program, and a perspective from both the high income and the LMICs, including India. So I would like to invite the panel onto the stage. First of all, we have Dr. Sharon joining live there. Dr. Sharon.
Can you hear me?
Yes, we can. Yes.
Okay, great. I just wanted to make sure it worked. I would say that the session was wonderful. I'm very sorry to not be there. And I really appreciated hearing the different talks from your colleagues.
Thank you, Dr. Sharon. So I would like to introduce Dr. Sharon Plon again. She's Professor Molecular and Human Genetics, Director of the Cancer Genetics Clinical and Research Program at Baylor College of Medicine, Texas Children's Hospital, Houston, Texas. Welcome you to the panel.
Thank you.
I would also like to invite Dr. Rajiv Sarin. So he just gave us a talk on the current status in India. He's a radiation oncologist. He's an officer in charge of the Cancer Genetics Clinic here at Tata Memorial Hospital with several publications and research to his, in his name. I would like to invite Dr. Deepak Bansal. Dr. Deepak Bansal is a professor, pediatric hemato-oncologist at PGIM Chandigarh. I invite Dr. Parag Tamankar. He's a senior consultant geneticist working at the Center for Medical Genetics in Mulund, and he's also affiliated to the SN Gene Lab at Surat. Dr. Anand Kesi. Anand Kesi is a consultant pediatric hemato-oncologist working at Shangara Hospital, Bangalore. Very welcome to the panelists. I think we'll proceed with the, can you change this? Okay. Okay, I think I'll start off with Dr. Rajiv Sarin, sir. What do you think are the necessary components in the implementation of a clinical CPS services program?
So everyone talks about counseling and testing. I will start with clinicians. Clinicians who are aware, who appreciate the value of evaluating this. Without that, nothing else would happen. You may have wonderful genetic testing lab, a lot of genetic counselors. So I think first and foremost, clinicians, the oncologists who see these patients, who treat these patients, and not just who see and treat them, those who look at the slides, the pathologists, those who look at the scans. So I think once they are aware and they start, and they will be the driving force behind getting a good organized services, then obviously it requires a cancer genetics clinic. It is unfortunately many centers in the country, when they have a patient, all they can do is if they suspect, they can send the sample to a lab in one of the labs and whatever they understand and get a report, and then they struggle to understand and interpret and implement what are the findings, clinical findings which are relevant based on that report. So you should have a genetics clinic. Genetics clinic, many centers in our countries have cancer genetics clinic, but primarily they focus on pediatric and reproductive. So someone in that genetics clinic who also takes special interest in the wide variety of childhood cancer predisposition syndrome, genetic counseling, then obviously the relevant genetic testing, as some of the speakers, including my slides, showed that the panels could be very wide. So relevant genetic testing, interpretation, and then risk management based on that. These are the essential components of that.
Thanks, Dr. Sarin. So I think that's where you need to have a dedicated cancer genetics clinic, and that too a pediatric cancer genetics clinic. And because the link between the patient and all of this is a pediatric oncologist or a pediatrician. So they too should be well-versed or introduced to this idea of germline genetic testing. So I think we'll move on to the next. So I would also like to hear a perspective from Dr. Sharon. So what is the structure or framework of these services in USA? And do you have a detailed algorithm on how this works at different points of care?
Yeah, so I agree that the prior answer is very similar. In the United States, the big children's cancer centers have cancer genetics clinics. That in many other hospitals, the geneticists do work on other pediatric disorders, as you just heard. But we have tried through the Children's Oncology Group to provide support across the United States. So the testing is now done centrally in one lab and sent out to all the hospitals, so they don't all have to have their own technology. And that has facilitated more testing being done of children with tumors, not relying on each individual lab. In terms of the algorithm, I think you heard in the first talk the description of the MyPOG algorithm. Many centers here use it. I will say about a third to a half of the children are positive by the MyPOG, so you still wind up doing a lot of testing. If you have a system where you can afford the test, I think it is more straightforward to test all the children with solid tumors, perhaps with a dedicated panel, so you don't miss ones. But the only thing I would say about an algorithm was what I was saying about that QR code. We have tried to publish all the guidelines so that at least doctors in all the different centers know what the experts recommend for surveillance. And that has been quite successful. That pediatric oncology series website, where the articles are all open access, has had a very large number of hits.
Yeah, thanks, Dr. Sharon. So I think we heard the word there, the algorithm. So algorithm is very important. And as she rightly pointed out, there are algorithms available, but maybe they may not be globally representative. If you look at many of the databases, the data from South Asia, especially from India, is not that much. And I think Dr. Rajiv Sarin is, we are embarking on a project where we are going to define the spectrum, the prevalence and the spectrum in the Indian population with all the geo-ethnic variations, which is very important, I guess. And also to come to an algorithm which is applicable to our population, because we know we need to find that balance of cost and benefit and how it is going to help our population. So
yes, I would agree. And I think having a database for your population is going to be critical.
Yeah. So I think the hub and spoke model, as Dr. Rajiv Sarin said, works well. We need to find nodal centers which can actually provide the expertise. Dr. Sharon also pointed out that we need to have centralized facilities with expert care or expert knowledge in this area, so as to put it best in the implementation program. And Infogus, one of the corporates, it's our Indian Pediatric Hemato-Oncology Cooperative Group, and we would be able to actually pinpoint and find these nodal centers and help expand the horizons of this program across India. Yeah, thanks. So next one, I think I would like to ask Dr. Parag for the Indian childhood cancer cohort, because this is what we said, we don't have much prevalence data. But what do you think among the different types of testings which are currently available? Taking into consideration also the pediatric cancer burden is quite high. What would you recommend across all the different types? I mean, which should be sustainable on a long term, not just you implement it at a cross-sectional point, but which is sustainable for a long time? What do you think would suit best?
Yeah, thank you for the question. So basically, the technologies have improved a lot. 10 years back, the scenario is quite different. The cost of sequencing is going down. From short read sequencing, you're progressing to long read sequencing. So depending upon the clinical scenarios, like for retinoblastoma, we will be interested only in the RB1 gene, or Wilms tumor or a specific gene. So for that, we can do NGS of that gene itself. If it's a large gene, an NGS. If it's a small gene like VHL, we can even do Sanger. But for most labs, actually, they're offering panels. It may not be sustainable to do NGS of single genes because you don't have enough samples. So of course, if you have an in-house lab, then you can tailor-made these panels for your own patients. On research setting, of course, the more the data, the better, because if you are primarily designed to identify new genes in those who don't have any mutations. So for research settings, a whole exome or a whole genome may be benefited. But of course, when we have negative results in the primary RB1 or our assays for the particular gene, we can go on to the larger panels.
Yeah. Thanks, Dr. Parag. I think that was also summarized in Dr. Sharon in one slide, how to choose your test. So do you think, is there a, I mean, cost difference or in terms of implementation, if you are going to choose between this?
Yes, there's a huge cost difference. So, but still the cost has come down drastically. And also, I'd like to add, it's not just about sequencing. You also have to have additional panels like MLPA, for example, which may be significant for genes like RB1 or uh, even the tuberous sclerosis, TS1, TS2. You can have 10%, 20% cases where we miss on an NGS, but we picked up on others. So it's not just sequencing. You also have to depend on other additional tests.
Like a combination of panels.
Yes, yes.
Yeah, thanks. Yeah, so I think I'll take a perspective from the Indian consultants. So, Dr. Deepak, what do you think, or who do you think are the stakeholders if you want to have a successful implementation of this cancer predisposition programs, the screening and sustenance?
So, I mean, theoretically, one can easily answer is to say that all these people need to be there in the program, but practically, we hardly have anybody. So I think the pediatrician will have to be the most important person. One will have to just take a printout or have a surveillance strategy, you know, and then give it out to the patient, and hopefully he goes to his pediatrician. We communicate with the pediatrician, and then he can do the surveillance. But before that, like as was said, one needs to have cancer geneticist, which I think for several years to come is not going to be that easy in most of the centers. So by sitting here, I was actually wondering that, I mean, how is it really going to work out? I mean, whether one needs to have a central lab, as was being told that in the US they have a central lab. So if that could work in the US, then why not maybe 5 central labs in India? And then one needs to have the molecular pathologist who will do the test, the pediatric oncologist, and the pediatrician. So I mean, yeah, these are the stakeholders which would be involved.
Dr. Sarin, do you want to add to?
So stakeholder, I said the most important are those who are with the children, the clinicians, the nurses, the pathologists, radiologists. They are the first, and they have to drive it. You can't just, so that they are the ones, and that's why I'm very happy that I'm addressing people who actually diagnose and treat children. And then, of course, you have to have genetics clinic, genetic counselors, pediatric cancer genetic counselor. It's a highly specialized area. It's a highly specialized area, subspecialization, but at least large centers should have it. Not every small centers could have it. The panels. I mean, ideally one could say, okay, let us do whole exome. Everything will be covered. As Parag mentioned, whole exome sequencing may report a CNV, but may easily miss a CNV. Even targeted panels, unless until your panel has been validated, multi-gene NGS panel, it can easily miss a CNV, or it may not give a confident call for a CNV. They may say CNV failed. So copy number variant, which are stretches of exons or introns, which are either duplicated or deleted. We used to call it large genomic rearrangements. And in our own data, for genes like RB, P53, NF, PMS2, and several other genes, about anywhere from 5 to 20% of all variants are these copy number variants, APC, etc. So that is very important. So know that the panel that you use, is it detecting the CNVs or not? If you have and then again, it goes back to, I'm very happy that I have a very good clinicians. So they are correlating. They say, we strongly suspect this syndrome and your report is negative. Because MLPA theory is one thing. You can't be doing MLPA for all the genes for every case. So if your panel is not robust enough to call CNVs, then for those cases, MLPA, because that is done for one gene at a time. So now we have a digital MLPA. So we in our lab also, so 40, 50 genes are there in the digital MLPA. You could run that. But syndromic differential diagnosis has to be first made, even for variant interpretation. We're getting a VUS. I showed in my example, a lot of cases were, we called it VUS likely deleterious. That could happen only because we had a very, in the beginning, we had a syndromic differential diagnosis, which was based on the presentation, age, histological features. So that is very important. So those part. Today, I really feel that in 10 years' time, we'll be doing whole genome sequencing, because a large component of missing heritability, which we are missing on targeted panel, even with whole this thing. As of now, we don't have the wherewithal to interpret and report whole genome sequencing for all cases. Maybe in some we will find that. So that is required. The one recent paper has shown that there's distal regulatory failure, not just in the intron exon boundary or in the 5' or 3' UTR, but much away from that in the intergenic region. So it's a very exciting field as well as very challenging field.
Yes, we can see that because you are not able to put a full stop at the end of your sentence. You can keep on talk about that. Yeah.
Like I'm tempted to ask Dr. Cyril, what do you advise for the multiple pediatric oncologists in number of small centers all over the country? Suppose they suspect a cancer predisposition syndrome, they want to send a sample. Where should they send? And how do they do the counseling? How do they plan the family screening?
So, they currently they send to the private labs, but I really feel so bad for them. They are just sent with one report, medulloblastoma or ALL. Like if I was getting such just one liner, this thing before testing, I would not report most of those cases. Unless until I have so much associated information, I would dread to, report that variant. But our private labs, unfortunately, don't have that luxury. You can't be going back and forth asking the clinician. So I think it is the clinician's duty to send as much information. You do not know what finding will be there. Sometimes even consanguinity is not mentioned. So based on that, when the person who is interpreting the variant and putting in the report, they have that much confidence. So testing as of now, it is done mostly in private labs. The clinicians have to send the relevant information as much. Today, you may not think this is relevant information. While reporting, Parag will tell, how that important it is. So many private labs, before reporting, they ask the medical geneticists and then they do phenotyping. They heavily rely on that. In cancer, that does not really happen. That is very important. Our own lab, we get samples from all over the country, but not as many. We'll be happy to do that. And of course, if you send samples to us, we will not report it unless until you give us all the relevant information. But a private lab cannot do that, then you will stop sending patients to them. Yeah.
So I guess there is a long way to go, and there is a lot of sensitizations needed. We will be taking questions at the end. Is that okay? Okay. So I think there is a lot of sensitization needed among the practicing clinicians, starting at pediatricians, because the primary point of contact for the child is a pediatrician, and going up along all strata of medical expertise. So, and what about government? I mean, to increase the accessibility, affordability, do you think incorporation of these into government schemes? I mean, you would say
I mean, it should be, but most of the diagnostic tests, ultimately, it's a diagnostic test. So they are not as of now included, but they should be there. So how it will happen, I don't know.
and surveillance programs, because that's not an easy way to go,
Oh,
because it
that's
costs a lot of
completely
money.
different.
If you see a Toronto protocol, it's such an intensive surveillance protocol.
Insurance, I don't know whether you have slide on that on insurance.
No, no.
So if any time
that
I
is
do
it.
that, before formally report and put the system, I tell that, have you taken an insurance for your child? Take family insurance. So these are open-ended questions. We don't have an answer to.
Yes, and that too before the diagnosis of cancer. Yeah, Anand.
Yeah, we have had one issue with insurance where we had diagnosed a retinoblastoma gene. It was in 18 where I started my career, and the insurance company refused to give the support for the further chemotherapy. So we really had a lot of issue, and we had to take it up to the health minister, but we couldn't to find it. Finally, but IRDI in 2000, I think 20 or 21, they passed a law that all genetic diseases should be covered under insurance as a mandate, and now we are fine.
Is the IRDA?
Yes. We got the official approval by the IRDI. So
Yeah.
all the genetics, like Down syndrome, I had to send back 1 or 2 Down syndrome patients with AML because they didn't have finances to get the treatment even in the trust hospital, and the insurance refused to pay for it because it was already a known case of Down syndrome, and genetics diseases were previously in some of the insurance were not covered.
Yeah, that's
But just one thing, I don't think it's universally implemented.
Yeah.
In many cases, they
No,
refuse us.
still it is happening that some of them are refused, but IRDI have a clear mandate now that if we take up it to IRDI, I think they will allow it.
I think so. There is still a lot of struggle in the areas of insurance, and especially in the setting of cancer and genetic diseases. And maybe all the heading programs could take up this and come up with a policy or a statement with regard to this. I think we'll move on to, yes, we know barriers. When we talk about any services for that matter, there are issues to adherence, compliance, and there are barriers to all of this. I would like to get a perspective from all of you. I mean, Sharon, Dr. Sareen, and Dr. Parag, what are the barriers you face in genetic services at different levels, whether it be the patient level, family level, or the provider level? Dr.
So one of most important is lack of awareness, whether it could be genetic or not. So because it considered to be rare, but it's not that rare. Then, of course, the cost, but the cost has come down. Previously, it was very expensive. Then discrimination is one important thing because it's genetic. Somebody might be blamed if it's if from either of the parents, especially if it is come from the mother's side, and there could be family break and all those issues might be there. And then, of course.
No, I think he has said everything. Just one thing I would say in terms of cascade testing. You have a separate thing on cascade?
No, you can go ahead.
So, many times we have many, people in our country who haven't had 10, 12 years of formal education. And I think sometimes we think that someone who isn't really very well educated will not be able to understand. I think that's where our genetic counselors do the trick.
Yes.
This is basic common sense. People intuitively understand inheritance. Except autosomal recessive, it takes, you need to explain to them. Dominant inheritance, all human beings, if they have an IQ of above 70, they will understand inheritance. And once they understand inheritance and they know that some things are there, you can explain to them and the cancer risk. And these were talking of people who have seen cancer in the family. So you don't have to explain to them what cancer is, what syndromic manifestations are there. And to take it even irrespective of their educational background or social background, they will understand the importance of cascade testing. Now, even after that, sometimes some people don't want to do that. Then that's the counseling trick. You have to figure out what is driving them to say no. Sometimes it is a cause. I think once you get a thing, then they will ask for test, how much it costs. So I think understanding what is in the mind and then working with them to take care of those things, that really works the trick. We have very, very low rate of families refusing for cascade testing. And that's the reason, because we have a lot of pre-test counseling, sometimes more than one session, and of course, many sessions of post-test counseling.
Yeah, so navigating through, yes, Dr. Sharon, from a US perspective, do you want to add to this?
Yeah, just a couple of things. In terms of cascade testing, I agree with what was just said. There was a big study out of the Mayo Clinic with adults that only 20% of relatives, even when the cascade testing was free, had it. What we have found in the pediatric cancer setting is parents are very good about the siblings being tested. They're not as good about getting tested themselves. In the United States, the children are more likely to have health insurance than the parents, especially in Texas. But parents are very good about having their other children tested if you find something. I think in terms of barriers, a lot of physicians are afraid of genetics. It's complicated. They think we're going to scare the family, and they don't make the referrals. So I think sort of breaking down barriers, even with our colleagues, are important.
Yeah, I think breaking down barriers across all strata, you're right, breaking down barriers across colleagues. So as already Dr. Sharon also pointed out, you have negative tests also, then you stop testing further patients. So there needs to be a lot of, there is a knowledge gap also. So that could bring about a difference in the practices in the future. I hope when you go back from here at the end of this, you're more sensitized to test who and send where for all these services. Thank you, Dr. Sharon. So, yes. So again, we can come to the same point because we know there is a shortage of genetic counselors, more so pediatric genetic counselors specifically trained for this purpose. So again, I think we had answered this in a bit, but Anand, what do you think with respect to self-efficacy of the treating pediatric oncologists? Where do we stand?
Yeah, except for a few major centers where there is a good dedicated team like Tata Hospital where everything is available. Many of the patients in India are currently treated under by private and setups where small setups where there is only one pediatric oncologist. The place where I joined, although they were treating more than 10,000 patients a year, adult patients, I was the first one to join as a pediatric oncologist, and it found it so difficult to even starting from the initiation of the treatment. I had to put the cannula myself and later start the treatment in the initial days. So it requires a lot of time to make a good team and start the treatment for a challenging for a pediatric oncologist. Later, coming to genetics is actually it's a distant dream. Even in our center currently, the genetic counseling, everything is done by me and one of my colleagues at ACD clinic. So it requires a lot of things, probably inclusion of all these genetic counseling and things as a part of career or part of teaching for all the students. Probably that would give a long way. And also, yeah, if anybody would want to.
Dr. Deepak,
I mean, I was just thinking that a lot of pediatric hemo colleagues are now getting passed out. And, you know, one could easily branch out into various specialties of pediatric hemo. The problem is who's going to give the employment? And the corporate sector may not be willing to put in money wherein, you know, the returns are not that attractive. So I think it's going to continue to be a little challenging.
Yeah. Yes, challenging, of course it is, but then we have to find a way through it and navigate through it. And one of the, yes.
So in adult genetics, there's something known as mainstreaming of genetic testing, and that has happened because, especially in ovarian cancer, now the guidelines suggest that every patient with ovarian cancer, especially the serous ovarian cancer, which forms 80% of all, they should have germline testing. And traditional route was they would be sent to genetics clinic, pre-test counseling, then genetic testing, then post-test counseling. And genetic clinic just couldn't cope. So now the practicing oncologists are being trained in mainstreaming just basic questions, and they will do that. And if a mutation is found or a VUS is found, then they send to genetics clinic. But they are dealing with just one disease, one set of genes, BRCA1, BRCA2. Pediatric cancer genetics is far more complex, you know, much more complex, even those who practice pediatric cancer genetics, but at least the common syndrome, like RB, knowing that this is a case of RB, you have to do genetic testing. If a mutation is found, in addition, looking at both the eyes and brain for pineoblastoma, risk of sarcoma and screening up to the age of 30. So that's this simple syndrome where the clear genotype-phenotype correlation, RB, VHL, RED, at least the low-hanging fruits should be dealt with by every, you know, pediatric oncologist or pediatrician, I would say that. But for the more complex, unfortunately, mainstreaming is not really possible because the number of syndromes, number of, you know, genes, genotype-phenotype correlation being sort of little fuzzy, that will not happen.
So maybe into the pediatric oncology curriculum or the pediatric curriculum as such,
Yeah.
you can have a short one chapter and a small
anyone
internship.
who comes to spend a week or 2 weeks with us,
that would be the enough sensitization to start it up.
Yeah.
So I mean, long term is always a long term plan, but short term, yes, we can have some of these gains by putting some of these into practice. Yes. Well, we have a long way to go, but yes, not with respect to the panel. We are nearing the completion of this panel. So I would again want to ask, again, this is one of the things that we come across. If you do a sequencing, you can possibly find a target and an actionable mutation there. Now, how do you, if you have that, especially in rare diseases or somewhere where it is a refractory disease or a recurrent disease, so this is one situation. There is a practice of doing NGS right and left. But when you see it, how are you going to complement the therapeutic with the diagnostic part?
Yeah. So very unfortunate what we in India is facing is currently even some of the first line agents, for example, treating a neuroblastoma. I have treated more than 30 neuroblastomas in the last 8 years, but I have not been able to give even the first line treatment for one patient because dinutuximab is not available in India and none of my patients afford it. Similarly with blinatumab for all relapsed ALL patients, similar with brentuximab for relapsed Hodgkin lymphoma patients. So it's a very difficult situation, especially in the private where the funds is a very big challenge. So what we can do is probably there are some centers in India where there are some compassionate access available for some of the drugs. So collaborating with them and probably taking the help from that hospital, for example, blinatumab from Tata Hospital, CAR-T-cell from Tata Hospital. Probably these are some things. Probably the bigger centers, they should probably try to include more centers to.
Yes, Anand wants all patients referred to the CAR-T-cell center.
So that is one thing probably would help. And also pharma companies, if at all, if they could provide some help for centers, probably that would go a long way.
Dr. Sharon, how do you integrate it over there? You get some diagnostic or a actionable target there, and how do you put it across to the?
Yeah, so first of all, I have great sympathy for the difficulty to get any of these targeted agents. I'm sure that's very frustrating. the panel that our hospital developed was designed for therapeutics. And then we worked with them to add the most common cancer predisposition genes so they could use the same panel for the tumor or for the blood analysis. And that has worked pretty well. Most of the targeted agents are not based on the germline testing, they're based on the tumor. Where I get involved is, for example, a child having a bone marrow transplant and they're worried that they have a rare recessive DNA damage disorder. And then that is more difficult. And often people forget that things like sister chromatid exchange or for Fanconi anemia, DEP, diapoxybutane crosslinks are probably a better test than a DNA test. But I would say if you're just talking about DNA testing, the main way we've tried to integrate it is to do paired tumor normal testing using the same platform. So the lab doesn't have to run two different platforms, one for the tumor and one for the blood.
Yeah, thanks, Dr. Sharon. I mean, Dr. Deepak, do you want to add anything? So I think that's our next question also. There was another question regarding that. Anyway, is there any thing that comes out of your mind how you can increase the adherence and compliance to the surveillance programs?
I think the trick is detailed genetic counseling, more than one session if required. And unfortunately, now we do more and more of video or telegenetic counseling. I don't think that is as effective, but something is better than nothing instead of not having any post-test counseling, some form of counseling. And I think, sitting face to face, making them understand, explaining to them, they don't understand what these intensive surveillance means. So explain to them, facilitating them, that is very important. Actually, what surprises me is that how some people continue with such intensive surveillance year after year after year. But these are all the ones who have seen their children die, suffer and die from cancer and other relatives. So I think once anyone has experienced even one cancer death or more than one cancer death with similar this thing, and they explain, this child is at the same risk, they are the ones who adhere and who really surprises me how they commit. But of course, many people just fall through. So when they come back, you have to reinforce, but all that can happen only through a genetics clinic. Average practicing pediatric oncologist will not be able to do that. They might do just for one odd case, but not in a systematic way. I think that's the real value of one is genetics clinic, other is the late effect clinic or the other clinic survivorship, groups. So they can also help in this. But many of these are previvors, they're not survivors. A sibling hasn't developed cancer, but at risk of developing cancer.
That's true.
So having a right timeline for counseling for genetics is very, very important because in my early part of my career, I had counseled a family who has come with ACC. I told them about the genetic risk and they never came back. So I understood later that it's very important to even provide the right treatment first and later there should be a good timeline. So currently what I practice is I will finish the treatment and at the first visit in their completion clinic or after completion of clinic, so that's the time when we introduce the sensitize them about genetic links and we have a 3 sessions of counseling and later we offer them the counseling. So our compliance risk, especially for testing and the counseling has increased now compared to the prior. So
yeah, that's a very important point, I guess. You can't straight away jump and say you're going to have multiple cancers. Your family is going to have cancers. I mean, in whatever way you're going to counsel them before, because that's not as soon as diagnosis. It would take a bit of rapport to get them into this and advise them and provide them pre-test counseling also.
Additional way could be even have support groups.
Yes,
because when they see the other families, they know they're not alone. And it's a journey which they go through together. So they may not like everything from the doctor's mouth. They want to hear it from their own people.
Yeah, I think there is a roadmap there. We have to define, with respect to India, how we go about this over a long term. Yeah.
For all these, there are groups on Facebook, on Instagram, on Twitter. So they end up, what I tell them when you go there, you will see that this is a horrible syndrome, people. But what I tell them that, like FAP, MSH6, I tell them, People who don't have problems, they will not write anything. Only the ones you would have going through serious problems, they are the ones who are more likely to post and something. So you will get a biased view. So don't get scared. You listen everything over a period of 1 year or 2 years, you will understand what is the nature of this. But many of those, like the FAP group, the kind of things they discuss on their group is something as a doctor, you would have never thought this is important for their quality of life or the day-to-day life. So there's also helps. And but
That's
with the rider.
Yeah, that's true. A lot of concerns they will have. Yes, I think we'll take questions for the panel from the audience. Yeah, Dr. Vikramjit and Dr. Yes.
It's not so much a question as maybe a brief comment. So first, I really appreciate this talk. I think it's been very helpful to all of us in many different ways. I strongly support Dr. Deepak's comments about scalability. This is a very Tata-centric talk, that this can work in a few isolated, well-supported genetic clinics, but to try and roll it out nationally is a huge challenge. Most people are struggling to even treat the patients, pay for the care, get their patients diagnostic delay for patients who are not part of CPS, is a huge problem for many centers. We still get diseases, patients presenting 6 months or 8 months or 12 months after their first symptoms. So trying to roll this out in a population-based way, I'm not saying this should not be done at more centers. I'm simply saying that you should pick and choose where to roll it out.
Well taken, well taken. I think these are problems which are very centric, especially to LMICs.
And I really want to comment, Dr. Anand, for how much he's managing to do. I worked in Varanasi. I know how busy these centers are and how difficult it is to take care of patients. Thank you.
Yes. I think these are some things which should go parallelly. I mean, we have to start somewhere, and starting parallelly and providing it and expanding it over the time, because we have various now interested groups also which will help forward this. So we start somewhere, and that is what the whole idea of this is about. And the project Dr. Rajiv Sarin and we have a contemplator is also in that
So
direction.
ICMR is in all likelihood give us a center for advanced research, 9 centers across the country. They will not just be sending samples, but a cancer genetics clinic with a genetic counselor. So I think that's will be the hub and spoke model. In the next 5 years, we would have many more pediatric cancer genetics clinic in all parts of the country.
And that'll be great. That'll give people a place, because sending it out into the private sector is really a recipe for disaster, because you can send out samples, but the reports which come back are very, very vague and
True.
not always helpful to the patients and families.
Yes.
Or the physicians.
So I echo what Vic and Deepak had mentioned about the challenges, but I also I'm happy to note the comment which Dr. Sareen just made. And as you know, there are now, so basically it's a health system problem. It's not a medical problem, it's a health system problem. How do you deliver a service which is so far not being delivered, and how do you build capacity both in terms of people, training, finances, and education? And so now within the country, there are examples of people coming together. National Cancer Grid is one example. The INFOG is another example. The ICMR is suggesting to, building capacity, another example. And so we start from single hospital to smaller local projects and then scale it up to bigger projects. And I think it's doable. The NGO community is strongly behind such efforts as well. So that's my overall comment. My question or my other comment was on the barriers. There was a slide on the barriers. And as a clinician, as a single pediatric oncologist in a private hospital, one of the challenges you face is that, and I'm sure it applies to others as well, is that you dial up the number of a lab, or you call your own laboratory person and say, well, I want to test this. Which is the test I should order? And you get a list of things and you don't know which is the right test. So A, you don't know what test to do, and B, once the report comes back, you don't know whether you ordered the right test. And so you're left with a negative report, and you're not sure how much confidence you have in that to answer your question, and you don't have the luxury of having a dialogue with the cancer geneticist over there. And so I think things like these, which can be solved by guidelines and by consensus, which tell you, okay, if you suspect a hereditary brain tumor panel or hereditary brain tumor disease, then these are the genes, or this is the panel, or this is what you could do. Because otherwise, in a clinic, you don't have the time to figure it out which one to, which way to send it and which is the right one. And some guidance over there would be very helpful. Thank you.
So there are guidelines available from the working groups with respect to various tumors, the implementation of surveillance programs. But then again, these are guidelines based upon the studies which are from the West. So it is for the current scenario, it is still applicable to the Indian population. But as I said, we really need to find out what is there in our population, because we have a lot of other things. You have a lot of consanguinity, a lot of ethnicity, variation. So something that we should come about and which can be later modified.
Yeah, what I meant was that although the guidelines are there in a journal, right, at the point of care, when the laboratory sends you its leaflet and says, this panel is what you should be doing, and you want to make sure that that panel covers what has been recommended, and how do you identify the right genes?
Sure.
Hello.
Yeah, Dr. Mukesh.
I want to ask one question, that these cancer predisposition genetic syndromes, would they come in the rare disease initiative of Government of India? Because if they come into the rare disease initiative, Government of India is giving to the tune of 50 lakh rupees for this patient. So does it come in the rare disease initiative? It does. Then, if you have a nodal, because KM is a nodal center for that rare disease initiative. And this patient, if they enroll into that, you can get up to 50 lakh rupees for not only diagnostic workup, but treatment also.
And surveillance, yes. Yeah, Dr. Kalashi.
My comment is on how to integrate when you have a suspicion or proven case, till you have the actual guidelines. So I feel at a pediatric oncologist perspective, you should have a strong suspicion. Even you don't have syndromic presentation. If the patient is having chemohypersensitivity, atypical manifestation, you should have a strong suspicion. Even if you don't have a history, you should go back and ask the history again, and to pinpoint your histories and signs, and then you check. So with my experience, every 1 in 3 patient, we are actually getting the reports, actual reports. And one more point to add is how to add a targeted and other agent. We should actually modify the existing therapy wherever needed. We should not give the same therapy for the set patient. And we should reduce the therapy to the maximum tolerable level with which we should be able to achieve the expected outcome without a treatment-related mortality. At least till actual guidelines, all these things are happening, these should be followed.
My question is to Dr. Sharon, actually. So we have a lot of variant of uncertain significance in our population because we have a paucity of reference database. I wanted to know, in your part of the world, how easy or how difficult is it for you to do a functional study for a VUS, especially in a case where the genotype and phenotype is matching, and how aggressive are you in terms of doing a functional study for such a variant? Because in our country, we are still in an infantile or maybe a fetal stage, whether we are, concerned classification of such variants.
Yeah, thank you for the question. So I think there is sort of hope, excuse me, hope for all of us. There are now these massively parallel functional studies that are being done that have the advantage that the labs will do thousands of mutations at a time and put that data into public databases. So whether it's a rare variant from India or one of my patients, that data may be available. It's actually very hard to get a lab to do a functional assay for a patient. The data already has to be there, either because a research lab was interested in that mutation, or now with these very large scale functional assays. So there was a paper that I played a tiny role in, but colleagues really looked at doing these large scale functional assays will probably help us both in low and middle income countries in the United States, even more than having larger population databases, because they can test thousands of mutations at a time. I would say it is definitely a problem that you don't have good population databases for, healthy general population. And as you all know, the history of your country is genetically so complex. So, the more that data can become available to labs in India, the better off you will all be. But hopefully these large scale functional assays may at least help tell you which of these suspicious VUSs are really pathogenic. I hope that answered your question.
I think it does, but are you doing specific functional studies for certain variants? I mean, because we need to offer prenatal diagnosis, the patient puts.
Well, that's what I'm saying. We do it pretty rarely because the labs are required to generate a report. They can't wait for a research lab to say, oh, I'm going to go test this and let you know. So for example, we recently published such a functional assay. I'm not sure the lab that did the original test report has yet to update the original test report. So, the pathologists want to get a sample, they want to run a test, they want to give a result. They don't want to wait for a research lab to go do an experiment.
So I think Aaron, you are referring to the large scale, using CRISPR-Cas for BRCA1,
yes,
BRCA2. But
yes.
I'm talking of rare genes. No one really looks at them, and there are no programs.
Well, that's a good point. Yeah, that's true.
Of only BRCA1, there's a big paper came for BRCA1, then for BRCA2, and maybe RAD51. But invariably for the pediatric cancer predisposition genes, I'm not aware of any systematic program for their functional characterization. Some of them we did, but I had a PhD student for many of them. In 5 years, they had to look at few hundred samples, so they could they could devote 3 months to that, but no one else would do that.
Yeah, I don't disagree with that point at all. I will say the labs doing the large scale functional assays are getting faster, and they are looking at genes that are not so common, like BRCA1. But you're right. You're absolutely right. For very rare disorders, it will continue to be a challenge. I'm just saying, I was trying to answer the question about how much do we do functional assays, and the diagnostic labs here won't wait for that. So you might go and have a graduate student, like I did, do a study, but it took almost 2 years for that to get published, right? So a diagnostic lab's not going to wait for that. So I don't have a good solution to that.
Yeah, thank you. Thank you, Dr. Sharon. I think we come to the end of the panel discussion there. Would like to extend a sincere thanks to all the panelists. Yes, Dr. Sharon, thank you for joining us live since the beginning of this session. Thank you. You are free to stay towards the till the end of this.
Yes. I think I'm going to get off. I will just say I did have the honor of visiting Tata Memorial Hospital a couple of years ago, and I'm very sorry to not be there, but thank you for allowing me to participate. I hope the rest of the meeting goes well.
Yeah, thank you. Thanks so much. Thank you. I would like to also thank our chairpersons, Dr. Mukesh Desai and Dr. Ratna Sharma. Oh, we'll now pause for a short break, tea break. Where tea is provided in the foyer. We request all of you to assemble back in another 10-15 minutes. And we would also like to inform you that e-posters are available for viewing, and they would be judging for the e-posters too. Please feel free to view those in the foyer again. And we have exciting prizes for two of the best e-posters. We'll reassemble at 11:30. Till then, you can catch up with the speakers and other faculty in the foyer. Thank you.
Hi.
Check, check, 1, 2, check. Check, check, 1, 2, testing. Hello, check, 1, 2, testing. Hello. Hello, check, 1, 2, testing. Hello, hello, hello. Hello. Hello, check. इधर Hello all, back again. Let's continue this session two. So I hope you're all refreshed and interact well with the rest of your colleagues. Networking is done, right? So here now we have very relevant to what we have today, that is changing paradigms of pediatric oncology management. So we're going to have a session on precision medicine. So we have a lot of queries, what to do with these tests which we send out, and then whether we have any cheaper alternatives, what are these actionable mutations, what do we target them, and how to access these. So I hope most of these queries are going to be answered in this coming session. So I'm going to invite the chairpersons for this session, Dr. Shweta Bansal, who's a senior consultant at HN Reliance Hospital, Mumbai. And I'm going to invite Dr. Binita Rajeshwari, who's a senior consultant at RCC Trivandrum. Over to you, ma'am.
Good morning, everybody. So in the morning, we had a very good session on cancer predisposition syndromes. And now the next session, which we are going to have, is on the precision oncology in pediatric cancers. I was wondering, like, I work with a hospital where there is a very strong adult medical oncology, and they have a very strong precision clinic on the adult cancers. And there have been talk about starting the pediatric precision clinic also. But I think we are still in very nascent stage, and we need to learn a lot how we are going to integrate this in a everyday clinical practice. And I'm very thankful to Dr. Ganesh, Dr. Maya, keeping this session over here in the EBM to help us in learning about it. So we are going to have a very good session. And with this, I would like to invite Dr. Mamta Gurav, who is a scientist in Tata Memorial Hospital in Molecular Pathology Department. And she is going to tell us about the testing of molecular targets in pediatric cancers, how, when, and why. Welcome, Dr. Mamta Gurav.
So good morning, everyone. I think everyone is fresh now after a tea break. So let's start with a new session. So we'll be discussing in this session about testing of molecular targets in pediatric cancers, how, when, and why. So this is a brief outline of my talk. Now let's directly go to the topic. Pediatric tumors, also known as childhood cancer, is a very distinct entity than the so pediatric tumors, which is very rare. I am not doing it. We go back to first slide. Yeah. Can we start? Next slide. Okay. So these are a very rare tumors having a occurrence of less than 1 to 1.5% and very different than the adult tumors. They are less common. And as we know, adult tumors are much more seen as a carcinomas, whereas in here, pediatric tumors, hematological malignancies or central nervous system tumors, soft tissue sarcomas are very much more prevalent. And so they have a very distinct localization, also genetics. Now, there is a pan-cancer assessment which was done, and it was shown that the 50% of the targetable or 50% of the genetic alterations which are being observed in pediatric cancers are completely different than the adult cancers. Of the total pediatric tumors, we will focus on the solid tumors here. 60% of the pediatric tumors constitute the pediatric solid tumors. Broadly, this mainly includes CNS tumors, neuroblastoma, Wilms tumor, other soft tissue sarcomas, and malignant epithelial neoplasm. So as I said, these are genetically different from the adult cancers. Now, we all know that adult tumors are basically driven by receptor tyrosine kinase inhibitors like EGFR, KRAS, BRAF, and you have a very well targeted therapies against these. But pediatric cancers lack these kind of mutations in receptor tyrosine kinase mutations or other targetable alteration, but they have a different genetic events happening in these tumors. So if you can see here, these are different subtypes of the pediatric solid tumors, and these are the classic molecular events which are associated with these pediatric cancers. So let's talk about BRAF-V600, which is a very classical marker of low-grade glial tumor, or PXA, BRAF fusion, which is a very diagnostic marker of pilocytic astrocytomas, and also a classical event happening almost to 50 to 60% of the PCAs. Histone mutations happening in pediatric high-grade glial tumors or diffuse midline gliomas, which are here playing a diagnostic role. Some of them are MECAN amplification in neuroblastomas, a classical event of neuroblastoma, which helps us to stratify the patient into low risk, high risk. And soft tissue sarcomas, as we all know that these are mainly driven by the RNA fusions, such as SYT fusions in synovial sarcoma, EWS5 in Ewing sarcoma. So there are so many markers and classical single gene events which we know for these pediatric tumors. So there is a need to detect all these. Why? Because it will help us in accurate diagnosis, as I said, in CNS tumors, prognostic information to risk stratify the patient, treatment monitoring, clinical trial eligibility, and also currently for targeted therapy selection. Now, with so much research happening in molecular diagnostics, there are so many targeted drugs are being tested and used in clinical trial for all these pediatric markers. Now, when I say there is a classical event happening in pediatric tumors, is it very simple? No. Pediatric tumors also are complex in genetic nature. Let's take an example of neuroblastoma. Neuroblastoma is not only driven by MECAN amplification, but it also shows different segmental chromosomal aberrations happening at the chromosomal arm level. So 1p loss, 11q23 loss, or amplification seen in chromosome 2, 17q. So along with MECAN, there are other aberrations also happening into the neuroblastoma, which also play a role in the prognosis. So it is very important to include the molecular tests in routine pediatric oncology workup to identify this marker and to help in the better clinical management. Now, when I say we have to identify these markers, what exactly we are looking at? First, pediatric tumors, as I said, are different from adult cancers. They're mainly driven by RNA fusions or gene rearrangement. So firstly, we will be detecting the gene rearrangement happening because of the translocation between the two different chromosomes or two different genes. Genetic level alterations, which can be either single nucleotide polymorphism, small insertions, deletion, and also copy number variation happening at the genetic level or a gene level, which can be gains, amplification, losses. So there are so many platforms available to identify these molecular aberrations, ranging from traditional methods of PCR, fluorescence in situ hybridization, Sanger sequencing, to much more advanced NGS assays. So this is a small comparison or a brief overview of all these technologies which are available, which can be used for a pediatric solid tumor molecular testing. Just let's take an example of sarcomas, which I said are driven by a simple RNA fusion or a gene rearrangement. So for a single gene marker, we can basically use a single gene assay such as FISH or real-time PCR, which will be much more quicker with a very high specificity and sensitivity. But when we want to go for a DNA mutation alteration, such as in pediatric CNS, gene sequencing can be a choice of method, which is gold standard for detecting any DNA alteration at any genetic level. Now, but when we look at the higher aberrations, when we want to look for neuroblastoma, MECAN amplification, other copy number gains, and segmental chromosomal aberration, these single gene assays will not be helpful for us. So we have to go for little bit advanced technologies such as MLPA, which can detect all these aberrations simultaneously. And further, if we want much more comprehensive molecular knowledge, where you include all these aberrations happening at DNA, RNA, or a copy number variation level, you can opt for a next generation sequencing, and these are some of the advantages and limitations of these assays. Now, the choice of the molecular testing in laboratory will depend not only on what is your purpose of the test, what is the sample type which is available, what is the sensitivity and specificity of the assay, what incremental value that technology or that method will add into the patient clinical management, and obviously the cost effectivity. So let's get into some of the samples and how we will do the molecular testing in these assays. This is a sample case 1, 11-year-old girl presented with left-sided scalp swelling for 4 months. Histopathological analysis showed differential between metastatic undifferentiated neuroblastoma and Ewing sarcoma. Now, as I said, if I want to rule out Ewing sarcoma, the best possible molecular marker which needs to be tested is EWS1, which could be a classical event happening in Ewing sarcoma. Also, the possible available sample type here is FFP. So my choice of assay will be any single marker assay, which will be quicker to differentiate between the diagnoses. So here the choice of option will be FISH, which is easier to do in any sample, and you can get the result within 2 days time. So we have opted for a break apart fish probe of EWS-R1, and the sample was tested, and the sample showed more than 15% split signals for EWS-R1, showing the detection or a positivity for EWS-R1 gene rearrangement and ruling out the differential diagnosis and confirming the diagnosis of Ewing sarcoma. Now, as I said, fish, you are using it for detection of gene rearrangement. Also, it can be used for other aberrations such as detection of copy number variations or like deletions or loss or amplification. The best example is MECAN amplification in neuroblastoma. Let's get to the sample case 2. Now, this is a 2-year-old girl with palpable firm mass in the left abdomen. Initial diagnosis was suspected high-risk neuroblastoma. Now, here I have a FFP block available, and we have a suspicion of high-risk neuroblastoma. Now, as I said, neuroblastoma high-risk stratification mainly depends not only on MECAN, but other SCAs like 1P loss, 11q23. Now, if I want to save on the time and go for detection of all these assays, my choice of detection will be MLPA because it will help me to risk stratify based on all these markers in a single assay. Now, MLPA, when I said MLPA is nothing but a simple PCR-based technique where you can multiplex up to 60 different genes or genes regions simultaneously, and you can detect the copy number level variations in these 60 regions together. Now, this is the MLPA data for that particular case. Here, each individual peak actually represents each individual probe complementary to a particular DNA region. And this is a profile for a reference sample or a normal sample with which we will compare the profile of our patient sample and will give it a ratio depending on which we will call it whether it is amplified, loss, or gain. Now, in this particular sample, by seeing just the profile, I can say that it is very highly amplified for MECAN sample. Along with the MECAN amplification, it has showed 1P deletion. However, it was negative for 11q loss. So, considering positivity for both MECAN amplification and 1P deletion, the case was called as high-risk neuroblastoma, MECAN amplified stage 4. Now, these were some of the traditional methods which can be easily done and routinely employed in molecular diagnostic. However, with the advancement, molecular profiling has evolved from traditional methods to much more high throughput assays of NGS, where you can not only multiplex different genes, you can also multiplex sample, and it can also detect multiple alterations together. MLP, as we see, we can multiplex somewhere around 60 gene regions together. NGS has the capability to multiplex n number of genes, multiple samples, multiple aberrations in a single reaction. So it gives you much more high throughput data for a patient molecular characterization. And there are different approaches which can be used in a lab for a NGS. It could be a small targeted panel of 30 to 50 genes only containing clinically actionable targets, or it can be larger panels of 100 to 500 genes, which will provide you much more information of comprehensive detailing. Or you can go ahead with the genome-wide sequencing of either whole exome sequencing or whole RNA sequencing. But also the cost factor will increase depending on what is the choice of NGS you have. However, in routine molecular diagnostic lab, targeted panel is the one which is much more preferred because of the cost effectivity and the easiest of the performance. So this is the pediatric match trial. When I said we can go ahead for an NGS for comprehensive analysis, whether it is worth doing it in pediatric oncology or it will add any incremental value. This was a pediatric match trial which was performed where they did whole exome sequencing of the pediatric refractory cancers to detect the targetable alteration. And they found out that 31% of the pediatric tumors showed actionable genetic alteration, which mainly included TP53, cell cycle markers like CDK4, CDKN2A loss, alteration in MAPK pathway genes. And out of these, 28% of the patient could be assigned to a particular treatment arm, and 13% of the patient were actually enrolled in those studies. So this trial resulted and it showed that NGS is actually effective in identifying actionable genetic alteration for investigational targeted therapies. Also, it supports the use of molecular testing in this population. This is another study. As I said, pediatric cancers are much more driven by the RNA fusions and gene rearrangement. But is it that one subtype will have single fusion only? No, there are possibility of n number of different fusions which can be seen in a particular subtype. So detecting all these subtypes in a single assay is practically not, by a single gene assay is practically not feasible because it will delay the patient management because you have to go to sequential assay performing. So this is the study published in 2020 where they compared the utility of RNA sequencing along with the traditional RNA fusion detection of fish, and they identified that RNA sequencing could detect 29% additional fusions in those samples which were tested with the traditional methods, which could either be missed or could have been delayed because we have to go for a sequential assay. And also tissue would be an issue if you go for a sequential profiling. So now with so many years, there are so many studies and trials which are coming up showing the utility of the molecular testing in pediatric oncology, and they have shown that you can detect 15% to almost as high as 86% actionable targets in these pediatric tumors, where they've employed different types of molecular testing ranging from comparative genomic hybridization, RNA sequencing, targeted panel, or whole exome sequencing. So there is a definite need for integrative genomic analysis of these pediatric cancer, both at the diagnosis level as well as the relapse level, to detect all these kind of aberrations, mutational signature or structural variant or fusion expression. So in TMH also, we do a NGS assay for our solid tumor cases. Till now, we have performed for pediatric cancers, we have performed NGS on 116 cases. This is a targeted panel of 55 genes. This is a pan-cancer solid tumor panel. And the pediatric cancer subtype is majorly included CNS tumors, followed by neuroblastomas, sarcomas, and some other subtypes. Of the total cases, we could detect alterations in 47%, DNA alteration in 47% cases, fusion were detected in 4%, concurrent mutation and fusion was detected in 5% of the cases, and 44% did not show any kind of alterations. Of the 78 cases which were of pediatric CNS, this is the histological spectrum, including low-grade glial tumor, pilocytic astrocytoma, high-grade glial tumors. So this is the mutation map which we identified. In the pediatric CNS tumor, we could detect alteration in 21 different genes, and many samples showed more than 2 alteration in a single sample. And this mutation ranged from BRAF, TERT, PIK3CA. Also, we could identify BRAF fusions, AKT2 fusion, ALK fusion, and there were certain CNV amplification which were observed in the CNS tumors. And this is a mutation map of neuroblastoma cases which we did. We could only perform, we have only performed NGS in 20 cases of neuroblastoma. These are all MYC and non-amplified cases. And we could detect ALK mutation now. ALK mutation is one of the important marker which is coming up in neuroblastoma, specifically in refractory cancers, where you can have a possibility of ALK inhibitors. And along with ALK, there was TP53 BRCA, and many of the samples showed multiple alteration in these neuroblastoma cases. So we have seen that there are so many different types of alterations happening in pediatric oncology, and there are so many molecular testing methods ranging from single gene assay to the NGS. The choice depends on what resources we have and what is the purpose of the assay. But there are certain challenges we need to face when we go for molecular testing of these assays. Basically, as we know that FFP is our sample of choice in most of the labs. So this FFP tissue itself has certain issues related to tissue processing, fixation, tumor heterogeneity. And many of these multiplex assays or a high throughput assays require a very high, good quality sample quality and quantity. So FFP could be the issue in some of the samples to get the molecular assay successfully done and detect the alterations. Also, there are, as the adult tumors is well established for the targeted therapies and the treatment, we don't have so many targeted markers available in pediatric oncology, although the research is ongoing. So there's a lack of targeted drugs, and other is platform heterogeneity and obviously a cost. So not all challenges can be solved immediately, but the first challenge, which is the first important challenge in any molecular diagnostic lab, is the FFP sample. However, liquid biopsy is coming as a promising solution over these issues. Liquid biopsy is very well established in adult cancer, but I think in pediatric also it is now routinely being tested. And there are so many trials happening which will help us to identify new targeted therapies also. I think with that, I can conclude my talk. This is our molecular pathology laboratory team in TMH. And thank you. And thank you for patient listening.
Thank you, Dr. Mamta. I think we'll take the questions at the end of the session. So going on to the next talk, we invite Dr. Venkat, who is one of the leaders in pediatric oncology in the current scenario, to speak to us on precision oncology in pediatric cancers, the current status, scope, and gaps in India. Welcome, sir.
A very good morning to all of you. I'd like to thank the organizers for this opportunity. A lot of what I'm going to talk to you today is probably being covered by the speakers, but I'll just try to highlight it again and discuss it with relevance to the current status, scope, and gaps in precision oncology in India. The first question is, what is precision oncology? So precision oncology tailors to the treatment to the genetic and molecular characteristic of tumor of a patient. And there's a growing role in pediatric cancers as we have seen. And pediatric cancers, unlike adult cancers, are kind of different in terms of the mutation burden. They tend to have fewer mutation burden, but they have larger structural variations. And there's a strong correlation with certain histological types with the tumor landscape. And there are various clinic applications as we have seen today, and this includes, at metastasis to see if there is any treatment available, any targets are there, patients where you're not able to find a diagnosis, unknown primary, trying to help you see where the tissue is coming from. We had excellent talks on cancer predisposition syndrome today, so it identifies at-risk family members and also helps in identifying risk factors, prognostic factors, and integrating pathology in diagnosis. And there are various techniques, and my last speaker discussed about them. It depends on how deep and how much you want to go. So you can sequence the whole genome or just the exome, and you can look beyond the DNA, go to the RNA. You can look at methylation. You can look at targeted panels and expression microarray. One thing which we all tend to confuse is that we think precision oncology is just the lab and just the DNA and RNA. It's beyond that. And when we talk about precision, we're looking at the patient. And so you have to look at other aspects like radiology, artificial intelligence, bioinformatics, theranostic, that is where you use radioisotopes. There is no precision oncology if you can't generate evidence. You might be able to find a gene, but does it really make a difference? So you need to have customized precision oncology clinical trials. So as practicing clinicians, we should develop all these areas if we really want precision oncology to succeed. And this is mainly for fellows. A lot of adult data on various precision oncology trials. If we as pediatricians need to show that precision oncology has to succeed, we need to start doing these kind of trials. These are basically, most of them are phase 1 and phase 2 trials. And for example, basket trials. So basket trials are nothing but it's like each fruit is a type of cancer with a single mutation. So if you have BRCA positive, you can get BRCA in breast, prostate, and so and so. So you call one drug for various cancers, a single mutation. Umbrella is that you take one tumor and try all the types of drugs. Then you have octopus and platform trials. These are evolving trials. You start doing the study and you find something works, you continue, something doesn't work, you do it. And N+1 is actually one patient trial. You try something new on the patient and you want to see. But all these have challenges. They're small numbers, they're complex, you need high cost, you need heterogeneity, there are statistical limitations. Currently, this is the biggest challenge in India. We do not have, even in adult patients, such trials ongoing. So if you want to develop precision oncology in India, we should start thinking about designing such studies, and maybe INPOG and the PHO chapter can have some initiatives. Again, it needs government intervention because phase 1 trials in India can only happen if the molecule is developed in India. So if you have a molecule which is developed in US, you can't bring it to India and do a phase 1 trial. The next question is, does it work? It sounds fancy, it's expensive, you get the latest Illumina machine, you put it in a lab. And as clinicians, frankly, sometimes it can be really overwhelming because when you have so much data, you have hundreds of patients to treat in the clinic, do you want to spend that extra effort sending those samples, getting those targeted treatment, even if you want to get it on a compassionate basis, the paperwork involved, does it really translate? Does it give you bang for the buck? And that's why we need evidence. And as my colleague has already alluded, you have the National Cancer Institute MATCH trial. So this was a large trial of 6,000 patients on precision oncology. It had about 1,300 pediatric and it's young adult. And there were multiple sub-studies, and each sub-study was like a phase 2 trial. And the idea was to pick up a target, give a drug, and see what was the objective tumor response. And this was run across US, and here you can see the various drugs, the targets which were detected in pediatric patients, and patients were, if they found a target, they were put on the drug. If they progressed, again the biopsy, if they found a target, again put one more drug, and they found out. The interesting thing is that when this was in collaboration between NCI and COG, they thought they would detect about 10% of patients to have an actionable alteration when they started out, but they ended up detecting almost 30%. And certain tumors like CNS tumors and the patients who are enrolled in pediatric phase 1 clinical trial network sites had higher chance of being given a targeted agent. And surprisingly, the MAP kinase pathway was the most frequent alteration, but currently we don't have any that much effective drugs for these kind of treatments. And these are all the 6 or 7 papers based on the match trial of various drugs, some of them unpronounceable. But the question is, has it changed the practice in India? No, not yet. There is data. Yes, we have a repository of pediatric cancers in the US. But if we want to do something, we need to have an INPOC match or a PHO match or a pediatric match in India to really understand where we stand. So this is a bigger challenge for us. So it's taken the West to almost a decade to reach here. So, and nothing has been path breaking. There is something that they tried these agents, but does it really translate to better outcomes in the clinic? We really don't know. And these are further trials which are done in the West, in Germany, UK. Look at this graph here. About 20% of patients end up receiving targeted treatment. And also interesting is that about 10 to 15% of patients have a germline predisposing mutation. But we really don't know what was the impact of detecting drug. Did it make an improvement in the progression-free survival or overall survival? Did it make an impact on quality of life? Unless we know that, maybe in the next few years, we really don't know whether this works or not. This is interesting because, yes, this gives the germline mutation gives us enough knowledge to screen the family, do surveillance. So this data is very interesting for us. And I would go on and go on. There are some single center studies which have shown that they were able to detect actionable mutations in 1/3, and they were able to refine a diagnosis and prognosis in another 1/3. And people have even looked at combining genomic profiling with drug sensitivity, and they showed that there was 1.3% improvement in progression-free survival and between patients where you ended up doing the genomic profiling as well as the drug sensitivity. Again, this is from Poland, which shows that 4% of cases had a diagnosis. So it's very heterogeneous, anywhere from 10% to 30%. But what do parents feel about precision diagnosis? Parents are usually parents are very hesitant to participate in clinical trials, at least in India. But when it comes to precision oncology, they have very high satisfaction despite uncertain outcomes. It probably gives them a ray of hope, because most of the patients are relapsed, refractory, and this is something which probably tells them that there might be a miraculous drug available for them. So they're generally happy, but they're concerned about the wait times and access to the drug. So this is a good paper and tells you that from the parents' side and the patient side, precision oncology is liked, and they want us to do more such studies. And there are various databases. So you have the German database and the Senjus database, which actually puts up all the mutational signatures and expression profiles on the web. And I think it's high time India also has such a database, and I'm hopeful Professor Sareen and her team are working towards it. So we need to have our own pediatric cancer database in our country. So this is another big gap where we lack for a country which has almost 15 to 20% of the world's population. It is high time that we start having our own repository which is easily accessible to the researchers. Further, moving on to the Indian scenario, if you do a Google search for precision oncology, it is a current buzzword. You have India's first AI. There is a precision oncology in rural India. I don't know how is it different from urban India. So there are a lot of things. There's a lot of buzz. India is a country of contrast. So probably just like we have PET scan in every street, we might end up having an NGS machine in every street. But there is lack of trained personnel. There is lack of quality control, validity, expertise. Even if you're able to detect a mutation, what do you do about it? Where are the drugs? Even if the drug is there, are they able to provide? For example, crizotinib, you detect ALK fusion. Alectinib or lorlatinib would cost you 200,000 rupees a month. How many of them are going to afford this? So these are some of the challenges in the current scenario we are facing. And we need, if you want to do precision oncology, everybody has to start biobanking their samples. Again, that requires a lot of investment. There are no currently laws on biobanking in India, and we need to strengthen the biobanking law. So there has to be some regulatory and infrastructure needs which needs to be addressed. The market is going, as I've already said, there are so many companies and it's projected to reach $7.3 billion by 2028. And most of them is driven by private investments and funding and the cost. In the US, it's about $12,000 to $21,000 per patient for precision oncology. We don't know what is the cost in India. Definitely, it is beyond the reach of most people. And the next few slides, I'd like to thank Dr. Vijayalakshmi, our molecular oncologist, because she does all this work. And for example, you want to do a whole genome sequencing, and she found out that it takes about 1.3 to 1.5 lakhs, and turnaround time is up to 3 weeks. And these are all the various machines or companies which are able to do this for you. You want to do a whole transcriptome sequencing, changes from 20, charges are anywhere from 20 to 40,000. Again, various options. It's like a buffet, you can choose whatever you want. I'm not an expert in this. When it comes to whole exome sequencing, again, the price is between 25 to 75,000. When you want to do a methylation sequencing, anywhere between 20,000 to 1.2 lakhs. You want to do expression microarray, 12,000 to 30,000. So what I would like to say is a CBC would cost you 500, 600 bucks. But if you want to get into this, suppose a child with ALL comes, your flow, fish, everything sets you back with 10,000. Putting another 20,000 to 50,000, where do we get the money from? When we, unless it comes in your Ayushman Bharat or insurance scheme, we are not able to afford this test because it's like the annual salary of most of the people, at least in the settings where I treat. And there are a lot of targeted panels. So you have lymphoma panel, leukemia panels, lung, breast, and adult side. There are currently no individual panels which are designed for pediatric cancers, which are commercially available in India. In the US, you have the SJ St. Jude Speeds panel. We also need to develop such panels, and that can only happen if we are able to identify what are the common genomic alterations in our population. So we need to start having a national pediatric oncology registry for precision oncology. We have to start integrating genomics in our routine care. There has to be more public and private partnership because most of the labs are being opened by private centers for genomic testing. There has to be more academic and industry involvement. And we have to start including pediatric cancers in all the national precision oncology medical programs, because it has to be mandatory that if somebody is trying to do precision oncology in adults, they have to have a pediatric cohort, and we have to start designing clinical trials which include molecular target therapy. Now, all is not doom and gloom. I don't want to sound negative, but there are a lot of rays of hope. Then this is from Tata Memorial Hospital, the Narsimha project, which was done by Dr. Nikhil Patkar's and team, and they sequenced leukemia patients. And the good thing is that they were able to bring down the cost to almost 10,000 INR. That's about $150. And the turnaround time was only 2 weeks, and it's open source. It's freely available for the world to see and implement. And this helped in diagnosing things like BCR-ABL, PH-like ALLs, and we are going to get away from redundant technique like switch. So we need more Narsimas in our country. And the ICICL group is slowly moving towards incorporating the genomics into our routine care. So we have the Radical project approved by ICMR, again led by Dr. Nikhil. We are looking at low-cost NGS MRD with DKMS. And we have the AI-based relapse prediction, which Dr. Vijayalakshmi is doing, which is the Prepare ALL. So to end, I would say that precision oncology has a potential to revolutionize pediatric cancer care. We are a long way. We have been able to do for selected patients, but we still don't have the bandwidth in terms of infrastructure, policy support, and collaborative efforts. We need to focus on affordability, accessibility, and finally, the clinical impact, because if you're putting money, it should actually have some benefits. So thank you.
Thank you, Dr. Venkat, for a very lucid presentation. It is a complicated topic, and I think we are learning a lot. And I always remember for one of the book, like which way to choose, it depends upon where we want to reach.
Yes.
And this is how we are going to work on that. Thank you so much. So next talk is by Dr. Darren Hargrave. He is from University College London. He is into a lot of pediatric oncology precision trials, and he's going to discuss his experience on that and the lessons learned. Thank you, Dr. Gord.
So thank you very much, and thank you for the organisers to invite me to this fantastic meeting. I'm learning a lot. I'm going to talk about lessons learned from pediatric oncology precision medicines. As I said, I deal a lot with early phase trials, and these are my disclosures, but the thoughts that I'll be giving you today are my own. I'm going to skip over this, but I would like to say something. I totally agree with the last speaker that precision medicine is not just about molecular targeted therapies, even though that is what I'm going to mainly discuss. It is a much wider scope of things in pediatric oncology. So let me move and get down. I think the key is for precision medicine, you need to combine these two elements. So you need powerful genomic technologies, of which you've seen from the previous speakers that there are multiple ones. It's really important to have a turnaround time that's clinically meaningful. It's no good to have something that takes many weeks. Has to be cost efficient, which of course depends on context. And you need to actually be able to look at all the genetic aberrations. And of course, the other component is we need access to treatments. Otherwise, what is the point of our precision medicine programs? So I'm going to start off with some successes, and particularly in relation to one of the major areas that I've been involved with, which is in pediatric glioma. So pediatric low-grade glioma is the most common brain tumor in children, about 3,000 to 4,000 cases per year. Most patients will survive, but there is still a significant number that will die from their disease. But they have a lifelong chronic disease, often with multiple morbidities. And our conventional treatments for unresectable lesions have been standard of care chemotherapy for many years, and radiotherapy, which we know can cause late effects. But what we've learned from research is that one of the common things about these tumors is they have MAP kinase activation as a hallmark, whether that's from neurofibromatosis as a genetic predisposition syndrome, from BRAF V600 as a point mutation, or more commonly from BRAF fusion. So, of course, that was intriguing for us because these targets had been developed for adult cancers, and we were able to think about repurposing these drugs. So one example is dabrafenib trametinib, and approximately 12 years ago, I worked originally with GlaxoSmithKline and then with Novartis to develop a pediatric development program for these agents. We knew that they were very effective in BRAF V600 melanoma, including in CNS metastases, as shown here by this waterfall plot, where we can actually see significant responses in patients who relapsed after standard of care chemotherapy. So we actually designed a basket trial. So this is an example of a basket trial. It was sponsored by Novartis, a global study where any relapsed pediatric cancer was eligible as long as they had a BRAF V600. It was a seamless phase 1, phase 2 trial where we actually had a pediatric formulation and were able to dose according to PK modeling. So we didn't dose to toxicity. And then we had tumor expansion arms, of which the most common were the gliomas, but we also had histiocytosis involved and access to other rarer tumor entities. What we actually saw from those early phase was a very high rate of response rates in pediatric low-grade gliomas and high-grade gliomas that had BRAF V600. We rapidly moved this forward to an international study. So this was conducted in 15 countries and 50 sites, and we published this back in 2023, the results of this pivotal randomized study. So this is what it looks like. This was available for newly diagnosed low-grade gliomas with BRAF V600. They had a 2-to-1 randomization of the experimental targeted at-home oral therapy versus standard chemotherapy. And we also had an arm for relapsed high-grade gliomas. So these are the results. These are waterfall plots, and you can see that pretty much every patient responded. For patients with dabrafenib trametinib had a much deeper response. They had a more durable response with less relapse cases compared to standard of care chemotherapy. And this is represented here with a 47% objective response rate compared to 11% for chemotherapy. That translated across all histological subtypes. So having the BRAF V600 mutation was the predictive biomarker to response rather than histology. and it translated into progression-free survival, which actually met our predetermined endpoint at a significant level. In fact, actually more patients continued, because what we found was there were patients who had small increases in size, but actually never returning to their original status, and those patients benefited from continuing. This is a swimmer's plot. These are individual patients, and we can see that responses were very early compared to chemotherapy, and they were durable. But of course, one of the big issues is when you can stop these drugs, and we're still not entirely sure. We would normally treat patients for at least 2 to 3 years and then have an attempt to stop, but some will rebound and need to be re-challenged. So here's just some representative scans. You can see a very early and dramatic response, both in T1 and T2, to patients receiving this, and this was repeated throughout. Very importantly, we studied quality of life for the patients and their families. And what we found was the quality of life improved for patients on the oral targeted therapy, whereas unfortunately, the quality of life decreased for those that were receiving our conventional decades-old cytotoxic chemotherapy. And this was due to the response rate, but also the adverse events, with half the grade 3 adverse events occurring with oral targeted therapy. And what we saw is a difference in terms of skin reactions, mainly in targeted therapy versus hematological, febrile neutropenia, need for transfusions, etc. So a much decreased time spent in hospital. I'm pleased to say that the high-grade glioma cohort, which was non-randomized in relapse, also, we published this in JCO, also actually showed very high response rates, as shown by these waterfall plots, similar rapid responses, and actually a progression-free survival. Although patients did sometimes develop relapse, they actually survived for many, many years, whereas actually previously this would have been measured in months. So has this led to a change? I would argue it has in some places. So actually, across the Western world, this has actually now been approved by the FDA, by the European Medicines Agency in the UK, and funded, and actually has become a new standard of care in many places, but not everywhere, because obviously there are cost implications. So is this just a one-off? Well, no, we've also embarked on newer type 2 RAF inhibitors. We published this results in Nature Medicine last year, and actually this has led to early approval of tovorafenib, a type 2 RAF inhibitor in the FDA, and we hope to actually get similar approvals in Europe. This was the Firefly-1 study. And actually, just very quickly, again, showing very good response rates. Interestingly, in orange are patients that were previously exposed to MAP kinase inhibitors. So it does seem that you actually can get additional responses when using these agents. So that's the good news story, but actually I wanted to present the kind of full lesson, and you've seen some of this, but I want to take up the lessons that we've learned here. So in fact, this one of the tables from this has already been shown, but this was we had a workshop of all the leads of the major precision medicine trials, so including Will Parsons, who led Paediatric Match, but also the French, the German, the UK, and Australian leads. And you've already seen this table where we compared it, but I'll show you some extra data which we've included as a result of our own UK-based stratified medicine pediatrics, which I have the privilege of co-leading with one of my colleagues at the Royal Marsden. So this is another next generation scheme where we've treated over 1,000 patients now, and we use both panel sequencing and more recently whole genome sequencing. I run and chair a national molecular tumor board to feedback, and we triage patients for either approved or clinical trials. And what we showed in these tables, this is the French, the German, the Australian, and the UK, was that actually, even using different techniques, we actually were able to deliver this, usually in a clinically meaningful platform time. So I have to say, we've now got this down to around about 14 to 21 days in the UK. Germline has been described. Changing diagnosis actually did occur even in these developed countries, with refinement in about 12% of cases. The actual mutation rate is always presented to you as kind of 40 or 50%. In the UK, we've been a lot stricter about what we call an actionable mutation rate, and we described it as 33%. But when it actually comes down to a molecular tumor board recommendation, you see it falls between about 13 to 18%. And when you look at high-level evidence, so tier 1 evidence of actionability, which is based on actual clinical data as well as strong biological rationale, we kind of find around about 10% of patients can actually truly have that. But this is at relapse, so that still is significant. So what are the lessons we've learned? Well, from the view of the first generation, we can see that there's a massive variation in the sequencing technologies used. We can see there's a massive variation in the bioinformatic pipelines used, and actually in something as simple as the definitions of actionability. And actually, this variation does actually lead to us being not able to easily compare or, for instance, do a meta-analysis. So we're now starting to work to see if we can adjust that and harmonize things. I've already talked about actionability and the various differentiations. Some of the trials included P53, for instance, as being actionable, and that's because they had clinical trials looking at that. But we know in reality that is probably not actionable. Some included mutational signatures, which I think are of interest in the future, and some also looked at retrospective evaluations such as tumor mutation burden. But again, I would emphasize, if you look at the proper tier 1 level evidence, what we really were finding is we could predict responses for BRAF inhibitors, MEK inhibitors, TRAC inhibitors, and ALK inhibitors. But beyond that, actually, responses were actually relatively low. Even in these large national platform studies in developed countries, lack of availability of drugs within clinical trials was a major barrier to actually matching. And many of the children actually receive this off-label or by compassionate access programs. So that is something that we need to build on. And certainly, I agree that clinical trials are the way forward if that's possible. That could be due to geography, age, social access. But there's also a lack of standardization in the outcome reporting. And as already been said, I think that's really important if we're going to actually really value the value addedness of these precision medicine platforms. So all of them detected the same aberrations. And you've kind of seen this graph earlier, and this is just the UK data. And we actually get pediatric cancer is probably pretty similar across the world. One of the big problems we have, though, is that a lot of pediatric targets are currently undruggable. And if we look at MYC, MYC-N, PAX, EWSR1, we currently are unable to drug those. But there are major initiatives now in pediatric oncology looking at these to see whether there are actually opportunities to drug them with degraders, molecular glues, etc. So implementation, well, this has moved on. And in fact, in England, all children now who have cancer will get a whole genome sequencing at the time of diagnosis and at relapse, as well as panel sequencing. In France, it's a very similar situation for high-risk patients, and Germany is securing funding to do the same. What about the technology? Does it matter? Well, when we looked at these platforms, what we saw that there was parallel use. So we were actually duplicating tests in order to look at all the genetic aberrations, which of course is very expensive. But the idea is that can we eventually arrive at one particular technique that would actually allow us to do this? But currently, DNA sequencing is used for nucleotide variants, RNA sequencing for gene fusions. And each technology has its own problems. What tissue does it need? What form of that tissue? How much tissue? The cost, the turnaround time, the amount of bioinformatics. So none of them is perfect. But I have to say there is an increasing move towards using whole genome sequencing in a lot of developed countries, along with RNA and methylation. This is the Cancer Zero Australian study where they actually say that they actually found that there was an added benefit to this for actionability. And this is actually one of the first papers coming out of the UK-funded NHS whole genome sequencing, where we were actually finding, we did find aberrations that were not found in some of our panel sequencing. So what's next? Well, in stratified medicine pediatrics 2, we're moving on. And actually, we are looking at whole genome sequencing, but we're looking at new technologies. This particular one is called nanopore sequencing, which has the ability to sequence DNA, RNA, and methylation from the same sample. It has real-time analysis, which means that you can theoretically get the result back within days, if not hours. And actually, this has already been started to be implemented, and this is what we will be studying in the UK. One of the first outputs that we looked at was what's already been mentioned, which was liquid biopsy. And in stratified medicine pediatrics, we actually looked at plasma samples. It doesn't work in brain tumors. In StratMed Peds 2, we're going to be doing it on CSF. But in plasma, what you actually see is there is an overlap but you get more information. So actually, it's giving you a more complete picture of metastatic disease, tumor heterogeneity. So stratified medicine peds is actually looking at serial liquid cell-free DNA as a major determinant. How are we going to use this? Well, this is what Example Connect, which I have the pleasure of co-chairing with Mariam Filadi, is a transatlantic neuro-oncology program. And this is an umbrella study. So the example of an umbrella, we all know that pediatric high-grade glioma is not one tumor, it's multiple different entities. And what we're trying to do is to actually devise a multi-arm platform umbrella study to address all of these molecular entities. What it has allowed us to do is to harmonize between US, Germany, UK, Canada, and Australia, our precision medicine platforms, so we're having the same results. And this is a major effort, which is actually taking all these people, and I'd like to thank them. I think we need to move beyond just DNA, and I think we do have to start to consider the tumor microenvironment, the immuno-oncological profiling, and it's already been mentioned that, for instance, the Dutch team are now doing real-time organoid testing for individual patients. So finally, I think we've demonstrated that from a technical point of view, this is possible to implement at a national level. It's actually allowed us to facilitate these new generation molecular trials, but also introduce some agents into clinical practice. But the majority of patients do not currently have matched therapy due to non-druggable targets. So we need to look beyond that. And there are, of course, been mentioned other benefits, but it has to be actually looked at in a value-added context. So with that, I'd like to thank some of the funders of our research, but specifically the patients, their families who agreed to go onto our trials. And thank you very much again to the faculty. And I'm happy to answer questions during the panel session.
Thank you for that wonderful talk. So, Maya, should we take questions now or after the panel? Yeah, sure. Thank you, Maya. So for the panel discussion on the impact, and so we have listened to a lot of theory now. So is it really possible to implement these in a molecular tumor board setting, in our settings, in LMICs? So to head this panel, we have Dr. Girish Chinnaswamy, sir. Welcome, sir.
Good afternoon, and thank you, Binita and Shweta. I would like to invite our panelists. So Darren is already here. So as you all know, he's from Great Ormond Street, and he just covered beautifully what precision oncology means in pediatric oncology. I would now like to call Venkat on stage from Cancer Institute, Adyar. I also have another Venkat who is actually sharing the same sequence of Venkat and Ram, but then he's got Gollamadi and he has got Radhakrishnan, so there's a difference. So Ram, come on stage. And Mamta, can you please come on stage? And I've brought the person who does the most precision oncology in Tata, Kumar Prabhash. He's here. Yes. Please come. He's an adult medical oncologist who has a lot of experience, especially in various adult cancers where precision oncology has come in much more active. And there's one more person missing. Is that it? 5 panelists. Okay, great. Okay, thanks. So I think what we will discuss now is it actually time to set up a molecular tumor board in pediatric cancer, and whether we can actually do it in a resource-limited setting. I will take you through a few cases, which are all our cases, which are done here, and one from outside as well. And like your inputs on whether we should actually set up a molecular tumor board, and in what context and what benefit it would provide, taking into account all the discussion which has occurred in the last 3 talks. So the molecular tumor board, I mean, as was explained by all of you, and Darren very rightly put it, you actually need a very strong diagnostics. And so the availability of the diagnostics is critical, and the type of testing which is being done. And we have seen how the generation of testing has changed and change, including the new generation of tests are identifying both newer targets as well as and the number of druggable targets are also very different by the type of test you use. And the second component for a low and middle income country is about therapeutics. What is the drug availability? What is the accessibility? Including cost, which is actually a major factor here, especially taking into account that a lot of these drugs are not covered by the government schemes or the public funding, for the reason that many of these are not approved in children and many times in adults to be used as well. So we need to discuss this in the context of the resource limited setting. What is the impact of bringing molecular testing and molecular tumor board compared to what we are achieving in conventional therapy, which in children is quite substantial compared to adults in terms of survival. So from that point of view, we need to look the whole discussion today. So I'll start off by a case, and this case actually is by Vasudha, who is in the audience here from Bangalore. She's from Rainbow Children's Hospital, and this was a patient who was 6 months old, came with vomiting for a few months, and with increased frequency over the last 2 weeks, and was a well-thriving child. And per abdomen, there was a mass in the epigastric region and the umbilical region, which was homogeneous, enhancing well as well. And then this was the biopsy of the mass. It was an infantile fibrosarcoma, a spindle cell tumor, and the immunohistochemistry was pan-NTRK positive, S100, and SMA positive as well. So the morphology and immunophenotype all consistent infantile fibrosarcoma, and it was a pan-NTRK positive. So this is not a very uncommon situation for pediatric oncologists. So we see that quite common in less than 2-3-year-old child. And we don't really panic when we get this because we generally think it's something we can handle fairly well. But this is what happened to the child. The child was started on vincristine, actinomycin, cyclophosphamide, standard treatment. Some people would do only 2 drugs, but here Vasudha did go on to give 3 drugs. And in spite of giving 3 drugs, she saw improvement for in the first 9 weeks. And then the bilious vomiting came back again. And then there was a marginal increase in size. So the chemo had not had the desired response, which we would expect in this condition. So surgery was done. It was an R+ resection. And post-op 2 months after the resection, there was a recurrence of the lesion with infiltration to the duodenum. And now a gastrojejunostomy had to be done because there was intestinal obstruction. And then around this time, the molecular testing was sent to a private lab, and this is what you saw. So you had a MYH9 NTRK3 fusion positive. So it was a Tier 1A mutation, which was a pathogenic variant, which was seen. And the drugs which can be used here, which are approved, was larotrectinib or entrectinib. Now, there are various issues which came up. The child is small, so cannot take tablets. And the tablets generally are not advised to be crushed because of the inactivation which occurs in the gastric juice. But somehow this patient was able to get the liquid preparation. And so the liquid preparation was started. And 4 weeks from initiation, you saw a dramatic response. The mass is pretty much gone. It pretty much disappeared. So it was a very significant response. And then after the mass went away, the discussion was how long we give, and the plan was we'll give it for 1 year and stop because we didn't know how long to give the therapy. Let's give 1 year and stop, and I'll tell you what happened to the child subsequently. So now my first question is, maybe I'll put it to Venkat. Infantile fibrosarcoma, when you see, would you ask for molecular testing or would you just go with treatment?
If the patient can afford it, yes, I would. Otherwise, I would just go with the treatment. So it has to be individualized. If there are guidelines that you have to diagnose infantile fibrosarcoma based on molecular testing, and if you're planning to give a targeted treatment, I wouldn't give blindly based on histology. I would need some genomic proof to say that, yes, this target can work.
Okay. Ram, would you like to answer that question? Anything what would you do? Would you also agree that you would send a molecular testing for infantile fibrosarcomas?
So we rely heavily on the histopathology, the IHC, where we look for the pan-TRK and then usually proceed with the diagnosis and plan for the treatment. But ideally, whenever we are planning for molecular therapy in a refractory setting or unresectable tumor, that's when we would do a testing.
Okay. So I'll tell you about infantile fibrosarcoma. What generally the consensus for infantile fibrosarcoma management is that if you have a localized disease and surgery is feasible, you do surgery and no further chemotherapy is required. However, if you have like a group 3 IRS group 3 disease and mass is left behind, then chemotherapy can be given. Or the other option is you actually give chemotherapy if it's a large tumor, shrink it and then do surgery, or you also use NTRK inhibitors. So there is both approaches which are there. But generally for metastatic disease, the consensus is that you go ahead and try to use NTRK inhibitors upfront so that you have a much better response which is expected than chemotherapy so that you could actually go and then do the surgery. Generally, no adjuvant therapy is given for an R1 resection, and the goal of therapy is to achieve a gross total resection. And most of the chemo and the inhibitors which are used are for NACT adjuvant therapy, and there's really no role for radiotherapy. Kumar, you wanted to go ahead.
A comment and maybe question to our to pediatric oncologist. So if you don't do it upfront and think about 3 years down the line, the disease comes back, then do you do the test or you don't?
Ram, would you like to take?
And you do the test now where from? The old tissue or you'll do the biopsy again? And then maybe that question can come to her, how comfortable she is with the 3-year-old tissue to do the test. But first, so this again for the audience to know that when, what are those merits and demerits if you don't do it?
So I guess one is these are canonical mutations which are seen in almost all the patients, and there's going to be diagnostic of infantile fibrosarcoma. But at the same time, coming back to the point that they can be reliably diagnosed also with the IHC in place. But when we are definitely in a relapse setting, then would definitely go for a testing.
Mamta, would you like to say what would
Old
say?
tissue, new tissue. In case you don't get new tissue, how comfortable with your 3-year-old tissue?
So definitely if I have an option of newer biopsy, I will go ahead with a new tissue because that will help me to be confident to get a good quality nucleic acid, both DNA and RNA, because we are dealing with the RNA fusion. So getting a good quality RNA from a 3-year-old or a 5-year-old FFP block will be a little difficult. And you may miss out some of the fusion if you don't have a good intact DNA or RNA. And the other question was key. If not newer biopsy is possible, as I said, liquid biopsy could be one of the possible option. If you don't have new biopsy, you try it on an old block. If you don't get a suboptimal DNA quality, we normally don't go ahead with the NGS assays because that will lead to a failure rate or missing out some of the alterations. So liquid biopsy can be a possible option in that scenario.
Darren, what would you do? To do it upfront? Wow. Yeah.
Thank you. So, of course, as I said, everybody now does get testing irrespective of what histology or the suspected. But in the past, we did exactly what had been suggested, which is these patients would have been treated on chemotherapy, and then at relapse, that's when they would have had the targeted sequencing. So, so that is how we did it before, but now we've moved it all up front.
So just putting a number for the audience that if you do a 3-year-old tissue, half tissue you'll fail. Remember that, so that if you think about your disease relapse, a place where you are not able to get the tissue, and this we did a work, and Mamta will be aware that, so remember that if you're really planning for a treatment and a molecular testing, and the moment your tissue gets older, that should be at the back of the mind in also in decision making. I know if the prognosis is excellent, you are always constrained. If I do test, if it comes positive, what do I do? And this we also encounter. NTRK we deal with in our adult side and lung and some other cancer. So this is a problem you face. But also remember, if you don't do it now, and next time you don't have a tissue, that old tissue will be of help, but in half of the patient it may not.
Yeah. No, the point is very well taken. So there is a shift, gradual shift to testing this upfront in many hospitals across the country, even though you may not use the therapy upfront, just to identify that if you need to add the therapy in poor responders or in a relapsed disease, So most of the people do that upfront, and it's very common now in brain tumors that you would always test them, even though you may not use the targeted therapy upfront. And the idea is mainly the reason what you said. So you're getting tissue once in brain, obviously you can't get a tissue. You try not to get a tissue second time. So for which is that? You want to add?
But sir, the threshold for testing for tumors like this infantile fibrosarcoma, which has got excellent
much higher.
prognosis, compared to the tumors like low-grade gliomas pediatric, would definitely
It's
be
much
in
different.
practice in an LMIC.
So this is just to tell, just with surgery and chemotherapy, you would get an 89%, 90% overall survival and about 75% event-free survival. But obviously in this child, clearly molecular testing was critical, because if we had not done that upfront at 9, 10, 12 weeks, you would not have got this result for doing that. So for whatever reason, Vasudha was right, and she did send it early and managed to start off therapy in about 9 to 12 weeks, and the child did have a good response to that. So I will now move on. So this is a good responsive sarcoma. So here probably would do a molecular tumor board in the context of a situation where there is a poor response or there is a relapse disease. But now I'll move on to the rest of the sarcomas we see across 0 to say adulthood. As you know, as the age goes up, the rhabdomyosarcoma decreases, and you get more and more non-rhabdo soft tissue sarcomas. And as age increases, the soft tissue sarcomas response to chemotherapy also becomes less and less. Now, this is by no means a perfect list, because I am still not clear in which non-rhabdo soft tissue sarcoma chemotherapy would work and which is it's really resistant. So I think the resistant component on the right column is pretty much clear. I think chemotherapy has no role in any of those. And on the left column, probably have some role, works in some situations, and the response is modest in some, very suboptimal in many. So in this situation where we are, would you, and then the non-rhabdo soft tissue sarcoma whole approach is very different. So here you put them all together into one basket. All non-rhabdo soft tissue sarcomas are treated the same. You just approach them with local treatment and chemotherapy, and there are broad guidelines for chemotherapy. And as you can see, the outcome is very different. If you have a inoperable tumor or a metastatic tumor, then the outcome is far, far less in a non-rhabdo soft tissue sarcoma compared to those who are operable and low-grade tumors. So in such an approach where we do not have a clear systemic therapy backbone which would actually control the disease. So my question is, in these situations, would you actually recommend molecular testing for all for a non-rhabdo soft tissue sarcoma? And I would come to Venkat first on that.
Our current practice is not to do it. And the reason is that even if you're able to detect molecular aberration, there are, I think, very limited or no targeted treatments which improve outcomes of survival, at least in pediatric sarcoma. So they may be prognostic. They might tell you whether the child is going to do well. Say, for example, you detect a fusion in RMS, but you're still going to give the same chemotherapy. You don't have any targets. So if first treatment fails, relapsed, maybe I would do it. But upfront, we are not doing a full NGS. We have a IHC panel to know whether it's a FISH panel to know whether it's synovial sarcoma or Ewing sarcoma, because there the chemotherapy changes. But to upfront targeted therapy in sarcomas, if the pathologist is confident, we are not doing it currently.
Kumar, your take on this? If you have a non-rhabdo soft tissue sarcoma, where systemic therapy is not well established, would you want to do this upfront?
So pediatric knowledge will be limited, but in case it prognosticates, well. Now, I'll give you an example. In head and neck cancer, if you have, perineal invasion or not, or if you have vascular invasion or not, that doesn't decide treatment, but that gives me a prognosis. So do I require from a pathologist? I do. Now, here again, if we agree upon that it is giving a good prognostic differences in the group. Now, number I don't know. Think about it, differentiate a 5-year survival difference between the two groups by 40%. Will I like to know as a patient? I will like to know as a patient that how is the prognosis in spite of treatment being different. I do concede the resource issue is there, and sure, we will have the discussion regarding LMIC, what to do about to do or not to do the test, depending upon as a LMIC. But as a patient, do we need to have that information to me, I'll say most likely I do it where today many of the places we do it, that information is available where we have put in the system. This is not in the system at this moment. And one of the reason is the cost. Yeah.
See, I'm talking not about diagnosis itself. I'm talking more about systemic therapy.
Systemic therapy, it doesn't help you. This I agree. In adult sarcoma also today, except some of them, it doesn't help you in having a systemic therapy decision making. But if it helps me in prognosticating, there is some value there. And that value, we need to decide that, do we want to include in our information or not?
Right. So Darren, your input into this, if running a national molecular tumor board, how many are sarcomas which are not rhabdos, which are non-rhabdos soft tissue sarcomas, and how many you actually find that it was worth doing a molecular tumor board to actually identify some?
So great question. So sarcomas were heavily represented because of what you've said, that they did not have a response to systemic therapy. So therefore, if there wasn't good local control, they relapsed and they came to our national tumor board. And if I'm being honest, it was very few that had an actionable mutation that could actually be used as of today, either to identify them for a clinical trial or from compassionate access. So if you were really looking at resource, this may be a group where at the present time that wouldn't be done. Of course, the fact that they've got such poor survival means that you want more exploratory. But in terms of actually using it and actually being able to make recommendations, I'm afraid this would have been a group where we often had nothing to offer.
Nothing to offer. Great. Thanks. So I think that I would also recommend that a lot of people who are interested in precision oncology look at this ASCO educational book paper, which came out last year, which tells you what proportions of sarcoma cases had actionable mutations, but many of them were not, had druggable targets. So which was there. So it actually led to more distress to families who knew that there was something but could not have a target which was there. So and again, we discussed that in molecular tumor board, Darren highlighted, and so did Venkat and Kumar, that there are very few situations where you would change therapy in sarcomas, where in adults and young adults as well, that you actually found a druggable target and which you could give a drug for. Now, if you did find one.
Can I ask a question? So what were the percentages where you had those molecular positive for treatment being available?
So for us, it was around about 10%. This is across all pediatric tumor types. We had a separate leukemia program, so this is solid tumors, but it was about 10%. And I think that that's pretty consistent across all of the pediatric precision medicine. And it's not too different than adult precision medicine programs either.
So is 10% good enough or not? I think so. Maybe it will come out that, is it good enough or not in the clinic to do?
So for us, 10% wasn't good enough, and we've implemented it as standard of care because of those patients. But what I've said is that as we currently describe precision oncology, as in target A, drug A, patient A, 90% of pediatrics won't be covered. But what we need to do is actually identify those patients who can have dramatic responses, as you've seen. And then for the other 90%, we obviously need to do more research.
So just continuing on the discussion, both for Darren and to Kumar here, suppose you did find that there was target A and a drug A, but in that situation, in a non-rhabdo, say soft tissue sarcoma, would you combine chemotherapy with the target, or would you just try target on its own?
It's a good question. And I think, we know that usually one drug does not cure cancer. So but I have to say, the way we gained access usually was via an open trial. So we were governed by what we were allowed to give there. And even some of the compassionate access or off labels are somewhat limited because in pediatrics, there may not be that safety data to say it suggests that you can give this targeted agent with cytotoxic chemotherapy. So more often than not, they would have actually got a single agent for the personalized mutation that we found. And perhaps that's why the response rates were not as high. And certainly we're now moving to combining some of these targeted therapies with chemotherapy, but we're doing it in the context of clinical trials.
Right. Kumar, from adult side, ALK positive, say lung cancer, would you give chemotherapy in this one, or what would you do? No.
So, thankfully you took example where it is not so uncommon. It's uncommon, not so uncommon, and not only in palliative setting. Now you have a very good drug. In a curative setting, now you have an excellent drug, and if you do surgery of patient in today's time for lung cancer with ALK positive patient, you do give alectinib. It has got label hazard ratio is 0.2. That's the kind of benefit you receive, means 80%.
As a single agent.
As a single agent. So you have 80% reduction in the recurrence with these drugs. So I do agree with the comment that you have targets and targeted therapy. They have got different connotation in different situations. For example, again, taking from adult side, KRAS inhibitor have a targeted therapy. We are not so excited about it. But as I said, ALK inhibitor, you talk to any adult medical oncologist, they will say, somehow we need to give this tablet to the patient. In stage 4 tumor, you have a 5-year progression-free survival of 60%. Now we extrapolate, 5-year survival will be around 80% of these patients in today's time. And these patients had average survival of 8 or 10 months around 10 years back. Now, I gave 2 extreme examples. There are a lot in between. So it will depend upon which target we are talking about and which kind of targeted therapy. And then you say how keen you are that this treatment needs to be given to these patients as early as possible. Anti-RK is another very good example of that. You will like to see that you are able to give it. Now, in a very curative patient, think about ALL, where survival is around 95%. What more I can add? But in case I have a disease where the chance of recurrence is 40-50%, where you're going to get the data for a randomized trial in that setting, when in whole world the data will be of 40-50 patients, then you need to do some other ways to find out the value of the treatment in that setting. There was one very famous person who again works in that area called Dr. Razak, and she was putting some numbers, and it was very important that if you take these targets, therapies, and combinations, and she put in only 5-6 of them, and then say, hey, put permutation and combination, then for each of them you may end up doing almost few hundred randomized trials to prove that, and that will never happen. So if you have a drug which is very effective, again, I gave example, then think about you will be using that drug in different way as compared to targeted therapy. Now, sunitinib is also targeted therapy, but we are never so excited about it.
Thanks. So we went through 2 cases now. First one was actually chemo-responsive case, which did not respond, where molecular tumor board would have made a huge impact. And the second one we have discussed is the role in sarcomas, where there is no good systemic therapy, and you might have a modest role for using molecular therapy in that disease. So we also we discussed, Darren went through about, and so did Mamta, about the technique which needs to be discussed. So we'll skip that and we will not go there. But I had only one question for Mamta. When you say what is adequate testing, is IHC good enough if you get an NTR-Japan? Do we need to do a sequencing? If you get an ALK positive, do we need to do FISH or sequencing, or can you tell it's IHC is good enough? In what situations is it good enough, and what you would like further testing to be done?
For ALK, at least, I think we have a very good concordance with ALK IHC and ALK FISH and NGS assay. But for other fusions or other IHC, we definitely have to club or complement it with some molecular testing. Either you go for a FISH or a targeted panel that will give you much more confidence of the true positivity of that particular molecular marker. And because other markers are not very well established for the concordance rate with these ISCs and the molecular assays, so I'll definitely go ahead for the extensive molecular analysis in addition to the histopath assays.
Okay, so I'll move on to the next case. So this is a brain tumor case. So yeah, you want to add something? Yeah, please
do that. So this is regarding IHC and molecular profiling. I totally agree with her. Just adding a clinical part to it so that the clinicians, in case in the audience, see, we do have this notion that you do IHC first or FISH first and then do molecular testing first, and we end up thinking that we are saving money. Not really. I'll give you example. So what volume you do, it decides what's the cost. Now, if she does a good volume, and I know that she has a NextSeq 2000, I am aware of it, and she uses a P4 flow cell, the cost of the test, real cost of the test will be less than 10,000. I can give you a breakup for it. What it means, if you do fish, it will be costing 10,000 rupees today. If you do a single fish for patient. Now, how many times you will be doing it? But yes, you need to have optimization that in a center like TMH or center like Adyar, that you have that volume there, that you have a common panel which all goes there. Then this allows Dr. Mamta to see that you are able to get the report at the same cost, which as a clinician, we have a feeling, and believe me, that's a false feeling, that we do IHC multiple, then we do fish, and then we go to NGS. Not necessarily that may be cost effective. Am I right, Mamta?
Thanks, Kumar. So we'll move to the next case. So there's actually 1.5-year-old child presented with limping since 5 months. And there was a right-sided lesion in the brain, which was operated. And then that was a residue which was left behind. And what you saw was this was actually an infantile hemispheric glioma, NTRK positive on IHC. So now the question I want to bring here, the reason to bring it into a molecular tumor board would be different. So if it was a high-grade glioma in a bigger child, you would actually do radiotherapy. Now say, suppose this is a 1.5-year-old child who is not eligible to any further radiation. And this was the FISH testing which was done, which showed that it was NTRK3 positive. And then the question is, in a situation like this, where you have a young child, where you would not be able to deliver conventional modalities of therapy or multimodality therapy, what is the role of doing a molecular tumor board, and which brain tumors would you actually test for actionable targets? Ram, you want to go first, and then Venkat, would you agree? Okay.
So this is something which is a scenario which not exactly the similar case, but there are many such cases which come up in a joint clinic in a neuro-oncology setting. So the first group of tumors I can think of where molecular tumor board comes into picture is gliomas predominantly, and more so with the increasing amount of data which is coming in the pediatric low-grade gliomas. So the question of having this RAS-MAPK alterations in majority of the patients has kind of changing the paradigm of management of these tumors, which was to begin with for radiation and then chemo. Now it's more towards the targeted therapies. So in our own clinic, we do have this change which we have noticed. So BRAF and BRAF alterations account for predominant group of pediatric LGGs, and the entire pathway is also affected in many more patients, which also includes the NF1. Apart from that pediatric LGG, the other group where you have high-grade gliomas, especially the infantile hemispheric group, where you have alterations in NTRK, ROS1, ALK alterations, once again, they can delay the need for RT, and they give us another extra approach, what we can target these diseases to improve the disease progression to prevent it further. So apart from this, we do also talk about in other sets of tumors like embryonal tumors, ependymoma, about the molecular testing and a lot of debate. They may not directly contribute to the targeted therapy to put into practice right away, but they do help us in making decisions, prognostication, especially when there is poor response, when there is metastasis, when there is a recurrence in cases like medulloblastoma, also to step down on the treatment when it comes to radiation.
Venkat?
I'm talking about what we do in our routine practice, and the question is the target available easily? What is the cost? And if there is a compassionate program, is it available for children? Because if I have a result and I have to sit in front of the family and say, yeah, we detected a BRAF mutation, but the drug is going to cost 200,000 rupees. Now that leads to more distress. So it also depends on what kind of patient we are dealing with. For example, we had a patient who was treated in another hospital, and young child was detected to have mismatch repair gene. It's a brain tumor deficiency, and was advised PD-L1 treatment. It was very expensive, so they came to us, give us PD-L1. We didn't know what to do because it's still expensive, and the patient assistance program doesn't apply for pediatric patients. So you will not get 1+1 or 1+3. So we kind of ended up giving 1/5 of the dose based on the adult low dose chemo trials once in a month. So bringing down the cost from ₹1 million per year to about 100,000 rupees for the patient. So these are dilemmas I face. So it all depends on whether is there something which is reasonably priced in my patient population. If a well-affording patient, the sky is the limit.
Sure. So of course, so we'll come back to that straight after this, but I wanted to know what Darren's approach would be in these situations where you cannot give conventional treatment. Would you use this as a bridging therapy, and is there a role for molecular tumor board in these situations?
So, well, I think infant hemispheric glioma is one because, as Rams mentioned, when we did the trials that describe this, which actually we use methylation to base our classification on everybody, but we actually saw potentially targetable agents, ALK, NTRK, ROS1, etc. So certainly in infants, we felt it's been of great use. Having said that, at the moment, our current standard of care is actually multi-agent cytotoxic chemotherapy. But the CONNECT group, which I have already mentioned, we actually have 2 trials, one with larotrectinib and one with lorlatinib to cover all of the different entities. And that's up front. And the idea is that if you have one of these patients, they're treated with single agent molecular targeted therapy first. If they have a complete response and are in CR, they stay just on that treatment. If, however, they have a less than complete response, we're investigating it in combination with cytotoxic chemotherapy to see if it's better. So at the moment, I would agree that conventional therapy is kind of a bridging treatment, and certainly at relapse we use it. And I have to say my own experiences of dramatic responses in infant hemispheric glioma with both NTRK and with ALK using alectinib within trials of these patients. So I think it's likely this will move forward. But at the moment, we still use conventional treatment for them. Of course, though, I would argue, and I heard this yesterday, in a low and middle income setting, if you take the total cost and the total burden for a family of cytotoxic chemotherapy of everything that you actually do in supporting them with accommodation, it's an oral at-home treatment that's very effective surely starts to become attractive in the total burden of cost.
Absolutely. Thanks. So we'll come back to the patient perspective. The first one is I would like to come back to Venkat's point again. So the Venkat, which I was going to come to later, but we'll discuss it since this has come up. So how do you address, we have not looked at the patient perspective here. Once you do a test in a relapse refractory setting, the expectation, especially with many of our patients in India, is that this will throw up something which will cure my child. So that's the first thing. And we know from all the data which has been presented, 10%, 15% is the only case which is there. So that's the first one. The second thing is if you do find a druggable target, accessibility and affordability of the druggable target gives even more distress to them because you have now told them your child had this, but you're not actually going to do this. So I would like Venkat to comment and then Kumar to comment as well. How do you address this with the patients? What do you tell them in the beginning when you do this? And okay, we do a molecular tumor board. It's nice to do a molecular tumor board, but how much of the decision of the molecular tumor board is actually implementable? And that's what the context is. In a resource limited setting, how much weightage do you give for a molecular tumor board? Venkat, how would you address this? When you send off a test, what do you tell them? And what's your practice?
It's very difficult because from your academic side of the brain wants you to do the test and, offer hope. But then you have the practical side of the brain that who's going to pay for the test. And if you detect, you're going to tell the family to, pay from their pocket. To be frank, most of our patients, we don't do the test. That is the reality because we feel even more miserable that we found out something, they can't afford it and there is no government schemes to help them. We try to just give whatever is available in our setting, more chemotherapy or irradiation or try to send for surgery. Frankly, we don't do it. If money is not an issue, we would go ahead. I might sound barbaric, but that is what we are.
Pragmatic.
Yeah.
Kumar, you must be facing this situation every day, adult side. So,
first part, you mentioned a bit about molecular tumor board. I absolutely agree. I see some of the colleagues here who's part of molecular tumor board, then they'll vouch for it. It is very important. As much you think, I know ALK, and when you start listening from your group of colleagues, you learn many more things, what happens there. EGFR, which I thought, because I used to work on it, I thought, okay, I know things. And when you have this NGS profiling in a different way coming, better technology, you start finding, you say, hey, it is sensitive or not, and then you start your bioinformatics guy looking into it. Is it really a real mutation, or is it sensitive to treatment or not? So molecular tumor mode, very important. It is good to have it and good to be part of it if you don't have it, so that you keep learning from it. Now, second part of it, that how do we handle this part? What you said is right. I don't see Trupti here. If she's not, I said she causes a lot of distress to us. So every time, because there is 62 gene panel, for all 62, we don't have a treatment. And every time we get a report of 62 genes, treatment we have for EGFR, ALK, ROS. And trust me, for ALK and ROS also, the treatment cost is 80,000 rupees per month. That is the cheapest one is what we'll call crizotinib, or seratinib, that is around 40,000 rupees per month. So I have no doubt that that part is there. So a bit different from pediatric side. All get cured and distress is not there, but we get habituated to it. That's on the lighter side part of it. Now, I'll tell you the science part of it, why we need to do it, and why we need to learn to handle this so that patient benefits. These kind of things, how you are going to get access? One is you buy it. Another one, what Venkat said, you may have compassionate access to it. Another one, you have a trial going on. Now, this doesn't happen because you can't have the test today on and off. Today I won't do it, tomorrow I do it. It doesn't happen. Today compassionate access happened, so today I do it. And tomorrow access goes away, you stop it. But if you keep doing it, you will in between have these options available. And I'll give you one example for it, which we do it routinely, and we look for these. We have for ALK inhibitor, lorlatinib, when it came, it was not in the market. Because we were doing ALK, and again, we are thankful to pathology department, we had 40 patients who got free. You say 40 is not a big number, but you need to ask those 40 patients. So idea is that those 40 were important. They will be surviving, 5-year survival will be 80%. I can put a number to it. Our pediatric data suggests our 7-8-year survival is around 70%. So those patients are going to survive pretty long, and they will get free drug, because once the compassionate access starts, there is an issue regarding that, how you negotiate and see that they are able to get it. Clinical trial is on. Patient may go to Varanasi and take treatment, and it really happened. We had a MET positive patients, MET exon 14. We didn't have a trial running. Patient went to Varanasi and took it. That treatment cost 1.4 lakh rupees per month. But there they get free. He is able to travel by train and get it. And I see Pradhan sir here. And and there's a proud moment for them. They are doing far more these trials than which we are doing at this moment for pharma trial. So you have ways and means, but these ways and means are dependent upon the test you do. So I absolutely understand the issue, what the patient and caregiver goes through and what the doctors goes through. But I say that you need to deal with it in the broader interest of the patient finally benefiting with multiple options being available to them in the due course. And yes, many of them will not benefit. That also is true.
Yeah. No, I think you raised an important point that there would actually be a potential chance for patients to go on to multinational or pharma clinical trials. If you do have a molecular tumor board, well, you would be identifying that set of patients who would be eligible for those trials. And I think that would bring in probably the industry to partner more, because you got a molecular tumor board and you are having an infrastructure to do it and identify those patients, difficult patients who would otherwise not get those treatment. So I think we're in time, but I'll open up for few questions now from the audience. So audience, any questions? Yeah, go ahead.
Yeah, thanks for that. I think we've covered most of what we encounter usually from diagnostics to therapeutics, and how do we do it? So you talked about compassionate access, getting these things. I mean, you yourself have done a lot of work on treatment adaptations in Indian population. He has the landmark paper, you can say that it is where you have reduced and used a fixed low dose immunotherapy for many of the indications where you should have given, per body weight or a higher dose, thereby bringing down the cost. I think these are some things that should come up more and more, where we actually could adapt the treatment, not just replicate what has happened. I guess you would want to say a few words about that.
So what Badra is trying to say that, see, you have an opportunity for the dose the treatment is available. Is this the real dose or not? And we have a lot of debate that there is a way this treatment has been developed. So what we had done, this is for immunotherapy, and we did some work in targeted therapy. So immunotherapy dose, it was based on not, that was the biological effective dose. It was based on that where you have the maximum tolerated dose, because there was no maximum tolerated dose, so they fixed it somewhere. What we did, we used the data from phase 1 to get a maximum biological effective dose, and that dose was 1/10 of the dose. So rather than 240 milligram nivolumab, we used 20 milligram to prove that this 20 milligram in combination of chemotherapy is effective. And what it does, it brings the cost from 2 lakh rupees to 20,000. So many more patients can afford it. Similar work we did for osimertinib. We know that we give 80 milligram per day. So what we did, we used two methods. One, my friend, Dr. Amit Dutt, he worked and he did an animal study to see that if you give once in a week or less frequently, what happens? And looks like in animal study, it worked. So what we did in clinic, who can't afford the regular dose and they have a T790M mutation where this drug works very well. Again, it is also in Varanasi and at our place, both places we started giving infrequent dose. So rather than giving daily, give once on 4th day or one on 7th day. It looks like it works reasonably well, suggesting that this also gives you a chance to explore in the clinic and develop treatment for your patient using the drugs which is available, which are at far lesser cost and more patient can afford it. Badira, you wanted to one to come out.
Yes, this and yeah, that's true. So again, for us, as Dr. Girish already talked about, many of these targeted agents which are available cannot be scored, crushed, chewed. So the pharmacokinetics, how it works in children before, I mean, we know pediatric formulations are coming on the way, but it's going to take a longer time. Whether based on the pharmacokinetics, we again can increase the frequency, the dosing, whether it has to be a BD or whether it can we give it in 1 in 2 days, 3 days, does that work? Because we have seen in fibromatosis, even though the dose that they say is 150 mg per meter squared BD, and when we give it tapered without crushing sorafenib once in 2 days, sometimes they take once alternate day, it do bring about stable responses. So we need more studies on that way, and I guess or in that direction.
I'll comment on that. We did some work with Manjunath. Manjunath is so we did what we did was we have a head and neck. I did because I saw him, so because we worked with him. So we deal with head and neck cancer, not for all these drugs. So, but head and neck cancer, you have Ryle's tube and patient can't take these tablets, and we developed some tablets and combinations. So we were not certain it works or not. So what he did, we did a crushed and non-crushed and try to see what happens to drug level. Not crushing a tablet, please don't crush if you can take it otherwise. But if you crush and it leads to a severe decrease in the bioavailability of drug, it is a bit overrated. So as on date, we have done 3 or 4 drugs. We did it for methotrexate, we did it for erlotinib, we did it for pantoprazole. So looks like, if you don't, please crush and give it. So someone has done for capecitabine, that we didn't do it. Someone has done abroad. So it looks like it's a bit overrated. That doesn't mean I'm ever conveying that if you can take the tablet, you have to crush it. But if you're not able to take it, and I also totally agree with Badira and Girish that more work needs to be done for many more tablets to prove it. If you don't have solutions.
So I just wanted to ask Darren, because you did a pharmacokinetic based therapy, right?
We did, yeah.
So did you find the recommended dose of what was there on the label different from what you found on the pharmacokinetic? Did you give a lower dose or a higher dose, or what did you?
So firstly, we never reached a maximum tolerated dose because we used adult PK modeling. So actually, for trametinib and dabrafenib, we stopped before we actually got dose-limiting toxicities. When it actually eventually got labeled, in fact, it was simplified because what we actually found was, because the other problem with pediatrics is, they're from day 1 to 18. What we actually found was for dabrafenib, there should be a different dose theoretically if you're 12 or below, for trametinib 6 or below on body weight. actually, though, further data suggested that that probably wasn't actually making a difference and the dosage was simplified. But I think this is a really important point. And actually, I could really see where this could be an advantage for low and middle income countries to do what you've been saying, including in pediatrics. The FDA have now got Project Optimus, I think it's called, where essentially they want more schedules and more dosing to be done, because I think their feeling is that actually we're overdosing patients with these targeted agents. And of course, the side effects as well. So I think that this is a real potential actually that you're doing, but could be looked at in pediatrics, and possibly you could actually get some support from pharma to do it.
So for abiraterone, maybe in ASCO, if anyone interested, we have put 1/4 of the dose. You can see the abstract. This is a randomized trial we did, 250 milligram versus 1,000, and which we compared head to head because that was possible, and that data is interesting.
Gaurav?
Thanks. Actually, you already brought out a lot of the points which I was going to talk about. I was really glad you made the Kuzrock reference, because in the quote of hers, which I love, she says that the site-based classification of tumors is an accident of history. So if it's an ALK-mutated tumor, it doesn't matter whether it's lung cancer or ALK-mutated lymphoma, for example. Give the inhibitor and it's going to work. Same goes for BRAF across tumor sites, and my area is histiocytosis, and we look at that. What you did highlight was a very important thing. From what I've gathered, the burden is high enough. 10% is a big number. For those children where your outcomes are already poor, it's going to be critically important. There definitely seems to be a need that we should be going for universal testing. Definitely there's a need, and we should start moving in that direction. You have shown us how that if we get started, we can get the companies interested and start doing the trials. And we used to joke earlier that the adult oncologists are the ones who behave like children, new toy every week. They get a new drug, they don't like it, they want a new one. But you have actually done what we have been doing all along in pediatrics, and that is juggling around with doses and schedules and trying to get a better combination going. So I think we have a lot to learn from you. After getting started, the next important thing is when to stop the drug. Since most of these drugs have been tried as single agents, they are continued indefinitely or for very long periods. And that's the question in LMICs which we need to address. I think that working along with chemotherapy, using lower doses, lesser schedules, and along with some biomarkers which will tell us when we can stop the drug early might be the way to go, both for adult and hematolymphoid tumors. So just your thoughts on that from Agrev and from you.
Venkat, if you started, when would you like to stop a drug? Say in an adjuvant setting, I'll give two settings. One is an adjuvant setting, so the tumor is not there anymore. In adjuvant setting, you want to give. How long would you give, and what do you think would be a pragmatic way when would like to stop it?
Let's go back to the literature and see what's being done. I can't be.
Unfortunately, most of the time you won't find a strong literature to support this decision. See, in many of the adult tumors, correct me if I'm wrong, Kumar, it has been done in situation where it would continue till progression. So many of them. But suppose you had adjuvant, suppose you had an IMFT for which you gave an ALK inhibitor, did the surgery, now post-surgery, how long would you give it?
If the literature doesn't say, then go by the gut feeling as to how the patient has been. And I have about 3 or 4 patients on with relapsed ALCL on crizotinib. One patient's been going on for 10 years now. What happens is the patient herself stops taking the tablet and the tumor comes back within 3 days. And then she starts the tablet again, it disappears. So she's done it 2-3 times. Probably I'd go by 1 year or 2 years, but you have to be on close follow. I really don't have an answer to.
Ram, you wanted to add?
So I would like to add that we do face this kind of a challenge in 2 scenarios where we have high-risk patients, refractory patients, where we found a targetable mutation and we start like an example, like a patient of a relapsed neuroblastoma or high-risk neuroblastoma who did not respond well, and you have found there's an ALK mutation and you have started it. And that is where I guess we would be erring more towards continuing this therapy if it's working till the time of progression. Most of the times when we speak with people who do practice a lot of this therapy abroad also, this is where I guess we would continue giving the drug because it's a high-risk disease, a refractory disease, nothing else work until the time of progression if the finances are, of course, able to cope with that. The other critical question, I guess, is like tumors like low-grade glioma, where you have disease still in there, and you have treated the patient for a considerable amount of time, and you can't keep this going in your day-to-day practice. That's when we have to stop. That is more critical, and I guess that's where in those situations you stop and you need to closely monitor, which is what I guess would be practiced.
Yeah, I mean, I think it's very different if you've got a cancer where this is basically keeping the patient alive. Obviously, it probably doesn't make sense to stop it. But in the benign tumors, I think unfortunately the data isn't there. I actually wanted to do a randomized discontinuation study in pretty much all of the ones, but the pharmaceutical firms didn't want me to do it, which is basically we'd have treated to maximum response, and then after a period, we'd have randomized some patients to stop and some to continue and compare the difference to actually do this. And we would have done liquid biopsy, biomarkers, etc. But actually for those, I think you have to stop and then see what happens. Because at the moment, there are some patients where they don't relapse, although many do. And that means that those patients don't need to have the burden, the cost, etc. So I think in these more benign, lower grade lesions, actually stopping, usually after a period of, well, maximum response, which is probably 2 years, I think that's not unreasonable. And for some patients, that will be it. They won't need treatment. Others will progress, rebound, and then you might need to restart. So you need to know that you've got access to the drug. But ultimately, what we would rather do is cure patients rather than turn it into a chronic disease. But I'm not sure we're there for many of them yet.
That's why it's very important to publish real world data, even if it's one case, put it as a case series, because somebody in somewhere in the world, okay, they've done this. And I'd come again from the adult world, immune checkpoint inhibitors, nobody knew when to stop in metastatic disease. And somebody actually looked at the real world data and said, okay, at least give for 2 years, and then many of these patients ended up doing well. And that has given us some confidence that, okay, we can metastatic lung or breast, you can stop it 2 years, and then you can tell the patient that you might not need further treatment.
Great, thanks. Last word, Kumar, anything?
Yeah. So regarding stopping, we are slowly learning. Give you some examples. For example, there's a craniopharyngioma, BRAF mutation. They have given only 6 months, that NEGM paper. And if you see, majority patient don't relapse. So it looks like tumor to tumor, it also varies that which drug and where it works. This was 16 patients, if I remember correctly, and looks like tumor vanishes. Osimertinib given for 3 years, and alectinib given for 2 years. So that way the trial was done in adjuvant setting. It has been challenged that there was a drop. So the moment the osimertinib was stopped, there is a big drop in the survival progression-free survival curve. So it has been challenged that did we stop it early? So that has got a bit challenged, and we will see as the time goes by that was 3 years early, or giving beyond that may not be useful. So slowly we are learning. And yes, I agree, liquid biopsy is one technology we all can think about exploring, that good to stop somewhere in between. Right. CML taught us. CML was, imatinib, whole lot of people have got whole lot of trials stopping and giving again, and looks like, again, it is feasible to do it.
Yeah. Great. Thanks a lot. I think yeah, Nehal, I can't refuse you. Please go ahead.
Short comment. It is also critical to integrate with other disciplines like surgery and radiotherapy.
Of course. Yeah.
SBRT and other radiotherapy technologies have shown significant impact in metastatic disease.
So all patients of lung cancer, oligoprogressive disease, oligometastatic disease in RDMG goes to radiation oncologist. You can verify with Anil.
Thanks. I think we'll stop here. I think Maya had put 4 beeps for this, so I heard 4 times. So no, everybody got 2. So I think basically telling you better stop now. It's lunchtime. So thank you all. I think there are a few announcements to make. We will have the e-poster judgment happening tomorrow. We request all the poster presenters to be there at the tea break. If you don't finish in the tea break in the morning, we might spill it over to the lunch break as well. So between the tea and lunch break, we would like to judge the posters. And on Sunday, the last session will be the free paper presentation. Those who are selected, I think there are 6 or 7 abstracts who have been selected. And all the prizes will be given after that. So all the people have to stay till the end if you want to receive your prize. Otherwise, we keep the money with us. So we don't give it to you back. So thank you all, and please enjoy your lunch.
Check, 1, 2, testing. Hello, check, 1, 2.
इधर लगा, एक इधर लगा और वहां पर एक लगा रहा। पैसे आने जाने के लिए गैप में उधर खाली है ना, उधर ही लगा। लगा चिपका के लगा, चिपका के लगा बस। एक उसके बाजू में लगा अभी ये है ना, वो बीच में लगा, जिधर जागा है ना ऐसा, बैक के बाजू में, हाँ बैक के बाजू में राइट।
बाप रे, डॉक्टरांना जरा वेगळंच फील येते असेल इथे. हाईटची गरजच नाही मला. हाईट बास मला नाही पटवली.
So, time for the post-lunch sessions to begin. Welcome back, all of you, after lunch. I don't see too many people, but I'm sure in the next few minutes we'll have more in the audience. So, our next session, the third session for the day is related to immunotherapy in pediatric lymphomas and leukemias. As you know, the last few years, we have seen a phenomenal outcomes following immunotherapy, and many newer agents are coming each week and are being tried and published. So in the next few talks, we'll try to have a snapshot of what's happening all around, including some perspectives from India. So to chair these sessions, I would invite Professor Sangeeta Mudaliar. She is the head of pediatric hematology oncology services at B.J. Wadia Children's Hospital in Mumbai. Madam, please come to the stage. And Dr. Sachin Punathar, he's a professor and a senior BMT physician working at TMC Actrec, Navi Mumbai. So both of them will chair this session. This session will be followed by a Q&A section, followed by the tea break. So, Madam and Sachin, over to you. Thank you.
Good afternoon, everyone. Thank you, Dr. Girish, Dr. Maya, and the Tata team for inviting us to chair this session. So we'll start with the first session. I invite Dr. Hiroto Inaba from St. Jude's Children's Research Hospital to speak on principles of immunotherapy in pediatric leukemias.
Thank you very much. I'm going to talk about the first topic is immunotherapy in pediatric leukemia. This is my disclosure. So there are many kinds of immunotherapy available, but I'm going to talk about today is these last two, cellular therapy and monoclonal antibody therapies. There are many modalities of immunotherapy available. This is, for example, in the ALL. Some monoclonal antibody like daratumumab or rituximab, just going here, but okay. And then also bispecific antibodies such as blinatumomab. And then here, ADC, antibody drug conjugate, inotuzumab. And then many cell therapy, CAR T cells are available in the BLL. In this talk, I don't talk much about CAR T cell because I'm going to talk in a later session. So first, monoclonal antibody. And the first, this monoclonal antibody has a multiple function where effect, complement-dependent cytotoxicity after binding CD20, CD38, rituximab, daratumumab, complement comes here. And or effector cells, antibody-dependent cell-mediated cytotoxicity, or antibody-dependent cellular phagocytosis, or antibody cross-link, and then cause apoptosis in the leukemia cells. Now, one of the first example of effective antibody therapy was rituximab. And it is shown adult in the CD20 positive pH negative ALL. They gave quite a few rituximab, 16 to 18 doses of rituximab. They show better event-free survival and better cumulative incidence relapse for patients who got rituximab. And then cumulative incidence, this was not different. OS was better, not significant. Interestingly, in this study, they show few allergy to asparaginase, probably reduction of antibody against asparaginase by using rituximab. Then daratumumab was used for T-cell leukemia. T-cell relapse is very difficult to treat. But however, in the pediatric ALL, red showed overall response of 83%, and the AYA population 80% response, and about half of the pediatric patients have MRD negative, and many are able to go to transplant. Even T-cell relapse is very difficult, but they had acceptable survival of about 40% with 8.9-month median event-free survival by using daratumumab. So antibody therapy is effective in treating leukemia. Next, I'm going to talk about bispecific antibody. It is blinatumomab. As you know, blinatumomab have a CD3 binding site and a CD19 binding site, and then T cell come over here and then attack the leukemia cells. And then there are frontline back-to-back New England Journal papers showed efficacy of blinatumomab in the frontline, such as infant leukemia. Adding blinatumomab, something maybe gone, but adding a chemotherapy to blinatumomab showed efficacy, interferon 66% to overall survival increased to 93%. And then also, even NCI standard risk patients, overall cohort showed survival 96 versus 88%. Even average risk group, significant improvement outcome, as well as high risk of relapse patients. So blinatumomab is now become a standard practice in the USA to use B-cell leukemia. Most of the patients get blinatumomab in the frontline setting. Importantly, there are 19 relapse in blinatumomab arm, and then 9 bone marrow and 9 CNS, and 1 combined. Control arm has more relapses, and then 36 bone marrow and 10 isolated CNS relapse. From here, we can say that blinatumomab is a big molecule, therefore probably it's not effective much against about CNS relapses, but very effective in the bone marrow relapses. So, okay, so adverse effect of blinatumomab, it has I tried to show cytokine here, but the cytokine has, there's a cytokine release syndrome, and then onset day 2 to 5. And then the hypoxia, hypotension, tachycardia, tachypnea are seen. And then we use tocilizumab or steroid for that cytokine release syndrome. And then some neurotoxicity can be seen, immune effector cell associated neurotoxicity, and onset day 7 to 9. And then altered mental status, tremor, ataxia, seizure can be seen. We treat with dexamethasone and anti-epileptic, anti-seizure medications. And then Down syndrome is known to have a high risk of these toxicities, especially 10 years or higher. But now FDA is recommending all Down syndrome patients to receive anti-epileptic medications or prophylaxis before blinatumomab is given. So next, I move to other therapy, antibody drug conjugate, such as inotuzumab. Inotuzumab is a CD22 antibody, and this has a chemotherapy binded, the calicheamicin. After binding CD22, this antibody conjugate go to inside the cell, and they release chemotherapy called calicheamicin cause DNA damage. This is a T-cell independent. However, there's a unique cytotoxicity of the hepatotoxicity and the sinusoidal obstruction syndromes. This is a COG study showed that there are 48 patients, and then 19 plus 9, 28 patients, 58% went to CR or CRI, and among them, 2/3 are MRD negative. And they had, in a relapse setting, they had 29% EFS, 36% OS. And for those who are able to go to transplant or subsequent CAR T-cell therapy, because target is different, CD22 INO and then CD19 CAR T-cell, they had excellent EFS and OS. So inotuzumab was used for the bridge to transplant or CAR T-cell therapy. So I mentioned about antibody therapy, ADC, and then CAR T-cell, the AML. Let's talk about immunotherapy in the AML. There are many therapeutic modalities available. So far, by specific antibody against FLT3, CD33, CD123, or CAR T therapy against these kind of molecules are developed. So far, response is not great in the AML. I'm going to talk about later about this reason. And then now, monoclonal antibodies or ADCs are available, as well as some group are studying NK cells, especially memory NK cells. At this moment, as I said, bispecific antibody and the CAR T cell efficacy in the AML is very limited. So just talk about ADC in the AML. One great example is like inotuzumab, Myrotag, gemtuzumab, otogamycin. This is similar, CD33 is the target, and the antibody is conjugated to kariciamycin, and it is internalized and release the kariciamycin and kill the leukemia cells. And this was randomized study was done in COG, and COG showed overall survival was not significantly different, but event-free survival was better with the Myrotag compared to without Myrotag. This response is, dependent somewhat CD33 expression. They divided CD33 expression to quartile 1, quartile 2, quartile 3, quartile 4. And then for those, lower expression was more core binding factor, and the FLT3 ITD, which is a higher risk of AML, tend to have a more CD33 expression, which is maybe benefit because these are more difficult to treat. Similarly, low-risk AML had a lower expression of the CD33 compared to intermediate and high risk. So they divided CD33 expression quartile 1, low expression. There was no difference in the event-free survival or relapse risk. And then quartile 2 to 4, higher expression of CD33 had better event-free survival on relapse risk. And then they also subsequently found that KMT2A has high CD33 expression. And also SNP can predict the CD33 expression, and which were associated with a better outcomes. So CD33 expression probably important for the Myrotag efficacy. The other leukemia called CBFA2T3 GRIS2 AML, which was identified in St. Jude, and especially shown in infant and associated significantly worse outcome. This is a fusion of the two genes. And this leukemia is seen very young age, less than 3 years old, and then significantly associated worse outcome compared to negative, positive one, very bad outcome. Initially, it was identified in the M7, megakardioblastic leukemia patients. But even regardless M7, non-M7 or unknown FAB subtype, this gene fusion is associated with a worse outcome. And then it is identified that this fusion has a folate receptor 1 expression. It's very high expression. So now COG group or American group are testing this antibody called luberlutamib tazevibulin. I cannot explain very well, but this folate receptor antibody and also chemotherapy is conjugated, ADC, again ADC. This ADC is going internalized and release the chemotherapy and kill the leukemia. The called hemiasterlin derivative is conjugated, so release the chemotherapy and kill the leukemia. And then in this study, in this was outcome relapse refractory, it's very common to relapse this subtype. By using this ADC, they had a 41% MRD negative and then 6% MRD positive CR. So this is very difficult leukemia, but we are seeing some efficacy of the immunotherapy in this subtype of AML. So now, we have antibody therapy and then ADC available. Of course, cellular therapy is available. So how we use this method to the frontline therapy? Now we have, as I said, immunotherapy, and then previously we talked about molecular target therapy. And then these are eventually going to be frontline. We can dose reduce or remove conventional chemotherapy. This is a St. Jude data. We have seen dramatic improvement in the outcome of acute lymphoblastic leukemia with a survival of 94%. But if you look at very carefully, there's no improvement in the outcome in 2000 to 2017. Last 20 years, we are not seeing much improvement outcome. We are seeing that limitation in conventional chemotherapy. And then this chemotherapy is also associated with acute and long-term toxicities. We cannot ignore this. This is a great opportunity to use immunotherapy with a combined chemotherapy, hopefully reduce chemotherapy. And this is a great example tested in the 60 years old or higher and newly diagnosed Ph negative ALL by combining mini hyper CBD, very reduced intensity chemotherapy plus inotuzumab, and give blinatumomab. And then maintenance is just simple maintenance by blinatumomab. And their event-free survival increased to 34 to 64. Similarly, Ph positive leukemia, historically deadly disease. Now they are using so-called chemo-free, typical cytotoxic chemotherapy is removed, and by using initially steroid pre-treatment, after identifying Ph positive, the certain steroid was used, and then blinatumomab was added, and then outcome is very good, 75 DFS, OS 80%. So what Senju do now is high-risk B-cell leukemia, historically used vincristine, prednisone, asparaginase, daunorubicin, cyclo-RC6MP, but we are replacing with this new four-drug regimen, vincristine, dexamethasone, inotuzumab, blinatumomab. So we are reducing, hopefully, a lot of toxicities. And then childhood cancer, net survival is still in high-income countries, survival 80%, 20% population live, but low medium income country where 80% kids are live is still 30% outcome. And then Dr. Duffy is going to tell you about this, but we started blinatumomab humanitarian access program by collaborations and started India, Pakistan, and Vietnam. This is the first case, I think here maybe, treated in the blinatumomab. As a summary, target immunotherapy options are growing. Monoclonal antibody, bispecific antibody, as well as antibody drug conjugate and CAR T cells. ALL showed significant improvement outcome with the chemotherapy, but still a lot of toxicities. And then toxicity, intensive chemotherapy is raised to the limit. Immunotherapy, molecular target therapy can reduce or replace chemotherapy. And then this approach can be used in the global setting. Of course, cost is a big effect problem. AML still need a further improvement in outcome. But at this moment, effect of immunotherapy is limited other than ADC. And then further research is necessary for CAR T cell therapy and antibody therapy in the AML. That's the introduction. Thank you very much.
To invite Dr. Revati Raj from Apollo Hospital, Chennai, for a talk on antibody-based therapy in pediatric leukemias.
So good afternoon. Thank you so much for this opportunity to the Tata team. And I'm really grateful for the opportunity, other than the fact that you've sandwiched me between two talks of Dr. Inaba. So I'm a little bit nervous about what I'm going to say. The topic given to me is antibody-based therapy in pediatric leukemias. And my disclaimer is I'm not touching upon AML at all because the experience is very limited. Really nice theme, changing paradigms in the 21st century. And you can see how the whole field of pediatric leukemia has changed. And it gave me an opportunity to look at what I have personally done in my career. And we learn from different patients. So this is a child that we recently treated, 11-year-old boy who was diagnosed in December 2021, relapsed in 2023, ALL. We did reinduction, but there were 50% blasts. Nothing really worked except that he got bad neutropenic sepsis. we figured out he had PH-like ALL, so he had inotuzumab ponatinib. He responded well, but MRD was still positive. And then he had blinatumomab, he's MRD negative, and we're going to take him up for transplant. So these are stories where this child would have been palliative care only a few years ago, and now there is promise of hope. So I looked at what I have done from the early 2000 to 2010, because 2010 is when we had MRD introduced and PEG asparaginase introduced, and then 2020 to now. So what are the things in each decade, how we risk stratify, how we do optimal chemotherapy, supportive care, how are we doing our infrastructure training, and now what are we thinking about preventing late side effects. And I think, as the previous speaker had said, that antibody-based therapies really have made a big difference. And these are the lessons that we learned by looking at our own protocol. We use a UK ALL regimen. So the children go into standard risk and high risk, and they get a 3-drug induction, 4-drug induction. And we just looked at data from these 287 children because we now have follow-up up to 2025. So somehow majority of all our centers still have more boys than girls. 1/3 of them were good risk cytogenetics, but a third was negative for cytogenetics. And about a third, 74 children, were MRD positive. So they moved on to the higher regimen. And when they moved on to the higher regimen, did the escalation make a difference? Yes, it does make a difference. Those who continued on the same regimen, the relapse rates were higher than those who didn't continue on the same regimen. So this was an important lesson to learn. And when they relapsed, most of our relapses happened 6 to 18 months, between the 6 to 18 months, and mostly we had systemic or combined relapses. So we had done MRD at the end of induction, but for the TALL, our decision time point was at the end of consolidation. So this is what our disease-free survival looks like. And this is what you see from St. Jude's, 94% today. This is what we want to be. This is where we want to be, but we are not here yet because we are looking at 79, 80% disease-free survival in our cohort with this sort of risk stratification. So what is our current strategy to introduce precision testing, introduce immunotherapy, and what have we learned so far? So few of the studies that our team has done, the so-called good risk cytogenetics, not all of them are good risk. So if we go back and looked at the cytogenetics, the classical hyperdiploid, because a lot of our kids who relapse came from the hyperdiploid ALL. So why are they relapsing? So we went back and found that 39 out of these 139 good risk cytogenetics were actually non-classical hyperdiploid. And I'll tell you the definition soon. So if they had 1q duplication, 6q deletion, isochromosome 17q, isochromosome 7q, or TP53, then these are non-classical. So they actually should be under the higher risk regimen. So which is what we have done. And we also realized that the hypodiploid ALL, MLL, the KMT2A, IAM21, and 1719, and the PH and PH-like actually need a higher risk regimen, a little bit more than what we are giving, not just the high-dose methotrexate and the PEG asparaginase, a little bit more. And the TALLs, we were doing the oncogenetic classifier. If they had not, we were all right. But if they had ETP or RAS or PTEN, then they needed a little bit more approach. And here we are adding the nelarabine or bortezomib. So this is when blinatumomab came into our country. Initially, it was very difficult to procure and expensive, but the access got easier after 2022. So only the last 3 years, it has been easier. And we read that it was a very good bridge to transplant. So from 2022, any child who had relapsed ALL that we were going to take up for transplant, we've been using blina as a bridge to transplant because it made a huge difference to the remission rates. So this trial also showed that blinatumomab was good at refractory ALL. So this is what we've seen with our experience at the end of induction, end of consolidation, those pre-B ALL children who continued to have the residual blasts, they responded well to a cycle of blinatumomab. The outcomes of transplants were superior after the children received blina, and that was the result of the COG multi-center trial. For us, it's too early to assess this response because we've only used blinatumomab in a handful of children over the last 3 years, and it's too early to assess, but we are continuing to follow them up. And in isolated extramedullary relapses also, if they were late relapses, it made a difference and it gave longer remissions. So these are the lessons learned. And now people are talking about bringing blina to the forefront. Dr. Inaba also had alluded to this. So this is a 2021 paper. When we looked at it, around about 2022, what can we do for bringing blina to the forefront? And this is the paper actually as of this week. The 3-year risk of relapse. So these are whom we call standard risk. All of us know high-risk children need blina, but for the standard risk children, the ones who got blina, the risk of relapse was 3.3% versus the chemotherapy alone arm 11.8%. So I think in our country where treating relapses, the economic burden is high, giving one cycle or 2 cycles of blina upfront would actually reduce the burden if we select these children upfront correctly. We can't be giving for everyone, but the ones whom we truly think are going to be higher risk of relapse, we should be doing this cleverly. The infant ALL protocol, Interfant 06, added blinatumomab at the end of induction, and that's what we do in our practice. So all our infant ALLs at the end of induction get a cycle of blina. And so this blina upfront in infants is actually much better tolerated compared to the older children. So we now use blina in all of the children who are high risk, the 17, 19, the TCF, if they have RAS pathway genes, Downs, KMT2A, and infants, and the non-classical hyperdiploid, or those who've had MRD positive at the end of induction and consolidation. So blina, we have a way of delivering that the first 48 to 72 hours, we keep them as inpatient and they get blinatumomab as an IV infusion, after which we put them on a Baxter balloon pump. So they're doing ambulatory chemotherapy. So they come back to the unit and have it done to reduce bed charges. And upfront, they all have Jakavi because that reduces the rates of CRS. So along with steroids, they get this protocol. And most of our children, you can see, have been in the relapse group, and very few we are starting to use upfront. These numbers have gone up over the last 6 months. Coming to inotuzumab, this is again a very valuable drug, more tempting to use because it's outpatient. We don't need beds. We don't need to worry about CRS. So it's more tempting to use in children because it's easier to deliver. So because it's a weekly IV administration, which can be done in daycare. So this was also an equally good bridge to transplant as seen by the COG group. But what we found is it's very, very good drug to use in combination with ponatinib. When we've used inotuzumab on its own, it hasn't been that effective. So we are only using inotuzumab in combination with ponatinib for the pH positive and pH-like ALL children where the response is beautiful. So our trial had 10 children and 7 out of 10 were pH positive, 3 were pH-like, and the combination resulted in remission, MRD negativity in 9 out of 10. One other child, we could get into CR after cyclocytarabine, and they've had a transplant after which. The worry is, will it cause veno-occlusive disease or SOS? But we had a protocol when we transplanted these children from the day of admission. they were on continuous infusion of N-acetylcysteine, and none of our patients developed sinusoidal obstruction after they had their 12-gray total body radiotherapy. So the combination was well tolerated with 90% efficacy and really good safety profile. The platelets dip, the liver swells up on day 7, and then after that they recover. The last drug is daratumumab in TALL. So this we've used in refractory TALL, those who didn't go into remission in combination with cyclophosphamide and cytarabine. We obviously have to do the extended red cell phenotype, and we were able to induce remission and proceed to transplant in 3 of these children. The outcome didn't change. They all eventually relapsed. So again, we have to see where we have to use this drug more carefully. So our current protocols, if they are early relapse, they get the fludarabine, cytarabine, and then the blina before transplant. If they are late relapse, they get 4-drug induction, but still blina before their transplant. And if they are PH or PH-like, get inotuzumab and ponatinib. So this is where our transplant survival is at the moment, but hopefully, if we use all these monoclonal immunotherapy before transplant, we could see better outcomes for these children who really have lived to fight another day. The future, I think, will be a combination. So like the first child that you saw first will have inotuzumab and then blinatumomab, or probably with immune checkpoint inhibitors, because they are the 3rd group of drugs that we can add in these refractory children. So probably combinations, definitely not the higher doses of cytarabine or high-dose methotrexate. So the way we are going is probably more into immunotherapy. We have to have our own ways of delivering these drugs. We use 15 mics per kg and have our own institution protocol to reduce costs when they have these drugs. And we are only using a 2-week schedule rather than a 28-day schedule. And the pilot protocol has just now finished, so we'll register it as a trial and take it forward. So I want to end by placing my sincere thanks to all the children and their families. I think these are very expensive drugs, but if we say it makes a difference to their outcome, we have somehow managed to find resources to help try and improve outcomes. Although I must say, as Dr. Inaba had pointed out, in the CNS relapses, the use is very disappointing. None of these drugs work, so maybe we have to find a new drug that would help our CNS relapse children. All our nursing, PICU, and clinical pharmacists who helped us with the study, the physician team, and EBM 2025 for the opportunity. Thank you.
Dr. Hiroto Inaba to talk on cell-based therapies in pediatric leukemias.
Thank you again. Okay, so next I talk about cell-based therapy in the pediatric leukemias. This is my disclosure. I think 2004, about 20 years ago, St. Jude made this construct, CAR T cell with a 4-1BB co-stimulatory molecules. And instead of CD28, Dr. Campana and Imai made this 4-1BB intracellular domain. This showed a very excellent cytotoxicity against the B-ALL cells. This technology went to CAR T cells. Now we use a very successful CAR T cell, done multiple studies in Eliana, St. Jude Hopkins experience, and then real world CIBMTR. And then the same construct was approved by FDA as a Kymriah. EFS is about 50%, but considering these are very difficult to treat, it's significant improvement. Of course, we need a more improvement. When we talk about immunotherapy, historical risk factors, high risk, intermediate, favor risk in the chemotherapy may not be relevant anymore because the CAR T cells are effective regardless of the chemotherapy defined risk factors. As well as CAR T cell maybe work very well for the CNS or testicular disease, although some limitation known, but if effective, we are able to eliminate radiation by using CAR T cell therapy, at least for B cell leukemia. Some limitations, again, I said, in the CNS relapses because of maybe microenvironment is different. So survival of 50%, we need to improve this CAR T cell. A couple issues. We need to increase availability, and then limited persistence need to be improved, as well as non-response and relapse should be improved. I talked to Dr. Gorov yesterday. He's developing very, low cost and then product here actually. Always, limitation is the cost, and then authorized sites, lack of starting materials, and successful manufacture. But I heard his very successful program in here, and maybe he's gonna talk after me. And then, we may, at this moment, second relapse indication, but we can, move ahead to first relapse or extramedullary relapse. We don't know yet, but the frontline therapy, maybe we can bring it frontline. And then other issues, maybe, we are using autologous. Some people are interested in allogeneic CAR T, and then product manipulation, T cell selection, cytokine, gene editing. I just talk about autologous and allogeneic CAR T cell therapy first. We take from the T cell from the patient and then put the CAR T cell and expand and infuse back to the patient. This is what we do for autologous. But some patient has lymphopenia and T cell may be exhausted, or it takes time to produce CAR T cell, at least 2 to 4 weeks. Allogeneic T cell is slightly different. T cell getting from healthy donor, and then we have to some gene editing. CAR T cell, on top of CAR T cell, some remove HLA barriers, but we can keep it freeze and then storage, and then when patient need it, this CAR T cell can be given. As I said, gene editing necessary on top of the CAR T cell receptor, CD52 to make resistant to lymphodepletion, and also reduce reactivity so down-regulate T cell receptor, and then to prevent rejection, MSC molecules should be removed. And also some group remove PD-1 to remove the checkpoint inhibition to promote persistence. One study from UCART19 that's knocked out TCR alpha and CD52, and then expansion is slightly limited, but 3 out of 17 expanded beyond day 42. And GVHD was concern, but only 2 of the 20 patients developed GVHD. And CR/CRI was 14 of 21, and then 6 months progression-free survival 27%. And the other group also using this allogeneic CAR T cell approach by using stem cell transplant donor. After transplant, using same donor for the CAR T cell. And the Italian group showed that many are able to achieve another remission, and then some need a transplant and then arrive. And then some groups, including Japanese group, trying to make iPS cells to make a CAR T cell for the allogeneic. And in St. Jude, we are using memory CAR T cell by removing CD45RA naive cells, and then make a CAR T cells, which should not cause a GVHD in the memory cells. These studies are ongoing. So now, T cell can be, CAR T cell has limited persistence. And to avoid rejection, CHOP and other group using humanized product, and then adjust the pre-CAR T cell therapy by using fludarabine PK and adjusting these doses. And then, it is important to intervene early to check the B-cell aplasia and the NGS-MRD to see the responses. And then to promote B-cell aplasia, episodic antigen exposure by, for example, giving APCs or use of immune checkpoint inhibitors and then product manipulation or persistence. I'm going to show these blue examples. So NGS on day 28 is very important. If NGS positive on day 28, event-free survival, overall survival is not great. And also B-cell aplasia, especially early B-cell aplasia, 3 months, 6 months, these are not good event-free survival. So some clinical trials ongoing internationally, after CAR T-cell, no further therapy is given if NGS negative and the B-cell aplasia seen at 6 months and just monitor without doing transplant. These studies are ongoing. In St. Jude, we are trying to manipulate T cells. In the naive T cell, has effector genes are methylated and stem genes are not methylated. And then some all the terminal effector cell going to apoptosis is the opposite. Effector genes not methylated, stem genes methylated. Some T cells are exhausted. These are both effector stem genes are methylated. Important cells are functional memory. These are no methylation in either genes, as well as the multipotent progenitors. So in St. Jude, we are trying to knock down the DNMT3A, which is DNA methyltransferase 3A. So by knocking down, and then this survival expansion continue with the antigen stimulation by knockout, and then better, leukemia control. So we are developing DNMT3A knockout CAR T cell with a bispecific antibody CD19, CD22. The other problem in the CAR T cell is non-response and relapse. Sometimes no response, antigen loss, down modulation, linear switch happens. So many groups are doing dual antigen targeting and also new targets. And then method to increase antigen expression. And also, decrease leukemia burden high is not good. And previous failure to treatment blinatumomab is associated with outcome in the CAR T cells. And then we don't know who need a transplant, who don't need a transplant. This is very important to find out this making criteria. To target the multiple antigen, this is an example of CD19, CD22. You can use two different CAR T cell, you can infuse against CD19, CD22, or bisystronic, one cell express two receptors or tandem. There are many ways to target two antigens. In Chinese study led by Dr. Pui, showed that event-free survival about 70%, overall 87%. It's very good to have two CAR T cell infusion, independent. And then in this study, event-free survival better when a transplant was followed after CAR T cell. Overall survival was not significant. And then they showed that activity in the CNS and testicular relapse, again, they go to the extramedullary areas and can control leukemia. And then this is the NCI group showed that bistronic CD19, CD22, so tandem binding sites, and then 4-1BB. And then they had 12 or 20 CR, MRD negative CR. And then after transplant, many are alive, and they are showing a fantastic result. Also, UK showed that similar result with bispecific CAR T cells recently. We have very success for the B cell. What about other leukemia? T cell can be a problem because T cell, CAR T cell can attack other CAR T cells because they express a target usually, if you try to target T cells, called fratricide, kill each other. Sometimes kill the normal cells can cause a T cell aplasia, like a skid. And then, this receptor may be contaminated in the leukemia cells, and leukemia may grow. So these are concerns. So commonly, T cell, CD7 is most T cell leukemias expressed. So CD7 can be targeted. And then there's several ways to overcome this fratricide. And down-regulated CD7, UK group and others shown gene editing to knock out CD7. Other groups show the CD7 to retain the intercellularly, or just expand it, select only CD7 negative population, or Senju is trying to do initially select the CD7 population, then expand it. There are many ways to do it. I showed the example from Singapore which show the CD7 4-1BB, CD3 zeta CAR T cell. Otherwise, this cause each other, but they added anti-CD7 protein expression blocker to keep the CD7 molecule to the ER golded, so no CD7 expressed. And then by using these CAR T cells, CD7, a lot of leukemia cells before, but many went to MRD negative, mostly after transplant and alive. This is the one success story of the CAR T cell against CAR T cell against the T cell leukemia. CAR T cell against AML still some limitation, except some efficacy in the NK cells. Then why is it the AML slightly difficult? Is normal the AML antigen is very similar, and then also AML antigen can escape. And also CAR T cell against AML can target hematopoietic stem cells and can cause not only leukemia cells and cause cytokine release syndrome, hemophagocytic symptoms, or hematopoietic problems, stem cells killed. And also microenvironment, bone marrow stromas produce some suppressive cytokine, therefore CAR T cell activities suppressed. There are many challenges in CAR T, so we need a lot of research for to improve the efficacy in CAR T. Lastly, I want to talk about patient had a transplant after CAR T. Seems like better outcome compared to not going to transplant. But if we can prevent transplant, that's better for the patient considering long-term outcome. Should we use CAR T cell for bridge to transplant? There are many factors we consider. We have to have patient factors, ongoing comorbidities, or patient preferences, or disease pre-infusion, high disease burden, probably difficult to control CAR T cell only, or prior response to Brenner might be important. Now, maybe not important, but still high risk genetics, like a 1719 just showed. This one, we still have concern if only CAR T cell, we are not sure we can cure. Always we have nervous about, we have a historical chemotherapy risk factors. And then post infusion, we have to follow NGS MRD, B-cell aplasia, and then or co-stimulatory molecules, CD28 or 4-1BB. A lot of research needed. Who need a transplant? Who don't need a transplant? I think new biomarker necessary. As I said, we have just research ongoing, NGS MRD negative, and then B-cell aplasia persist 6 months beyond. Maybe they are trying to watch it. As a summary, so CAR T cell therapy brought a curable option in refractory and relapsed B-cell leukemia. And then optimization of CAR T cell therapy is necessary in a cost, source, autologous, allogeneic. I mean, mostly autologous is more practical, but allogeneic might be in the future. And then dual or multiple antigen targeting might be, overcome some resistance, and product manipulation to improve the persistence. And also cross monitoring necessary to MRD, B-cell aplasia, and new biomarkers. And then we need the harmonizations. Who should get transplant, who should not? We don't have that answer yet. And then now T-cell, against T-cell, CAR T-cell is developed, but the AML still need an improvement. So development of CAR T-cell other than B-cell leukemia is important. Thank you very much.
Thank you, Dr. Hiroto, for both your talks. I would now like to invite Dr. Gaurav for his talk on post-CAR T cell strategies in relapsed refractory BALL.
Thank you, and thank you for that great talk, Hiroto. Actually, you made my task very easy because I think most of my what I have to talk about has been covered, except that maybe we'll try to use the same data in context with what we need to do. So I will be speaking upon post-CAR T cell strategies in relapsed refractory BALL, and whether the very questions which Hiroto raised, which are not yet answered, I will give you our thoughts on that based upon our needs, our context, and what we have experienced so far. So this, of course, is again a chart which everybody is familiar with in this room. But I show it again only to highlight two things, that in India and as in most LMICs, our outcomes hover around the 70 to 80% mark. And also to highlight what Hirota has already highlighted, that by 95% outcomes have already been achieved in North America and in the developed world. But this is also in the pre-CAR T era. So this is in the pre-CAR T, pre-immunotherapy era, but till 2009, we already have 95% outcomes. So while the West looks to bridge the gap from 95 to 100, our challenge is to bridge the gap from 70 to 80 to 100. So this is a big jump that we need to make, and we can only do it by making a quantum jump and not by not in increments. This data showed our outcome when I just joined TMH. We took patients who had started treatment in 2010, about 330 of them, and it showed that it was around the same mark. And with the measures that we put in place, we found some improvement over the last decade. But when we tried to analyze our relapsed refractory patients, we saw that the outcomes were very, very poor. Now, this is despite having one of the longest transplant programs in the country, because bone marrow transplant in India was started in this center 4 decades ago. What we realized is that transplant may be there, and for those who get it, it might be a great option, but the fact is that most patients are still not able to get it. So there was a dire need for alternatives. Now look at the relapsed refractory. Why is it such a big challenge? Now, this is how we traditionally classify relapsed refractory BALL, but extramedullary and for combined or isolated bone marrow, and whether they are early or late. Based on that, we classify them as intermediate, low, or high risk relapses. And when you classify them according to the time from relapse, we find that those who relapse very early do poorly, and those who relapse later do slightly better. But what has happened over the years, that the high-risk relapses, we have known that this sort of stratifies. The late extramedullary relapses, you can get good outcomes with chemotherapy alone. And in the very high-risk ones, you get less than 5% outcomes with chemotherapy alone, and you can improve it to about 30-40% with transplant. But the intermediate risk ones are the ones where you can have about 40% outcomes and improve to about 60% with transplant. And this is where things have stood for decades. This analysis tells you that the black lines show you the trials which were done early, that means in the late part of the last century, and the gray lines are the trials which were done in the earlier part of this century. And depending upon whether these were early, intermediate, or late risk, late relapses, the outcomes have remained the same. So that means that this is to highlight the point that the available therapies, chemotherapy and transplant, have not managed to budge this line. So in this context, we look at where we stand with CAR-T and what we're going to do next. These are the approved therapies, and you've already heard about them in the previous three talks, so we will not be touching on them. I will be focusing on the available CAR-T cell therapies for children and young adults, and what we can do with them. As of now, in this age group, we have only Tisagenlecleucel, Kymriah, which is approved for children and young adults. And in India, we had the recent Talicaptogene autoleucel, which was developed between a collaboration between TNC and IIT Bombay, and now is being marketed by ImmunoAct as NextCar19. It has already been approved for patients with relapsed refractory BALL above 15 years of age. The pediatric trials below 15 years of age is still enrolling. We are hoping for approval this year. And then we will really be faced with a prospect of what to do, which is the topic of this talk. There are some country-specific approvals, which are in Israel, Spain, China, and Singapore. Some of us send our patients there. Some of us manage to import from there to give our patients. But this is the current status of what is happening in India. I don't think anybody has used Kymriah inside Indian borders at all so far. So what are the outcomes? Hirota has already told you the outcomes have stabilized around 50%, and these are the long-term outcomes for Eliana, which is for Kymriah. The updated results at 3 years. It has seemed to have stabilized around the 50% mark. And even those who do seem to have some events, the overall survival is still better at around 60%, and it has stabilized over this. So what we saw in Eliana at the end of 12 to 16 months when it got approval, this has held true down the line, more or less. I'd also like to highlight that all CAR-Ts are not the same. So when we talk about post-CAR-T strategies, we need to also factor in which one we have given, and each one behaves slightly differently. We talk about CAR-T as one group of products, but actually there are several different products. This just highlights to you the 3 available ones in North America, and Talicel, which is the one available over here, that they are all similar in many respects, but they are all different in many different respects. For example, Talicel has got a fully humanized antibody domain, not a nearly fully humanized antibody domain, SFP domain, while the other three have got the murine domain, and there may be some bit of similarity or dissimilarities between the rest of them in the other domains. Coming to the experience that we have with Taliso, because that's the one which is being used here, and the Emanil product is still to be approved for leukemia, so we are still awaiting that, and this talk is related to BALL. We took heavily pre-treated patients with very poor cytogenetics, some with two prior allogenic transplants with high disease burden, and these were the kind of patients which were there in our trial so far. We had a very good safety profile with no grade 4 or grade 5 toxicities at all, and only one grade 3 toxicity at CRS in the first 12 patients, which was the dose-finding study, and only one CNS neurotoxicity event amongst the whole cohort. Coming to the efficacy, these are the outcomes that we see in the swimmer plot. As you can see, these are the patients, lower group, who received less than 3 million per kg dose. This was a dose escalation study. The next was 3 to 5 million per kg. And finally, we went to a dose of 10 to 15 million per kg, out of which we did not exceed the 10 million per kg dose. At the lower dose levels, patients had either partial or responses, or those who had complete response lost their response. But once we crossed 3 million per kg, we started having durable and long-term responses. And at this dose level, between 5 and closer to 10 million per kg, we have all complete responses extending beyond 1 year. So this is where it stands. Only 2 patients needed further chemotherapy. 3 patients needed further chemotherapy, 2 for loss of B-cell aplasia and 1 for rising MRD. And these are the patients. One of them is still doing well, but the others have this another long-term outcome. But beyond this, he has now recently relapsed, but he's gone into a second remission. And this is one more patient who had relapsed for nearly a year and a half after the transplant. So what are the key determinants of impending loss of response? Now, this has already been covered for you, so I'll just quickly go through it. Some of pre-infusion factors, high-risk phenotypes, which are prone to antigenic shift, like MLL rearranged. They may be expressing CD19, but it varies over time, and they're not going to respond to a CD19 targeted therapy. High tumor burden at the time of infusion is something which has been consistently seen across trials, and we've also seen, and I'll show you that data in a bit. Extramedullary disease, apart from CNS, does not seem to respond very well to CAR-T. So we heard Blinner, CNS does not respond, and CAR-T, CNS can respond, though it's mostly excluded from trials for the fear for toxicity, but other extramedullary sites do not respond. Prior antigenic pressure of the same directed therapy, and this is something which we'll see as blinatumomab moves up into the front line, that time following it up with the CD19 CAR-T, we might have more CD19 negative relapses. So these are all factors which we need to take into consideration about how we're going to manage these patients later. Infusion-related factors are related to the CAR-T product and related to persistence, which are more in the area of research and into the hands of the manufacturer, really. So I will not go into them now. And post-infusion, the 2 most factors which have been determined are the loss of B-cell aplasia and low-level MRD. So just coming to that, this is the data to show you that pre-infusion burden matters. So patients who have, they should make all efforts to bring down the disease burden. We did in our trial, but in those patients in whom the disease burden did not come down prior to their infusion, this is the pre-infusion MRD, they all had responses except this one. They all had responses, but these responses were partial and they were temporary. Only those in whom the disease burden came down at least 1 to 2 logs before their infusion are the ones who had deep and enduring responses, out of which only 1 subsequently lost a response. So bringing the disease burden down seems to be a very important thing for CAR-T. One should not rush to CAR-T. We wait for months to put a patient to transplant, trying to get them into remission. So we should do the same for CAR-T. We don't need a remission, but definitely low burden disease is going to help a lot. In the T-cell long-term follow-up, we saw that B-cell recovery matters. And the other study, which I was also, Dr. Hiroto showed you, also I'm going to be referring to shortly, but this clearly showed you that once B-cell recovery starts before 6 months, these patients tend to do badly, and the longer it takes to recover, the better they do. This is the data saved by the Pershipper et al. Study with 143 patients who had received Tizacel. You saw that timing of B-cell recovery, this is beyond 12 months, no recovery at all. This is the one which stabilized over time at 60%, but anything before 12 months, they relapsed early. It's almost like a clear predictor of relapse. And NGS-MRD is highly predictive of relapse. This is also now clear. This data shows you that NGS-MRD at the level of 10 to the power minus 6 and below and above has this cumulative incidence of relapse, which can easily be predicted by the level of any level of MRD. And we are talking, mind you, about disease which may be flow negative but positive on NGS. And this showed that very clearly over here. This was the EFS and OS in panel A and B. You can see for NGS MRD, which is positive or negative at the level of 10 to the power minus 6. And the C and D show you at any level, when the same data, when you look at it, any level, and you remove the 10 to the power minus 6 level from it, you can drive a truck through these curves. It's that predictive of relapse. So how do we approach what to do next after CAR-T? That's the million-dollar question. This is a review which was published by Nirali Shah from NCI in How I Treat, because like Hiroto told you, the evidence is lacking, and this is an evidence-based meeting. So we should be talking about evidence, but it's lacking. So this is what she proposed as an algorithm, which I find most sensible and most people around the world will follow. Those patients who are very high risk for and have an event-free survival of less than 10 to 30% are those who have not responded to a prior CD19-directed therapy and have more than 5% blast pre-infusion. Others are MLL rearranged, KMT2 rearranged, CD19 dim expression, and non-CNS extramedullary disease. Now, these patients, if they go into a remission, you must consider a post-infusion transplant as per the current evidence which is there. So probably the transplant workup should start simultaneously. For those, for the rest, for this group, you can, and for those in whom it's not feasible, you can do post-infusion monitoring, follow the NGS MRD if it's available, or you can follow the flow cytometric MRD if it's not, and you can do molecular monitoring where it is available, like for a target like BCR-ABL in that case, and do the monitoring for B-cell aplasia. Now, this monitoring can help you to decide those who are losing their loss of B cells are recovering before 6 months should definitely be considered for definitive therapy thereafter. And these are the options which we can use over there. And in those in whom it remains as negative, maybe you can continue the monitoring. This is a group which is likely to do very well. These are the ones who are likely to have the 50% and higher long-term outcome. Those who have less than 5% blast pre-infusion and no other risk factors, these can be monitored safely with this and put on to taken up for a transplant only if this comes up. But if we have to take everybody up for transplant, that doesn't answer the questions that we wanted to in the first place over here in our country. And therefore, we must look at alternatives. Now, this is very interesting data, which from Sarah Gorashian and from the UK, where they took patients. It's not a randomized trial, though that's being attempted now, where they took patients and looked at patients who could have gone for a transplant but did not or could not, and were put on oral maintenance therapy. So this surprisingly showed no difference between the patients who underwent a subsequent transplant and who underwent only oral therapy, maintenance therapy, 6-MP MTX along with a VCR pulse regimen, like they gave with the UKLL. And this had almost similar outcomes. Now, this is very interesting. And frankly, we had the same idea when we went into CAR-T. Dr. Benavdi, who was a proponent of oral metronervic therapy, and we have sort of learned under him. This was our idea that after CAR-T, rather than go for a transplant, let's try oral metronomic therapy, especially for those who are going to be losing the responses. Not to forget that there are other things which you must look at. They are not necessarily in the domain of molecular science, but they do make common sense. Avoid deterioration of host factors. Prevent cachexia. Look after the diet. Improve performance status. Patients who have had multiple lines of ineffective chemotherapy, don't do this. If the chemotherapy is not working, we should take a for CAR-T early. The CAR-T is more likely to succeed, and these are the ones which we'll observe. Also, this is avoid high tumor burden, like I said, and these are probably more in the domain of further research. So this is the algorithm that we sort of think would work. Like Hiroto told you, there's no evidence, so we are sort of feeling our way through how we are going to approach this. High-risk relapses, which are early or very early veterinary, which are not in CR after the salvage induction. Very high-risk cytogenetics, like 17, 19, etc. Any post-allo transplant relapse, any allogenic transplant not feasible for any reason, any third line and beyond, we would go straight for CAR-T. And for post-CAR-T, we would prefer to do an allo transplant if no prior transplant, or if NGS MRD is positive at any time. If this is not feasible, then observe with oral maintenance if B-cell aplasia is lost less than 6 months. For intermediate and low-risk relapses, we would explore chemotherapy with transplant or chemotherapy blinatumomab, which is available to us through the assistance program. followed by transplant if they go into remission, if it's possible, or I know followed by transplant. We would consider CAR-T, these are not working, and post-CAR-T, we would observe and use oral maintenance if there's a loss of B-cell aplasia within 6 to 12 months. For refractory BLL, which is post-consolidation, at least one more salvage line of CAR-T, followed by allogeneic transplant, and then followed by, if no allogeneic transplant possible, then we would go for this. With that, I thank you for your attention, and I'm fortunate and grateful to work with a great bunch of people in the Pediatric Oncology Department, TMH, and we take questions at the end. Yes, thank you.
Our next speaker is Dr. Nirmalya Roy Maulik. He will be speaking on current status and unmet needs in India about immunotherapy.
Yeah, so I think it's too much to ask for a post-lunch session. So I would just request everybody to just stretch so you can get up in your seats for a minute.
We take a few questions, maybe that.
No, questions. You can also stand.
Yeah, that's what.
Okay, please stand. Hands up. Oh my God. Okay, down. Some sideways, and then you can sit. Okay. Over to you, Nirmalya.
Good, Chetan. I thought that I'll get a sleeping audience, but then you have deprived me from that.
I apologize. I apologize.
Okay, thanks. So I must thank the organizing team, especially Dr. Maya and Dr. Girish, for this opportunity. So I'll be talking on the Indian perspective of immunotherapy in pediatric cancers. So, slide. This will do it, right? Okay. So yeah, immunotherapy in pediatric cancer, the Indian scenario is my topic. So, I mean, needless to again introduce immunotherapy in pediatric cancer. You've heard from the experts about this. But what I wanted to highlight is that cost issues and issues with access remain, especially in the LMICs. And this will be a part of, I mean, the major part of my discussion in this talk. So quite a few immunotherapeutic agents have now shown tremendous impact in the outcomes of pediatric cancers. The commoner being, in the case of B-cell ALL, as discussed by Hiroto and Dr. Gaurav, neuroblastomas, anti-GD2 antibodies, and in the setting of lymphomas, we have the checkpoint inhibitors, which are also being evaluated and also have shown remarkable response in relapsed disease. However, from India, we don't have much data on immunotherapy, and no major trials on any of the immunotherapeutic agents have been published till date, to my knowledge. I'll cover these immunotherapeutic agents one by one to start again with CAR T cells, as you have heard two talks on CAR T cells. So we now have clear-cut evidence that CAR T cells improve outcome in pediatric B-cell ALL particularly, and there are specific indications now as standard of care by different agencies like the FDA and the EMA about CAR T cell use. And collaboration between IIT Bombay and TMC. We have homegrown CAR T, which has put India in the global CAR T cell map. We have two more players that have come recently, one based in Bangalore and one based in New Delhi, who are also producing CAR T cells. This write-up in Nature Biotechnology pegs the market size for CAR T cells in India to 20,000 to 40,000 per year, which is a big market size. Unfortunately, we have not been able to match the market size yet. We have only 3 small-scale trials that are, either already on or about to start in India, starting with this TMC IIT Bombay trial, which has completed, its phase 1, and the phase 2 has also commenced in 5 sites. We have the Imagine trial from using a CAR T cell, which has been primarily made in Spain, but we have got manufacturing license in India by the Immunil group. They have also completed their phase 1 with 10 children included in the trial, and they are planning to expand their cohort. The expanded cohort accrual is going to open soon. We have another trial that will start in CMC Vellore soon using the CAR T cells that are going to get manufactured in Delhi, and also some CAR T cells through imported technologies. However, as Dr. Gaurav has mentioned, only one CAR T cell is approved for commercial license in India. for 15-year-old and above is the ImmunoAct card, which is priced at 40 lakhs per patient, excluding the supportive care costs. More players, as you saw, are coming in the field, and we hope that the cost will also get a bit better, favorable to the patient because of more competitive pricing. However, the important question that remains is that is CAR T-cell a standalone therapy as of today? If not, if a BMT has to happen post CAR T-cells, the cost just doubles. Coming to monoclonal antibodies, you have seen a lot of data from Hiroto on blinatumomab and inotuzumab. There is no doubt that these are effective, both in the setting of relapsed refractory disease, and blina has now been shown to be effective in frontline, and there are trials which are going on using inotuzumab in frontline ALL as well, and hasn't been reported yet. Now, regarding clinical trials from India, no trial on blina has ever happened in the Indian soil. But if you see the CTRI website, there are 2 trials on inotuzumab that show up when you put inotuzumab as a search criteria. One of them as early as 2011 on adult lymphomas, which has been terminated. But there is another ongoing trial, it seems. I couldn't find any more information on this. But this tries inotuzumab at dose level 2 for both adults and children with ALL. So, trials aside, we have some publication on sequential use of inotuzumab and blinatumomab from our next door neighbor, Wadia Children's Hospital, who have published 19 patients who received a sequential strategy of using INO and blina in the setting of high-risk relapsed ALL, and the outcomes are quite encouraging. So what is the availability and costing of INO and blina in this country? So INO is available. It's available in TMC pharmacy as well. One course of 3 doses cost about 5 lakhs. 3 doses included. Blina access is more difficult. You have to import it on a named patient basis. 2 cycles for a 30-kilo child would cost about 30 lakhs. However, we are fortunate to be a part of the BHAP program that has come into place for the last 3 or 4 years and has supported quite a few of our patients, as well as 2 other sites in India and a few other in other in this part of the world. So based on this BHAP program, because we had blina available as well as the phase 1 CAR T-cell trial also started in our institute, we thought of including immunotherapy as a part of our relapsed ALL strategy. And that we did both for the low-risk relapses in case their in the MRD post-salvage induction was positive, and for all patients who were high-risk relapse to start with. And to assess the impact, actually, we did a audit, which was done in the early part of 2024 and was submitted as an abstract to a conference. And in that audit, we showed that of all the patients who were eligible for these novel therapies, including CAR T-cells and blina/inotuzumab, we could offer these things only to 10% of the eligible patients, which shows a huge unmet gap of 90% in these patients, despite the fact that we were very liberal with the indications. We would only probably nominate patients at a very high risk of relapse to these agents. Despite that, our unmet gap remains 90%. Sorry, there's something here. And it's not a surprise that the outcome of patients who ended up receiving blina and INO/plus-minus transplant would do much better as compared to patients who did not receive. Now, briefly touching on checkpoint inhibitors, recently we have seen a lot of evidence on these, especially in relapsed refractory lymphomas and some solid tumors. There is some encouraging data coming in from the adult side as well as pediatric studies as well in the frontline setting. It's freely available in India for clinical use. However, cost remains a concern. So nivolumab costs about 1 lakh per dose for a 30-kilo child. Pembrolizumab costs very similar to it, and for a 30-kilo child. However, as you heard in the morning from Dr. Kumar Prabhash during the panel discussion, that we have devised fixed low dose strategy to do cost cutting in this, but without compromising on the outcomes. I think the following speaker, Dr. Sham, will also touch upon checkpoint inhibitors in the field of lymphomas. Anti-GD2 antibodies, another important thing that I alluded to initially, has clearly improved the survival of high-risk neuroblastoma. Coming to our TMH experience, thanks to Dr. Ram Mohan, I got this slide. So we have been able to offer dinutuximab beta to only 9 patients out of close to 200 patients that were eligible for dinutuximab. However, I mean, the last analysis shows that the patients who received blina are doing much better as compared to patients who were treated with chemotherapy-only approach. Dinutuximab, again, no ongoing clinical trials in India. It's imported on a named patient basis. Costs about 55 lakhs for the recommended 5 courses for a 10-kilo child. So, but despite all these constraints, we do hear from our colleagues in various forums, including conferences and webinars, that immunotherapy is also being used, sort of in various centers. I mean, not in a very organized way or not in the form of clinical trials, but on a per patient basis. But then there is no data from India at all. So we plan to do a survey on pediatric cancer immunotherapy from, including 55 INFOC centers, thanks to Dr. Ramandeep, who coordinated this effort. A questionnaire with 22 questions were circulated that covered awareness, perceptions, practice, and hurdles of using immunotherapy. And we got nearly 76% response to this survey. And I'll just take you through the highlights of the results of this survey. So more than 95% of the respondents do treat relapsed refractory disease in their centers, but less than 60% of them say that, more than 60% of them say that they use immunotherapy rarely. So treating relapsed refractory disease more commonly without immunotherapy is the norm in our country. Coming to the salient points that came from this survey, monoclonal antibodies were the most commonly used immunotherapies used by the respondents who had made a positive response saying that they used immunotherapy. Usage of CAR T cells were quite limited to only 10%. And to my surprise, and which is actually not surprising, that more than 75% of the centers would access immunotherapy through funding that was solely borne by the patient and patient family. And dinutuximab, which is standard of care for high-risk neuroblastoma, was used by only less than 20% of the respondents when they managed high-risk neuroblastomas. So when they would discuss diagnostic, when they would discuss diagnosis with a new patient, only less than 20% would mention about immunotherapy to those families. The number would rise to 75% when they would discuss diagnosis of relapse or refractory disease. However, that doesn't mean that 75% of these patients will end up getting immunotherapy, because as you saw, the access is much more limited. So when it came, there was a question which said that if access was universal, which disease would you treat with immunotherapy? In the frontline setting, neuroblastoma was the preferred disease, and in the relapsed refractory setting, it was ALL. And most of the respondents agreed that cost remains the biggest hurdle in the use of immunotherapy. And more than 80% of the respondents say that government subsidy and local manufacturing / generics would be the most valuable solutions to this. More than 80% of the respondents said that they would be interested in participating in a trial which has immunotherapy as a component of it. However, more than 50% were skeptic about the future of immunotherapy in this country, given the issues with access and cost. So the main conclusions from the survey was that use of immunotherapy in our country is really limited. The limiting factors, anyone's guess, it's cost and also availability. You can't really get immunotherapy overnight in the country because some of them have to be imported, and there are long paperwork and processes involved in getting that. However, there is a remarkable interest regarding immunotherapy among practicing oncologists in this country. So what is the way forward? We need more generic versions. We need to facilitate access of immunotherapy through participation in clinical trials and international collaboration like BHAP. Also, if there are more players, we do expect some degree of cost cutting. And finally, we need to continue to advocate for government support for immunotherapy. I think I'll end with this. Thank you.
Malia. I would like to invite Dr. Shyam for his talk on role of immunotherapy and combination strategies in pediatric lymphomas.
Yeah, a very good evening, I suppose, to everybody. This would probably be the last talk in session of this session. I'll try to stick to my timing. So I think we have discussed a good amount of all these things. We have spoken about antibody and antibody-like therapies, the adoptive therapies, which include CAR T cell therapies. And what we have not dwelled much into are immune checkpoint inhibitors, because these are not something which are commonly used in leukemias. Um, so this talk is predominantly on lymphomas. I would discuss on Hodgkin's and also briefly touch upon non-Hodgkin's, especially the B cell. When you think of immunotherapy in Hodgkin's, the first drug which we want to, or the group of drugs we want to talk about, are the checkpoint inhibitors. As we all know, the Reed-Sternberg cells, because it carries a 9p amplification, this causes an increased expression on PDL1 on the surface of the Reed-Sternberg cells. In addition to this, the inflammatory milieu which surrounds the cells makes this particular tumor a good candidate for checkpoint inhibitors. And the first group of checkpoint inhibitors I would want to talk about are the PDL1, which is nivolumab. So these are the two pivotal publications which happened in NEJM and Lancet Oncology in 2015-16. This was, of course, in the relapse refractory setting, as all of us know that all these agents are first tried in the relapse refractory setting. And this led to the accelerated approval in 2016. The dose recommended from both these studies was a 3 milligram per kg per dose. Of course, they were tried as a single agent, and had to be given 2 weekly. However, these were the response rate. Though the overall response rate was good, a number of patients achieving CR was not great, and it was 9 to 17%. So this brings to the second part of this. How can we improve the complete remission rate when we use checkpoint inhibitors? Again, this is in the relapse refractory setting. So there are two ways to do this. One is to use it sequentially. That is, you try checkpoint inhibitors initially, see who are the patients who are responding. If they respond well and good, continue that. If they don't respond, you add chemotherapy to it. So the first study, what they did, they used single agent nivolumab, and patients, if they were not responding to nivolumab, they added bendamustine to it. And the CR rate and ORR rate, which you are seeing, is for patients who are initially refractory to nivolumab. Similarly, in the subsequent study, nivolumab was initially given, and the CR rate was 70% alone. And those who did not respond when they added chemotherapy, in this case it was ICE, there was an additional 20% improvement in CR rate. So this is one way of doing it. Try immune checkpoint inhibitors, and if the response is not great, add chemotherapy. Alternatively, combine chemotherapy with checkpoint inhibitors. And if when that was done, the CR rates were phenomenal, as high as 95%. So checkpoint with chemotherapy improves the remission rate considerably in relapse refractory Hodgkin's lymphoma. So the next point of discussion would be the dosing of immune checkpoint inhibitors. So as you can see in this huge list of, the table here, there are several malignancies and there are several ongoing, phase 2, phase 3 studies which are exploring much lower doses or probably increasing the frequency. I mean, in the sense, instead of a 2 weekly regimen, exploring 3 to 4 weekly regimen. So these are the studies, and this is data from India. Of course, we did discuss about the low dose study in the head and neck cancer, which got published a couple of years back from our center. Other than that, there are several other studies which are exploring the low dose checkpoint inhibitors. So this was a study done by the CMC team. Of course, this was in adults, relapse refractory Hodgkin's lymphoma, where they used the fixed dose nivolumab. So based on all this, this is data from Tata Memorial Center. Of course, this not only includes our hospital, but also the centers Varanasi and Mulanpur. So in the last 3 years, we had around 18 patients with relapsed refractory Hodgkin's, and we used a fixed dose of nivolumab. So the dose was 40 milligram, and this was combined with bendamustine, and patient received it on day 1 and day 15 of every cycle. So most of the patients received it as a second line. That is, the median previous line was just 1. And a good number of patients, as one would expect, were stage 4 at the time of relapse. Though the recommended dose is 3 milligram per kg, by using the fixed dose, we were probably able to deliver a much lower dose. And the response rate after a median of 2 cycles of nivolumab and bendamustine was 93%. The follow-up of these patients is not long. The median follow-up is just 1 year, and the progression-free survival was 88%, and the overall survival of this cohort was 95%. So in relapsed refractory Hodgkin's, a combination of chemo and low-dose immune checkpoint inhibitors do work. So what about immune checkpoint inhibitors in the frontline setting? Again, this was one of the recent publication. This study randomized patients receiving nivolumab and brentuximab with the chemotherapy backbone of AVD. This was a study which included both adult and pediatric patients, and the pediatric cohort was more than 12 years of age. And about 1/4 of the patients who were enrolled in the study were children. As you can see, the nivolumab arm in combination with AVD did better in this study. Another thing to be noted here, that less than 1% of the patients received radiotherapy. And just to highlight, this study was restricted to patients with stage 3, stage 4 disease, which would traditionally fall into the high-risk subgroup in the pediatric classification of Hodgkin's. And based on the previous data, roughly 30 to 50% of these patients would have received radiation if treated with conventional chemotherapy alone. So this was a major thing. So when nivolumab or immunotherapy got incorporated into chemotherapy, less number of patients would receive radiation, but still the outcomes could be maintained. However, one of the downside to this study was to try this agents in an AVD backbone, which is not the standard backbone used in children, which resulted in a slightly higher dose of anthracycline cumulatively delivered to these patients. Yeah, so the next thing I want to briefly touch upon is CTLA-4 inhibitors. These are not very commonly used in the pediatric setting. However, how the mechanism of action of PD-1 inhibitors and CTLA-4 are quite different. For example, PD-L1 predominantly acts much in the later phase, and they act in the peripheral tissues. And however, CTLA-4 would act much earlier during the priming phase. Because of this, they increase the clonal diversity, and they also have an effect on Treg functioning. Because of all these properties, they can also move into T cells, move the T cells into cold tumors, which PD-L1 cannot do. This may not have much role probably in Hodgkin's. However, this is being exploited, and combination therapy of PD-L1 and CTLA-4 inhibitors are being explored in other pediatric malignancies, predominantly solid tumors. The next drug which I would like to touch upon is brentuximab in Hodgkin's. So it is an antibody drug conjugate which directed against anti-CD30, and it is bound to auristatin E, which acts on the tubulin. The initial studies were again on relapsed refractory setting with a decent response rate, and this drug was approved for FDA approved in 2011, both for Hodgkin's and ALCL. So in previously untreated setting, that is newly diagnosed, brentuximab, when combined with chemotherapy, this was a phase 3 randomized controlled trial done by the COG group, showed that brentux, when combined with chemo, showed an outcome as high as 92%. So this is a little contrast to the previous study which combined Brentux with AVD, which had an outcome of only 82%. One thing to note here is the chemo backbone is much more intensive in this study because it was a pediatric alone study. And also roughly 40% of the patients also received radiation therapy in this study. The other study was the single-arm study by the St. Jude group. They used it in the European backbone, which was OIPA-COPDEC, and again, the outcomes are 97%. So both these studies were conducted in high-risk subset. So between immune checkpoint inhibitors and brentuximab, which is better in Hodgkin's lymphoma, as I told you, the phase 3 study showed nivolumab to be better, but the chemo backbone was not that strong for a pediatric study. And in the relapse refractory, there are no randomized studies in children. These are data from adults, but pembrolizumab was compared with Brentux, and pembrolizumab fared better. The other setting where brentuximab has been tried, this was the phase 3 Athira study, which randomized patients post autologous BMT between brentuximab and placebo. And in this study, brentuximab fared much better. But a couple of points to be noted here. Patients need not have achieved CR to receive a transplant. If you go back and look at the data, around 50 to 60% of the patient had PR or even SD, a stable disease. So they did have some disease post-transplant as well. So one could not truly call this as maintenance. Probably they were receiving brentuximab as a treatment in this study. So this is how things have changed in Hodgkin's lymphoma. Immunotherapy and targeted antibody drug conjugates have come into the front line. They have also come into the salvage part. Probably we are too early to say that we can get away from not doing a transplant, but that is being explored in several of the studies currently. So that is where we are. So briefly on non-Hodgkin's lymphoma, the familial drug, which all of us know, the rituximab, the Interruptus was probably the pivotal study. This was the transatlantic study, which in a phase 3 randomized manner looked into the efficacy of 6 doses of rituximab in high-risk Burkitt's lymphoma. All of us know this was a success study, and there was almost a 10% jump in event-free and overall survival. Following this study, rituximab became the standard of care in high-risk Burkitt's lymphoma. But more and more groups have also incorporated rituximab in the lower risk disease. And even in FOG, there is this ongoing study which is reducing the chemo intensity dose and giving rituximab. So this drug, based on this study, was approved in 2021. However, in the relapse refractory Burkitt's, things are not that great. Most of the international cooperative groups report an outcome of 20 to 30%. And I suppose in India, the outcomes are far, far lesser. So there are several options in relapse refractory Burkitt's. Let me just briefly go through them. I would probably struggle to pronounce the drug names, so I would just go to the mechanism of action here. So there are second generation or type 2 anti-CD20 monoclonal antibodies. So these are probably would work better in rituximab resistant cases. And this has been tried in adult high-grade B NHL. However, the toxicity rates have been high, and I'm not sure whether even in adults are exploring this drug anymore, and there are no pediatric data. The next drug would be an anti-CD90 antibody conjugate. So this was again combined with a microtubule inhibitor. There are data in adult DLBCL, and this has shown to work probably slightly better when compared to rituximab. And this is the radical study is an ongoing study where patients are combined, and that is rituximab with LMB, and this particular agent is added to the LMB chemotherapy backbone. So the next 3 drugs is probably what we need to look for in the next 4 to 5 years. These are BiTE. So these BiTEs act on CD20 and the T cells. there is a lot of data from our adult counterparts, which they have used in aggressive non-Hodgkin's lymphoma. They are either used as single agent or they are combined with these drugs. And these have slightly different mechanism of actions. But overall, even in a relapse refractory setting, the CR rates seem to be promising, and there are ongoing studies in children. No early data available yet. We did see several presentations on CAR-T. The outcomes in ALL and relapse refractory have been great. However, the same cannot be said in the high-grade BNHL setting. There are several reasons to this. In fact, to combat all these things, there are alternate studies which are in the pipeline, but no major published studies which shows a great improvement in outcome with the use of CAR-T cell therapy yet. So this would be the summary and what are the options we would probably have available for childhood lymphomas as of today. Thank you.
It was an excellent series of talk, and thank you all the speakers for keeping the time. We'll have a question answer session for 15 minutes. So I'll start with the question first for Dr. Hiroto and Dr. Revati Raj. You spoke about blinatumab in infants. What is your this one like about after giving blinatumab? Would you give the full dose chemotherapy to them, or reduce the chemotherapy dose, or how do you go about the further chemotherapy?
So we follow the interferon 06 protocol. So whatever there is in the protocol, they get that plus blina. This way we are reducing relapses, because they'll do well initially, 2 years later they relapse. So we have to wait and see with time. With the international trial, they have shown that they're doing better. So hopefully our infants also will do better. We haven't used it in any settings where there are some children we can't give any chemo, because whatever you give, they fall apart. If can we use blina in that setting, we still don't have trials that show that it's feasible to do that.
Okay.
But for infants, we're not reducing the doses.
Okay. And how often do you follow up with the MRDs?
Only as per protocol, they get one at the end of induction. Then at the after blina, they get their consolidation, and at that time there is one. And if they're positive, at the end of marma again.
Thank you. Is the practice same at St. Jude's as well?
Yeah, at this moment, St. Jude's same, but the randomized study now ongoing to reduce the post-induction intensity, because post-induction marma is very intensive, still high dose RC, high dose MTX. I think this part is going to be reduced by giving 1 or 2 doses of blinatumomab. That I think need to be studied, but this is probably the direction to reduce the chemotherapy.
Any other questions from the audience? Yes.
So we heard a lot about how for relapse ALL, relapse B-ALL, how for CNS disease, the immunotherapy doesn't work. So if you had a B-ALL with testicular relapse as well, what would you do?
I really hate the radiation. So, if you practice, common treatment is radiation to the CNS and testicle, which decrease IQ, or which lose the fertility. In St. Jude, for the first relapse of CNS and testicular, we use CAR-T cell. And hopefully, testicular number is small because we don't see much CNS relapse and testicular relapse. Testicular relapses, we see good response. We can avoid radiation. But the CNS is still, the CAR-T cell penetration may be small, or target of the B cell in the CNS is very low. So, as published in the European group, still CNS is not, great. Still, there are some relapses seen, but we try CAR-T cell first.
Patient doesn't have CAR-T access, then you prefer radiation or orchiectomy?
If no access, of course, radiation is a common practice, definitely. And then based on the timing, 18 months for the isolated. and 36 months of the bone marrow is a cutoff whether to use transplant or not.
So this is just a generic question for any of the speakers, whether Dr. Naba or Dr. Gaurav, if he's still around, or anybody else. Why are the generic names for CAR T cells and BiTEs made so long and unpronounceable? I mean, I assume there's a committee in FDA, et cetera, which sits and looks at these. But I can honestly tell you, I cannot pronounce half the molecules, but I do know the brand name. So is this all a plot by the pharmacy companies to encourage us to use the brand name? Go ahead, Gaurav. I have no idea.
So there's a nomenclature system for them, just like it is for the monoclonal antibodies, like for rituximab and others. There's a nomenclature system in place. Yeah. So blinatumomab is B lineage anti-tumor murine antibody. Am I right? By lineage, sorry, not B. So CAR T cell is like, so it same goes for the TISA, gen is genetic, LEC is leukocyte, and Lucell. So that's how the nomenclature goes. In fact, when this one, NextCar19 was being named, they had initially kept the name Actelicaptogene. But Actelicaptogene like Lucell, but that had to be but when they follow the WHO nomenclature, they were advised to rename it to Tally. Tally is there because that's what they wanted to keep as the first name. The Tally Cap, that is antibody, the gene, genetically modified, leukocyte, G-cell. So that's the nomenclature system makes the names complicated. Manufacturers just try to put some vowels in so that you can get a pronounceable name. Am I right, Hiroto?
No, I totally agree with you. I'm not English native. I cannot pronounce any of the names, so I totally agree. I think there's a rule to make this kind of or something. I forget how the rule is, but based on the, I agree, totally agree.
So one question regarding the dose of a blinatumomab. If you see this NEGM paper, they used a 15 microgram per meter square of blinatumomab continuous infusion for 28 days. In relapse refractory cases, they start with the 8 microgram per meter square, whatever the dose. So dose is different, duration is different. For our setup, is there any alternative dose which is actually feasible for our patient where the fund is the issue actually? So any comment on that?
Yeah, it's a very important question actually. So we're using 28 days, but there's a study that at the end of the 2 weeks, rather 2 weeks, T cell may be exhausted. Maybe not, maybe in vitro study at least, it doesn't make a difference. So there's an opinion that maybe how many days is enough? Maybe 14 days makes the price half. And then, those, I think maybe at this moment, we know that, sub-Q blinatumomab is under, study now, which is much easier for any country to give, high income, low, medium income country. It doesn't matter. Sub-Q is much easy. There's no MTD. So we can go higher. But at this moment, this dose is very effective, but duration maybe can be modified. But this need a very, randomized studies needed because already established 28 days. That's a very important question. How to decrease the price of the immunotherapy is very critical. So I agree with you. It's possible to decrease the duration by study. Actually, I have to be very conservative about this.
We are using the 2-week regimen as because the Chinese papers have clearly shown that after 2 weeks there is T cell exhaustion. So we are only using the 2-week schedule, and if they have frank relapse or high blast count, then 8, and if they are MRD disease, then 15 microgram.
I have a question for Dr. Reddy. In patients whom you have used immunotherapy earlier, other than with inotuzumab having challenges of SOS during transplant, any other peculiar or specific issues that came up during transplant?
No, I don't think any of these increase the risk of infection or anything. So the transplant protocol is just the same, whether they are haplo, mud, or sibling allo.
One more question was that, is there any role of immunotherapy post-HSCT?
So there, I don't think we have used in any setup, but I don't have any experience.
This is a very great question. Actually, it is maybe benefit. This need a study ongoing, but post-transplant Brina, for example, this use donor T cells, right? So maybe, this may be more effective after post-transplant. Maybe, patient T cell may be exhausted and using, T cell. Sometimes T cell infusion can be done too. T cell infusion plus Brina after transplant, donor T cell infusion. And this study is ongoing, Haplo transplant, we did it actually. So the result is not there yet, but this is a very possible effective treatment.
Anything in Hodgkin immunotherapy post ASCT? I think Sham was you.
Yeah. So I did show the Athira trial. So they did try brentuximab, and that is now their post-transplant Hodgkin's. Okay. But there are several reported studies. I mean, I couldn't put that. Both nivolumab and pembrolizumab are being explored. So yes, there is good amount of data there for us to explore post-transplant immunotherapy.
Thank you.
This brings us to the end of this session 3. I thank the chairpersons for chairing the session, and we're up for a tea break now.
Okay. Very good evening, everyone. Um, so last session of the day, and I can see some people are trickling in. So I think without any delay, we'll start the session. So on the podium, I would like to call upon the two chairpersons for this session, Dr. Sridhar Repari, who's Professor, Department of Pathology, ACTRIC, TMC, and Dr. Purva Kanvande, who is the Consultant Pediatric Hemat-Oncology at Wadia Children's Hospital.
Good evening, everyone. So we'll start with the next session, and our speaker for today will be Dr. Shakil Modak. He's a pediatric hemato-oncologist at Memorial Sloan Kettering Cancer Center in New York. His topic will be immunotherapy in pediatric solid tumors, current evidence and future scope. So please.
Not sure if I'm tall enough, but can you hear me, right? I'd like to thank the organizers for inviting me. It's always a pleasure. I grew up in Bombay, and so it's always a homecoming for me. And Tata folks have been always very interactive, and it's a pleasure to work with them. So since this is evidence-based conference, I'm only going to talk about published data and or data that has been in the public domain at least, and try to give you an overview of immunotherapy for pediatric solid tumors. So these are my disclosures. And today I'll be talking about target antigens for immunotherapy, effectors for immunotherapy. I'm not going to talk about checkpoint inhibitors, which are not useful drugs in, at least we don't know whether they're useful. So far, the data doesn't point to their being useful. I'm not going to touch on allogeneic transplants. Focus on clinical evidence and mostly on responses and not on toxicity of phase 1 trials. Anti-GD2 antibodies in neuroblastoma are the most common, most widely used immunotherapies. So most of my talk will be on that, which will include antibodies, immune cells, vaccines. Another target recently has been B7H3, so I'm going to touch upon that. Try to complete coverage of other antigens, and then where things are going in the future. So whenever we look at immunotherapy, we need an antigen, and to select an antigen is a pure tumor antigen is difficult because most tumor antigens also have cross-reactivity with normal tissues. An ideal tumor antigen should be able to elicit immune responses. It should be associated with an oncogenic process. It should be very specific, and truly there doesn't exist such an antigen. But there are antigens that we can use with a good therapeutic index. In pediatrics, we are hamstrung because we don't have neoantigens. Our tumors don't arise because of carcinogenic activity, but because of an embryological process, essentially. So we don't have the luxury that my adult colleagues have of tumors expressing neoantigens, and therefore immune checkpoint inhibitors for solid tumors have thus far not been effective. But some pediatric tumor antigens are targetable. This is a list of rather old list from the NCI, looking at what antigens can be considered for immunotherapy. And as you can see, there are antigens in pediatrics which could be appropriate, including GD2. So tumor antigens can either be expressed on the cell surface, or in the case of oncofetal antigens, they are intracellular antigens which are then presented on antigen or tumor cells, which can be picked up by the various immune effectors. So we do consider both intracellular and cellular antigens. Having said that, the repertoire of antigens that pediatric immunotherapies can target is relatively limited. Then we look at what are the effectors that we can use to effect an immunotherapy. So those can broadly be defined, divided into innate immune therapy and adaptive immune therapy. So in the innate immune system, we can make use of macrophages, granulocytes, complement system, and NK cells. So these are our innate immunity. And the way we can harness these components is using antibodies, which then bind to receptors in neutrophils, macrophages, and NK cells. These are the FC receptors. And they also can deposit complement, which can enhance all these parts of the immune system. But if we want to develop long-lasting immunity, we have to make use of the adaptive immune system. And thus far, until recently, that has been a challenge. But over the last 10 years, we've been able to generate CAR T cells, bispecific antibodies, and even vaccines against targets on pediatric cancer. And this is facilitated because over the last 20 years, protein engineering has become cheaper, more accessible, and you can design antibody constructs even in silico, that is on a computer, and then decide which construct you want to make, and you can make that construct relatively cheaply. For example, you can make an antibody that can bind both to CD3 and to GD2, and you can make various permutations of this antibody. For example, this is antibody that has 2+2 binding. This is what we would call a bispecific engager, such as blinatumomab. This is an antibody that we've made in our group, which has another 2+2 binding, two binding sites to GD2 and 2 to CD3. The point I'm trying to make here is that because antibody protein engineering has become much more efficient than it used to be before, we can be very creative, and we can make various constructs. And indeed, we have made various constructs which allow better or varied approaches to immunotherapy. So now we come to the first target, which is GD2. GD2 is an attractive target. It's attractive because there's a plethora of molecules on neuroblastoma. It persists on cell surface, that it's not easily shed. There is very little free antigen, so the problem of circulating antibody antigen complexes doesn't arise. It's very homogeneous, and there is a case for it to be thought about in other solid tumors. Now, the thing about GD2, one possible negative aspect is that we don't know what its function is. So it's not an oncogenic antigen with oncogenic function. So targeting GD2 is essentially targeting the scaffolding of the cell. In summary, there are 3 antibodies that have been approved by regulatory agencies in Europe and in the US. And there are, one of them belongs to a 3F8 family, that is the antigen binding sites resemble the mouse antibody 3F8, which was first used at MSK. And the humanized version of this antibody is naxitamab, which has been approved for chemo-resistant and chemo-responsive disease. The other two approved antibodies are dinutuximab, which is based on a murine antibody called 14G2A. And dinutuximab is a chimeric antibody with about 70% homology to human IgG and 30% to mouse. And this antibody was made in a cell line called SP20 and in another cell line, which is the CHO cell line. So dinutuximab was made in SP20 and dinutuximab beta in the CHO cell line. So their FV sites are almost identical, but because they are made in different cell lines, some characteristics might be different. Now, when we look at anti-GD2 antibodies, in a test tube, they have varying killing mechanisms and varying properties. So for example, mouse antibody is 3F8, is an extremely potent complement activator. So it uses the complement killing systems very efficiently, whereas the naxitamab, the humanized version, has less complement activating properties. Whereas dinutuximab has good ADCC, but far less complement activity. So in a test tube, when we parse out the various effector arms, you will see some sort of different activity. Whether this holds true in a patient remains to be seen. But these do have different properties. However, all of them have similar adverse events. Because GD2 is also expressed on nerve cells, there is pain. Because these are molecules that are abnormal as such, we mount some sort of immune response to them, which manifests itself as fever and hypotension, IgE mediated. And then hypertension can occur because some of these antibodies probably bind to receptors on sympathetic nerves and cause both hypotension and hypertension. The very serious side effects, capillary leak and progressive reversible encephalopathy, posterior reversible encephalopathy, are uncommon and have rarely been described primarily with dinutuximab. But the first 5 adverse events are very common. Now I'm going to go through what do we know about these, and some of it is historical and some of it is currently used. So we first used murine 3F8 at Memorial, and we found that in the era of adding 3F8 plus subcutaneous GM-CSF, our survival rates of patients with high-risk neuroblastoma after chemotherapy improved. We also used it after patients relapsed and were put back into remission to try and maintain that second remission. And we showed that this approach was beneficial to patients. Dinutuximab was first tested in a phase 3 seminal study at the Children's Oncology Group, and when combined with IL-2 and GM-CSF and cis-retinoic acid after transplant, it showed significantly improved event-free survival compared to standard therapy. And these data were used by the FDA to approve this agent for widespread use. That was in about 2010. A similar approach was taken in Europe, where dinutuximab beta was used, and in a randomized study of using the antibody with and without IL-2, it was shown that IL-2 was not needed for its function, and these event-free survival was better than historic data. And again, these data led to the approval of dinutuximab beta in Europe. And lately, dinutuximab beta has been used as a prolonged infusion, and recently there was a paper published on its response rate in patients with chemorefractory disease. Humanized 3F8 was approved in 2020, and the data that led to its approval was a 50% response rates in chemo refractory patients. That is, patients who had chemotherapy and did not achieve a complete remission, those patients had a 50% response rate. And that was the indication for humanized 3F8. And then our group and other groups around the world have also used it in first remission. And in the initial first remission study, we've shown event-free survival of 73% in patients after chemotherapy. Finally, another antibody, the humanized 1418, was also tested in a phase 1 trial. This antibody had complement deactivation, that is FC part of the antibody was modified such as to not activate complement at all. The idea was that this might lead to no pain, but unfortunately it was associated with pain. But when the St. Jude's group used this antibody upfront with chemotherapy, compared to historical data, their outcomes were better. And based on this data, the newest Children's Oncology Group study is incorporating dinutuximab, not 1418, because this is not commercially available, into upfront chemotherapy. And that study was launched last year. Finally, antibodies have been used with other agents in order to enhance them. So for example, they've been used with GM-CSF or IL-2, with other agents such as glucans, and a bit about that later on, and recently in combination with chemotherapy. And when combined with irinotecan and temozolomide, both naxitamab and dinutuximab show about a 30 to 40% CR plus PR rates. And this has led to the increasing use of chemoimmunotherapy in the relapse setting. So to summarize, 3 antibodies, dinutuximab beta, and naxitamab. Dinutuximab and dinutuximab beta usually start off at least inpatient, and there is an attempt to treat patients outpatient with continuous infusion of dinutuximab beta. Naxitamab is used outpatient as a 30 to 90-minute infusion. Most commonly, dinutuximab and dinutuximab beta have been used in first remission after transplant, and naxitamab, most patients have received it not having transplant before, per the MSK approach. Dinutuximab is now being tested upfront after 2 cycles, and in our study after 4 cycles. Dinutuximab beta is being considered for use in Europe as upfront treatment. Again, I'd mentioned transplant versus no transplant. The response data were not initially provided for dinutuximab or dinutuximab beta, but for naxitamab, those were provided for its approval. And chemoimmunotherapy, we still don't have prospective data from dinutuximab beta, although there have been recent retrospective study published in small numbers of patients. But in my experience or opinion, these antibodies will have responses with chemoimmunotherapy. Now, how can we make these antibodies work better? One approach that I mentioned was combining it with cytokines and with chemotherapy. But another way would be to create a molecule that already has an IL-2 attached to it. And this was done by Paul Sondel's group, where they made an immunocytokine, humanized 1418 IL-2. And this showed responses, but only in patients with bone and bone marrow disease. And thus far, this has not been taken further for commercialization. Another way would be to radio-label antibody. So in our case, we radio-labeled the naxitamab or humanized 3F8 with iodine 124. And you can see that in this patient who had a lot of liver disease and bone marrow disease, within 2 hours of injection, you can see that the antibody, which is the dark spots, can target to the tumor. And in the 1980s, we had also used the previous iteration of this antibody incorporated into upfront treatment for neuroblastoma. So another way to enhance the effect of antibody or to use it for a different method, different way of delivering radio-labeled therapies is to radioconjugate it. Yet another way would be to add it to NK cells. We and other investigators showed that when patients have a KIR-HLA mismatch, antibodies work better. So in order to make use of this, there were 2 trials run. In our center, we took patients, in both of these centers, St. Jude's and us, we took haploidentical cells from parents. And we treated patients with chemotherapy and then gave the NK cell infusion and then 3F8 or humanized 1418. And we did see responses. These were not home runs. And when we looked in our relatively large number of patients, this KIR-HLA mismatch that we had discovered retrospectively did not actually pan out. Another way to use NK cells would be, instead of using only transient NK cells, that is when you take haploidentical cells from parents, those are going to last for about 2 weeks. But how about if you do a haploidentical transplant? That is, create a whole new repertoire of NK cells, as the Germans did with in the Tübingen group. And there they took patients and conducted haploidentical transplants from parents, and then added the dinutuximab beta to it, and again showed that compared to historical data, they were seeing some benefit. But the holy grail in immunotherapy is to use T cells. These T cells provide long-lasting immunity. And I won't go into details of all the initial trials that were unsuccessful, but as many of you know, the trial in Italy from the group, Dr. Locatelli's group, showed about a 63% response rate in patients who had chemorefractory disease. So this is really, in my opinion, the only trial of GD2 CAR T cells that has shown encouraging results. And now they are planning to expand this into a phase 2 and phase 3 study going forward. Another way you can use T cells is to chemically conjugate the antibody, as we have done, and so-called arm these T cells. I won't go into that in too much detail. I'm running short of time. So switching gears from cells now, we had discovered what's called an anti-idiotype network. That is, if you treat a patient with an antibody, in this case, the antibody actually acts as an antigen. That antigen then elicits an antibody against that antibody, and therefore a mirror image of GD2 is created within the patient. And we found that those patients who had mounted a human anti-mouse antibody response actually did better, paradoxically, than those patients who did not have HAMA. This was in a small number of patients, but we then validated this in a larger group of patients, and we then thought, why not make an anti-idiotypic antibody? And that was made, these are 3 anti-idiotypic antibodies made in rats, but none of them were commercialized. But based on these data, we conducted and continue to conduct a vaccine, which, to cut a long story short, can make glycolipids immunogenic by combining them with lactones and with glucan. And this, we've treated about 500 patients so far. What we can say is that we are seeing an immune response. If you measure the immune response with anti-GD2 IgG1 titers, we can see that over time, patients are mounting an immune response. For reasons we don't quite understand, these patients don't experience pain. And when we compare those patients who had a good immune response versus a not good immune response, the cutoff here was 150 nanograms, we found that these patients, after second remission, do very well. So after we made this observation, we are now conducting a study where we incorporate vaccine. We allow first remission patients to enroll onto the new vaccine study. Going forward, for this to be successful and used in multiple centers, we do need pharma backing, which we don't yet have. Finally, on the GD2 front, in one slide, anti-GD2 antibodies have not been successful for osteosarcoma. 2 studies were conducted. The time to progression for pulmonary mets was looked at, and patients were treated with either dinutuximab or naxitamab. And the time to progression, although marginally better for both, than historical controls did not meet the predetermined criteria. Now, whether this still has a future remains to be seen, because there clearly was some activity, but the bar was set quite high, and that bar was not met.
Dr. Modak, you need to wind up.
All right. Can you give me 2 more minutes? The B7H3 quickly.
Yeah.
We use B7H3 for radioimmunotherapy, both for desmoplastic small round cell tumor and DIPG. And some more studies need to be done for this. CAR T cells against B7H3 have not been effective. Other antigens, again in one slide, L1-CAM, oncofetal antigens, and HER2-neu have all been targeted for pediatric tumors. And in summary, targeting these antigens has not been beneficial. So for the future, and I'm going to make this my last slide, we need to be better at choosing antigens. Perhaps there are other antigens that we can select. For example, GPC2, FOX2B, et cetera, are being looked at. Can we make better effectors? Can we make bispecific antibodies, which we have almost completed a study on? Can we make antibody drug conjugates? And this study is going to be launched soon in multiple centers. Can we improve on the CAR T cells? The tumor microenvironment in neuroblastoma still remains a black box, and we don't quite know whether that's going to be, whether we can understand it or not, and that's a big frontier that needs to be crossed. So going forward, in summary, we have some challenges in front of us, but we have made major steps, especially in neuroblastoma, for immunotherapy of in the world of pediatric oncology immunotherapy. And I guess I'll take questions later on, but thanks for your attention.
Thank you, Dr. Modak. We can take one question if is there any burning question, or probably we can reserve it. Thank you very much. And I take the pleasure to invite the next speaker, who is Dr. Tejpal Gupta. Is a very good friend of mine. You can say that, friend in all forms, professionally, personally as well. He himself is a publication house. I mean, his areas of expertise is in neuro-oncology. And he's a radiation oncologist, the lead of neuro-oncology team at Tata Memorial Center. Dr. Tejpal, you have got 20 minutes to convince the audience about the various options of immunotherapy in pediatric brain tumors.
Yeah, thank you, Dr. Sridhar. Good evening, everyone. Can I have my slides, please? So first disclaimer, I mean, Sridhar has already said I'm a radiation oncologist. I don't actually practice immunotherapy, but still I'll try to do some justice to immunotherapy in pediatric CNS tumors. So briefly, the outline about the epidemiology of pediatric brain tumors, the cancer and immunity cycle, the immunotherapy approaches that have been tried and tested, some preliminary evidence of safety, efficacy, ongoing studies, future prospects, and summary and conclusions. So this audience probably doesn't need to know, I mean, doesn't need to be reminded. Brain tumors are the most common form of solid tumor in children 0 to 19 years of age, and the second commonest type of cancer after hematolymphoid neoplasms. And they remain the leading cause of disability and death in children. It's a wide variety of tumors that we see. This is the anatomic and histological distribution, but you would see that gliomas and embryonal tumors are the most common tumors. Nearly 65 to 70% of them are gliomas and embryonal tumors. Now, one of the hallmarks of cancer is evading immune destruction. I mean, this is being increasingly recognized over the last 10, 15 years. And it's a multi-step process. There are several players involved. Cancer cells are like soldiers of an invading army and more like traitors within the ranks of the normal human cell population. So this is how you would summarize the cancer cell. And you can tackle each step in cancer progression through immune approaches. So this is when we do radiation and chemotherapy and some targeted therapy, you release cancer cell antigens. These are then sort of presented. There is priming and activation, not in the CNS, but in other sites. These traffic to the lymph nodes. The T cells go to the tumors, and then it is recognized. There is recognition by the T cells, and then that leads to killing of the tumor cells. And you can target each of these steps with immune approaches. The two major barriers or impediments to successful immunotherapy in pediatric CNS tumors is that immunologically, brain tumors and including pediatric brain tumors are pretty cold. They have a very low tumor mutational burden. And we all know that CNS has been considered as an immune privileged organ. There is a barrier of to entry of immune cells. So these are the two major barriers for successful immunotherapy. As I said, this is a slide summarizing the mutation frequency in pediatric cancers. And if you see glioblastoma, I mean, all pediatric cancers for that matter have low mutation frequency, including brain tumors, including gliomas, as opposed to the adult cancers. So there is a low mutation frequency. As I said, that's one of the barriers. And if you look at the microenvironment in pediatric brain tumors, you see it's generally it's an immune desert. So you don't have too many antigens and too many things to sort of act upon. Also, CNS is an immune privileged organ. So if so, how do the immune cells enter into the CNS? And some of it is because there's some disturbance or disruption of the blood-brain barrier because of the tumor itself. There are some sites that are deficient in blood-brain barrier. There is replacement of pericytes and endothelial cells. Some pores form through endothelial cells, and from blood to the CSF via the choroid plexus within the ventricles of the CNS. And now this term called glymphatics or glial lymphatics. So that has been now shown that there are lymphatics within the CNS as well. But blood-brain barrier remains an enigmatic challenge for CNS tumors. Now, broadly, 4 approaches for immunotherapy in pediatric CNS tumors, and we'll go one by one. One, of course, the easier one is the antibody approach, then is the oncolytic viruses, then the cancer vaccines, and last but not the least is the adoptive cellular therapy, the poster child being CAR T cells. So before we go to the checkpoint inhibitors or immune checkpoint blockade, this is the cell cycle, and we all know that there are several checkpoints in the cell cycle, and these are that are targeted by some of the checkpoint inhibitors. The most common ones used are PD-1, PD-L1, and CTLA-4 that have been used quite extensively in adult solid tumors, but also have been tested in pediatric brain tumors. So, but we know that the response rates of immune checkpoint inhibitors in pediatric CNS tumors are quite modest at best. So this is a summary slide showing pembrolizumab, nivolumab, atezolizumab, and avelumab. If you see, the response rates are, the experience is of course limited, but even the response rates and the outcomes are even not very encouraging as far as immune checkpoint blockade is concerned. The only sort of tumor that has shown some benefit with immune checkpoint blockade is the replication repair deficient gliomas. So this is a cartoon showing you the mismatch repair pathway, and many of our children with brain tumors have defects in the mismatch repair pathway, and high-grade glioma is now a common sort of manifestation of mismatch repair pathway deficiency, the so-called CMMRD. We do see quite a bit of patients having gliomas. And most of these children have gliomas, but some of them can have other tumors such as medulloblastoma and even ependymoma. So One of the ways of selecting pediatric CNS tumor patients for immune checkpoint blockade is to have patients that have these defects in the mismatched repair pathway. In the unselected population, you get a very poor response to anti-PD-1 or anti-PD-L1 therapy. But if you have hypermutant tumors, which is very typical of the mismatched repair pathway associated gliomas, the MMR, RRD deficient gliomas, there is hypermutation, and these actually respond well to immune checkpoint blockade. Even the SMARC-B1 deficient tumors do respond to immune checkpoint blockade. And this was shown, this is a data set from Sick Kids, where they demonstrated the benefit of adding immune checkpoint inhibitors in MMR deficient gliomas. As you can see here from one of the examples in the paper, there was a multifocal progression, and then with nivolumab, there was a very significant and sustained response. The survival curve also shows you that post-relapse overall survival on immune checkpoint inhibitor was much better. This is from the IRD consortium. They demonstrated that combining immune checkpoint inhibitors in recurrent RDD associated gliomas showed improvement in overall survival. So patients who continued the immunotherapy had significantly better outcome. This is a larger data set, nearly 75 children with RRD high-grade gliomas, where combining checkpoint inhibitors led to a sustained benefit. And based on all of this, this is a study, the UR Immune. It's a prospective multicentric study where in the replication repair deficient high-grade gliomas, GBM, there's the upfront immune checkpoint inhibitors are being tested. Even Tata Memorial is one of the participating sites. I believe the study has just opened in the UK. Maybe Girish and Maya can tell when we will open the study in TMH. Coming to oncolytic viral therapy, it can be done intravenously or through intratumoral administration, and it elicits an immune response, which ultimately leads to cell death. Tumor is killed. A host of viruses have been used, and this is a list or a slide summarizing all the viruses: the herpes virus, adenovirus, vaccinia virus, Newcastle virus. I mean, all kinds of viruses have been used, and some of the characteristics of these viruses, not that one is better than the other. I think in terms of response rates and efficacy, more or less pretty much similar. I would just, this paper actually was just published in the New England Journal of Medicine, and I thought I will just show the summary of this. So this is using oncolytic DNX2401 virus for DIPG, and it was a dose finding study, and a lot of sort of adverse effects were seen in children who were given this. There was some, the median overall survival was actually 17 months, which is historic data suggests it is between 10 to 12 months, but possibly these patients were well selected patients, and but this does seem to be doing something. So what they concluded was that intratumoral infusion of DNX2401 followed by radiotherapy in DIPG, DMG induces responses, but is associated with significant immune-mediated toxicities. The third approach is the cancer vaccines, and a lot of vaccines have been tried for pediatric CNS tumors. The four types of vaccine approaches: you can have peptide-based vaccines, RNA, DNA vaccines, whole cell vaccines, and dendritic cell vaccines. The peptide vaccines and the dendritic cell vaccines have been most commonly tried, but I think there's a lot of promise with the DNA, RNA vaccines moving forward. This is a summary of the vaccine trials in pediatric CNS tumors. So as I said, dendritic cell-based vaccines and the peptide vaccines have been tried the most often. Again, did show some benefit, but most of these studies were to find the dosing that is required and assess the toxicity of the vaccines. Coming to the last approach, which is the cellular therapy approach, or the CAR T cell therapy. So T cells are gathered from the patient. The CAR structure is engineered into the collected T cells, and the modified CAR T cells are then augmented to sufficient amount and infused back into the patient via the catheter into the tumor in the cavity, or intraventricular, or even through IV infusion. So this is a summary slide of the various targets for CAR T cell therapy. And as you can see, as Dr. Modak also mentioned, there are several of these targets, including the GD2 that has been used for gliomas as well, HER2, B7H3, IL-13R alpha 2. So many of these have been used and tested. Again, most of these are sort of dose-finding studies looking at the toxicity profile of CAR T cell therapy for mainly for gliomas and refractory recurrent pediatric CNS tumors. This was a paper recently published in Nature. This was looking at intravenous and intracranial GD2 CAR T cells for histone mutant diffuse midline gliomas. Some responses were seen, but so you can see this is from the paper itself. There were some responses, but overall, so actually the authors concluded that sequential intravenous followed by intracerebroventricular GD2 CAR T cell induces responses and benefits patients with DIPG and diffuse midline glioma. Sorry. Some of the mechanisms of toxicity that we see, and it's not peculiar only to CAR T cell, in general with immune therapy approaches, we do see something known as cytokine release syndrome, the ICANS and the TANs, and there is a lot of on-target off-tumor toxicity, and fatigue and skin rash is pretty common, and I think other side effects are not all that common, but we have to be aware of the toxicities of immunotherapy for pediatric CNS tumors. Nearly 80% of children will develop grade 2 or worse toxicity with any of the approaches that I just mentioned. Coming to ongoing clinical trials, again, this is a very busy slide, but this is again divided into the vaccine trials, the oncolytic viruses trials, the checkpoint inhibitor trials, and the adoptive cellular therapy, including the CAR T cell approach. So a lot of action currently ongoing as far as pediatric CNS tumors are concerned. Some of the challenges that we face, the antigen escape phenomenon, as Dr. Modak also mentioned, there are a limited number of known tumor antigens or tumor-associated antigens or tumor-specific antigens. The blood-brain barrier is again very peculiar to CNS tumors. There are long-lasting effects and toxicities of these immune approaches, and most of it is due to inflammatory response. For the CNS, there is a lot of difficulty in monitoring the response to therapy, and we also have to balance the need and the use of steroids, because steroids remain one of our weapons for symptom control as far as brain tumors are concerned. And last but not the least, affordability, accessibility, and availability issues. So these are some of the challenges that we face. How do we improve immunotherapy, and what's the way forward? Of course, there has been a lot of work going on as far as bypassing the blood-brain barrier is concerned, either through focused ultrasound, MR-guided, or microbubbles. You could look at characterizing multi-compartment immune landscape. I'll just focus on the last four, which is improved understanding through preclinical models, warming the cold tumor microenvironment, the next generation of technology, both in CAR T as well as vaccine, and combinatorial approaches. So preclinical models for glioma immunological research have come a long way, and now most people are preferring the use of organoids as far as preclinical models are concerned, and they can actually enhance our understanding and provide insights as to how to proceed further. There are several strategies to warm the cold tumor microenvironment, and one of them actually uses novel agents such as ONC201 in diffuse midline gliomas. The CAR technology has evolved over time from a conventional CAR technology to a multi-antigen CAR. Now there is something known as the adapter CAR technology, which probably can enhance immune responses and provide more sustained responses. Even vaccine strategies, there have been advances in vaccine strategies through the use of personalized vaccine and optimizing the vaccine design. And finally, the combination therapy that can actually increase the immune response as well as provide sustained immune response. So in conclusion, CNS tumors, though rare overall, are the second most common neoplasm in children. Surgery followed by radiation therapy with or without chemotherapy remains the mainstay of therapy. Most pediatric tumors have low mutational burden. They are immunologically cold. CNS is an immune privileged site. It restricts entry of immune cells in the brain. Various immunotherapy approaches have been tested in pediatric CNS tumors. I mentioned the 4 approaches, which is the checkpoint inhibitors or the antibody approach, the oncolytic viral therapy, the vaccine approach, as well as the cellular therapy or the CAR-T approach. Most patients do develop grade 2 or worse toxicities, which is largely an inflammatory response. The efficacy of immunotherapy has been rather limited in pediatric CNS tumors, excepting for the replication repair deficient gliomas, which do exhibit a remarkable response to immune checkpoint inhibitors and can be a case selection criteria. If there is mismatch repair deficiency, those patients are most likely to benefit with immune checkpoint blockade. Insights from preclinical and multi-compartmental landscape are needed, and that they can provide us the way forward. And combinatorial approaches may help improve outcomes in pediatric CNS tumors. Thank you for a patient hearing, and I'm happy to take questions. But before I end, I just want to show and invite all of you to the Indian Society of Neuro-Oncology annual conference 2025 at Dehradun, and we will have a session on immunotherapy in brain tumors, not necessarily only pediatric, but immunotherapy in brain tumors. Thank you very much.
We will start with the next session, which would be a panel discussion on immunotherapy implementation strategies in routine clinical care. I would invite Dr. Chetan Dhamne. He's a professor of pediatric oncology at Tata Memorial Hospital.
Thank you, Purva. And I would thank the chairs for chairing this session, Dr. Sridhar and Dr. Purva Kaninde. So now we have heard a lot throughout the day on different immunotherapies that are being used, the cell-based as well as the antibody-based. But how to implement them in our setting is something that we need to look at. And we will see what are the challenges that we face in these. We are all aware of these challenges, but how to overcome them and how people have overcome them is something that we would like to discuss. So I would like to invite upon the panel Dr. Rahul Purwar, Dr. Gaurav Narula, Dr. Revati Raj, Dr. Shakil Modak, Kala Shekhar, and Dr. Caitlin Duffy. Okay, good. So one of the commonest things that immunotherapy agents that many of us have used is the blinatumomab. So I would like to ask the panel as to what are the challenges that they have faced in implementing these strategies in India. So India is quite heterogeneous. We have the government hospitals, we have the private hospitals, then we have state hospitals, the regional cancer centers. So each section will have their own challenges. So I would like to first ask the tertiary care hospitals in India. I will start with Dr. Gaurav as to what are the challenges he has faced in implementing this.
Batteries. Yeah, thanks. I think in a public hospital, the biggest challenge that we have faced is availability of beds. So we have been, we started 3 immunotherapy-related programs in our department, in our unit. The first one to roll was the blinatumomab humanitarian assistance program, where we were getting blinatumomab through this humanitarian assistance, which is coordinated by Caitlin Duffy and group in St. Jude and Amgen and Direct Relief. And then the second program that we rolled out was the CAR-T clinical trials. And then the third one, which has been rolled out, is the denatumab infusion, which is going on to the neuroblastoma and the solid tumor group. And the biggest challenge that we faced for all 3 has been bed availability. The problem with blinatumomab is 28-day infusion, and it was required close monitoring because it was a new thing that we were starting, and that was the requirement of the program. So to occupy for one patient a bed for 28 days and then reserve that patient as a bed for another 28 days was a big challenge in a high volumes unit like ours. For the CAR T-cell therapy, of course, again, it was a clinical trial, so we could get. But again, despite being a trial, the patients had to compete for other patients in the transplant waiting for beds. So it was quite challenging initially to begin with. So that's the biggest constraint, I think, has been the availability of beds. The second was to, in a large volume patient center, to train multiple people, because we have people on rotation. So we have got large units. We also have large caregiving units. Sisters on rotation, residents rotate, consultants rotate, and everybody needed to be trained to be able to, treat these patients and to be the same. So continue the training, and having the continuity of training was the second biggest challenge. So I think these are the 2 biggest challenges. There are other challenges also that we faced, like logistical issues, availability of pumps, for example. The pumps suppliers don't distribute those pumps in India very easily. So because probably there was no market for them. So to get the pumps, to get the spares, to get them repaired, to get the cassettes, the right size cassettes, all of them have been challenging issues. So these, I think, 3 would be the main really, challenging issues.
Right. So definitely there are logistic challenges that, as we see, are the problem, even if all these therapies are available to us. We would like to go ahead with the same question with Dr. Kalashekar, but then Dr. Rahul Purwar needs to go. So we would just like to ask him his experience about the CAR-T, how he has moved on from the phase 1, phase 2 trials to the real world, and what are the challenges and differences he feels when he has before and after approval of the CAR-T, and also his experience as to how many infusions they have done so far and what is the success rate.
Thank you. Thank you so much for having me here. And it's my apologies that I have to leave immediately. Regarding the challenges, I think it depends in which, because this very broad, like the delivery of CAR-T from phase 1 to phase 2 and then market authorization. We had challenges in many, many areas, right? So if you see clinical delivery, challenges in clinical delivery, I think as the Gaurav sir mentioned, in private hospital, the bed availability, the logistic issues. But in the private sector, there are different types of challenges we have, right? The patient, what type of patients, patient selection, and all those issues you have there. Then manufacturing side, there are different types of challenges, like what we face in the manufacturing. And the regulatory challenges, of course. And so there are challenges in each direction. But besides all these odds, we could manage the completion of trial within 8 months. The phase 2 was completed in 8 months. We get the approval for market authorization. And this phase 2 trial we did in 5 different centers across the country. And then now within 1 year, we have almost treated 270 patients already. And every day we treat 1 patient on CAR-T. So almost 30 patients we do across country. And so this experience has been remarkable. So now if you see in the real world, the logistic challenges, what we were thinking, like they will be huge. And it's to our surprise, our logistic systems are really very good. The courier services are very good. Within 24 hours, cold chain, we can supply CAR-T to any part of the country, including tier 2 and tier 3 cities. So that was a good, I think, surprise to us. So in the real world, I think we are doing very, very well. The scale, what we are doing is really making CAR-T not a boutique therapy, but rather this is becoming like mainstream so that it is available to many, many patients. Thank you.
So that is quite commendable that you are able to do 30 CAR-Ts a month, so one every day. So that is really commendable. So a big round of applause. So Dr. Rahul, just one more question before you leave us, as to when you had this idea of a startup. Okay, so how did you come with that idea? And after the startup, how do you feel? How is scaling up the startup helping you, and what are the
I will
challenges?
answer your last question for how do I feel after startup. I feel very, very happy about it. But the first question is very interesting. When Gaurav sir and we started together this journey as an academician, because both of us from heart we are academician. I am still professor at IIT Bombay, and sir is here. Our idea was that we will remain academician and we will do the product development at IIT Bombay, clinical development at Tata Hospital, and then we will find a pharma player who can then do the scale up, because both of us are not trained for the scale up and delivery and logistics, right? As Professor Shakil mentioned in the previous talk, that even GD2 card, despite having some good results, pharma is not coming up. Same thing we faced even in India, much more, I think, at higher level than you face those challenges in the United States. Our pharma did not come up when we were approaching them, because CAR-T is again very expensive therapy. So besides all the logistic problem what Dr. Gaurav sir mentioned, so CAR-T does not make commercial sense in our setting. So the way pharma in India is wired, CAR-T does not fit in their business model at all. So that's how we approached many, but unfortunately we did not find a partner. So when sir did not want to become the entrepreneur, then I had to become the entrepreneur. So I am always called, I am a forced entrepreneur. So I started the company, and now we are very, very happy. We are not only in Tata Hospital. Now imagine the very rural part of the India is using CAR-T. And we are very proud that we could make CAR-T as a mainstream, not as a boutique, as I said.
Great. Thank you so much. So now that we have all these CAR-T therapies, so Dr. Kalashekar, with all these immunotherapies, what do you think that Dr. Rahul Porwar said he can deliver the CAR-T to even the remotest places? But then how many CAR-Ts have you been able to infuse? And if yes or no, what are the challenges?
So if you see, compared to TMH, so RCC is also a tertiary cancer hospital, although funded by the state government. So we see around 750 patients who are actually, as you know, Kerala being in the education aspects, they are very in a high end. So they are actually the health seeking behavior is very good, where patients are very aware about all the treatment modalities. We face such patients daily in our OPD. However, so as of today, we are able to deliver the first anti-GD2 therapy for our patient. Only one patient, and the second patient we are trying to give. But we are facing a lot of challenges. Like as Nirmalya's survey clearly showed, all the points he showed, like from the cost, from logistics, everything we face on a day-to-day basis. So procuring all these costly medicines and administering them. Say we want to give a blina. Suppose we have a patient who can procure. We don't have a transplant backup. So we are actually doing only autologous transplant. We don't have allogenic setup still. Being one of the premier centers who caters to 750 patients per new registrations annually, we don't have allogenic transplant yet. So we are facing multiple challenges at multiple levels. Although we are being a young team, we are trying to address all these challenges, and hopefully we will be able to deliver all these immunotherapies in the near future.
So Kala, I think we are a bunch of we are very driven pediatric oncologists, and I'm sure that we will make it happen. The CAR-T story is a success, and we can now jump to Blina. Blina is not available in India, but through the BHAP program, we have been made, it is available now, and many centers across the country have been able to give Blina. So I would like to ask Dr. Duffy as to what were the challenges initially? How did you come across the BHAP program, your implementation strategy, and then we'll come to the success of it in the later question.
Thank you. So BHAP is specifically our blinatumomab drug donation program, and I think playing off of some of the discussions that have already happened already, one of the significant challenges is understanding that middle ground with industry. And so there was a lot of concern about kind of individual or ad hoc distribution and really not being able to have this kind of consistent communication about how these patients were doing. And so one of the solutions for that was to form a collaborative relationship with Amgen, with St. Jude Global, and with Direct Relief, who is our NGO who really specializes in importation. And I think that that addressed some of these pharma concerns. And then what we've tried to do is recognize that beyond just establishing the drug donation program, which I think addresses some of the funding issues and some of the access issues, we really needed a parallel implementation study so that we could really understand the process of implementation and how to go about doing that. And we actually created a hybrid study, so not only looking at implementation, but also looking at effectiveness. And so about half of our sites who participated in the drug donation program has also participated in the hybrid study, which I think is actually what's going to be able to take this kind of to the next level as we think about what are we going to do beyond this pilot drug donation program.
Right. So I think that also is something that we should applaud, is that the St. Jude Global thought of expanding the program beyond the United States. And probably it is not the pharma, but the St. Jude Global that thought of looking at beyond US. So that is something commendable. And do you have any inkling as to how that came into shape?
You know, you cannot make up for timing. I think it was something that I was really fortunate to have great mentorship as I was coming up within St. Jude. And I think recognizing that this was something that I had been interested in for a very long time, and had good support that implementation science was more and more being integrated and actually going to impact how we deliver care. And so I think having the institutional support was very good. I also think we would not have been able to do it without good partners who understood the value of implementation science and gave us feedback throughout the process, so that what we were creating is actually something that was ultimately useful for people. And I think, again, representative of the experience from a lot of these different institutions. It certainly wasn't an easy experience, and we have 7 centers in India, 5 in Pakistan, and 1 in Vietnam. And of those 13 centers, it's not been the same onboarding any of those. And so I think we really got a good idea of some of the heterogeneity and challenges, both in India, where we're really reliant on kind of the per patient donation, and then with some of our other countries where we have to do bulk donations. But then there are other complications and other logistical issues that arise that we have to kind of work through. So variety of challenges.
So not many of us understand what is implementation science, but I understand that how do you implement a program in the developing world or any other center across the world. So what are some of the key takeaways or what learning points or experiences that you would like to share in what you said was heterogeneity among the different centers?
Yes. So I think the bed capacity is certainly one that is one of the biggest challenges that we've encountered. And I think recognizing that, you know, we have these FDA eligibility criteria, but even beyond that, there are so many patients that would be eligible, but because of the logistics on the ground, just can't give it to all of those that would meet that criteria. I think the challenge with the indications for blinatumomab evolving as the program goes on is also, I would say, 1, a challenge, and 2, I think a real opportunity, because I think what has come out of this very intentional study really highlights the relative advantage of some of these alternative formulations, issues related to tubing, issues related to getting the filters, getting the pumps. And so it actually, I think, has then now put us in a position where we can say really definitively, like, these have had a huge impact on our ability to implement this drug and implement it consistently. And so we really need to consider, as additional formulations become available, that they become available in these places.
Right, great. Thank you from all of us for having that in place, and it has definitely helped a lot of patients, and I'm sure you're going to highlight that when you publish your paper. So just moving tracks a little bit, and we had to juggle a bit because Rahul had to leave. But I would like to ask Dr. Modak so you see, you started with 3F8, which was murine, then you went to humanized, then you have the new CHO derived antibody. So this keeps on coming up, something new all the time. So at what time do you say that now it is ready for marketing? Especially at your center, because you will specialize in doing phase 1, phase 2 trials or phase 3 trials. But then when the market authorization comes, how do you deal with a new molecule? So what are those challenges and how do you face them?
First, I want to make two comments. One is, Gaurav, congratulations and unbelievable work and fantastic. And then about the St. Jude's program, is it specific to blinatumomab, or are you guys considering?
It is now, but the third aim of our study is actually to create a model that hopefully we can apply to other complex therapies like anti-GD2, et cetera.
So you had buy-in, sorry, I'm cross purpose.
That was my next question.
Because so you had buy-in from Amgen with.
Did you, no, so the product is donated from Amgen.
So, so it's an altruistic donation from Amgen?
There was a slide earlier that showed kind of the intersection between these like 3 Venn diagrams, and I think that that's the best representation of what the relationship represents. So the drug donation program is only active in LMIC countries where blinatumomab is not commercially available. And we have partnerships with individual institutions, which I think builds on some of the longitudinal relationships that St. Jude Global had built over the last several years. The drug donation program, I think, represents an opportunity for a pilot, but it's certainly not kind of the end all be all. And I think we've talked a lot about, like, there are many steps to go beyond the pilot. And I'm, again, very hopeful that what we're doing from an implementation science perspective actually helps us move beyond just the drug donation program itself.
Thank you. So, I mean, that's relevant to the question you asked me. I think it's a very difficult, it's a very different world out there in Europe and in the US. I won't go into all the details as to why companies feel that they can make a profit out of a rare disease, and that's basically been instigated or spearheaded by the legislation that was passed in the US, whereby startup companies can make a profit. Ultimately, it is a profit-driven economy. So because of various legislative activities, there has been a focus on rare diseases by private companies, and therefore there has been a push towards developing drugs for orphan conditions, which has benefited patients, but also has benefited pharma. Now, when you have a pharma like Amgen, which is a well-established large pharma, for them to participate in a donation program of this sort is easier than for the startup pharmas, which both were relative startups, which made anti-GD2 antibodies. So because these are small startups and they are publicly traded companies, they have to show a profit. And because of the legislative activities, like the Creating Hope Act in the US, they were encouraged to make drugs that they could use for orphan diseases. So that's the background about how these 2 anti-GD2 antibodies came to pass in the US. And in the EMA, there were other pressures for pharmas to make drugs for rare diseases, and those led to the development of dinutuximab beta. Now, these are some of the most expensive drugs out in the West, if not the most expensive. So the first question is about why are these, your first question, Chetan, was why are there 3 antibodies? And the answer to that is because of market conditions, right? But when we bring these to India, or we would like our patients here to get these, we come across some of these monetary obstacles. And so the bottom line is that unless we have a program like yours, I don't think these will be widely available in India. There are also parent groups who are also quite active, more and more active in India. And there needs to be some pressure applied to pharma from parents group in order to make these drugs available. Another possibility could be for biosimilars, but with such a small market, I'm not sure whether biosimilars are going to be interested in making anti-GD2 antibodies in India. But there is a tradition of making biosimilars here, and if there's one place in the world where we could make it, it would be here. And the fact of the matter is, at least for dinutuximab, the patent is not too far away from running out. So that could be one way to, you would need pharma to be, some sort of pharma in India to be interested. The numbers will probably support it, but I don't know the funding models here. It's a much more complicated story. Also, blinatumomab was available for far longer than at least naxitamab is. The second point was about how do you choose an antibody and so on. And I think the short answer to that is whichever antibody you're comfortable with using here, that's the antibody to use. So for example, if you want to do dinutuximab beta and you need a pump and a long infusion and you have pressure in inpatient beds, then you might want to consider the other naxitamab. But for naxitamab, you basically do need an outpatient, almost like experienced ICU for half an hour or 1 hour administration of nurses who know how to use it without panicking. So it depends on your setup. I think if the way we developed naxitamab outpatient was because we had a big infrastructure to administer this drug outpatient with at least 2 nurses and possibly 1 nurse practitioner attending at the bedside, almost like giving ICU care over 1 hour. A similar setup was used in Barcelona, where naxitamab is widely used, where they had an anesthesiologist or anesthetist available for about 1 or 2 hours when this product was being given. So I think the choice, there is no clear-cut evidence that one antibody is better than the other. And there will probably be no such trial which will be able to compare back-to-back or antibodies one versus the other for commercial reasons. So my advice would be that, first of all, try to make it less expensive. And if it is still expensive and you have a choice and you have the resources, then I would use whichever antibody you can use in your center. Also, you know, we ourselves would be happy to participate in the nitty-gritty of administering antibodies, because both of these antibodies do require some art of administration. But I believe you have already used dinutuximab beta, so I'm sure you're gathering some experience using it. The second question here, which in a world where there is unlimited resources, like in the US, where both the antibodies are available and we really have not faced pushback from insurance companies yet. My personal practice is to use both these antibodies for various indications, which I won't go into. And a case could be made that if a patient has some sort of severe reaction to one, you could use the other. And indeed, I do that in my own practice. And because the paradigm in neuroblastoma has changed such that patients often live for years, but yet keep on relapsing, I've discovered myself using both these antibodies for my patients, for many such patients. And I've kind of, even though been involved in the development of naxitamab, I've been more and more agnostic and patient-centric in my choice. So I would say that whichever antibody you can use, I was in Saudi Arabia a couple of years ago, a couple of days ago, and there they did not feel comfortable with sending patients home on a pump. They would prefer to do it in-house. So I think every place has its own unique needs while giving, antibody. But we have to, as a group, and it's a responsibility of us from the West to find a way for immunotherapy to be available to patients here. How to go about this, I'm not quite clear, but these are some of the avenues I'm thinking, parent groups, pressure on the pharma, and so on, because naxitamab, for example, is used in China quite a lot. I believe that 300 or 400 patients have received it already. But there is a public-private partnership, so the government does cover some of the cost of very expensive drugs. So this will have to be tailored to each country. Regarding CAR T cells, I can't comment on that much because we don't have a CAR T approved for neuroblastoma, but CAR T cells are covered by insurance in the US, which is the Novartis product. So we really don't push back, get much pushback as long as we stick to the indication.
Right. So useful insights. I put that last question because I just wanted to, we will soon be in a position.
So one question, sir. When we discuss with people in pharma, they always, so about biosimilar, as you mentioned, they always talk about the patency period. So which is not over, so we are not able to manufacture. What exactly it means and why we call ourselves pharma industry to the world. India is being projected. So we ask the same question to pharma. So they tell, because the patency period is not over, what exactly it means?
I mean, patents are valid for a certain period of time. So during, say, 10 years, depending on how the drug was approved for, say, X amount of years, you cannot make a similar drug. So that's the patent. Now, pharmas also have learned to try to extend the patent in several ways. So there are tricks pharma plays to extend the patent. I'm not aware of, because I don't know exactly what pharma does for Qarziba, which is a European, or with Unituxin, which is a United States products, which are about, I would guess that if they've not found a way to extend the patent, they are about to expire. Whereas naxitamab was approved in 2020, so that is not going to expire anytime soon. But with the other two patents, I would guess that they're near expiry. It will still take some time for, biosimilars to be made because you'll have to, I guess you already have the system in place because rituximab and many other biosimilars are still being made here. So it might be plug and play. You could just take the cassette and plug it into a pharma that's interested. I don't know the details about when these patents are expiring, but I would guess it should not be too far off, at least for dinutuximab and dinutuximab.
Right.
So it needs some work and needs some work from people here.
Yeah, so there's a lot that has been done, but there's still a lot that can be done to get immunotherapy to every child that needs it. So I think we are all moving in that direction. So the last question I put for the CAR T product is because soon we will have 2 or 3 CAR T products available in India. And when that is available, the question would be, how do we choose? Because I would put that to Dr. Gaurav. So then the patient is going to ask, sir, which would you want us to give? So I know we will have different answers, but I would just like to hear what are the possibilities.
In fact, that thought was occurring to me when you were saying that, Shakil, because why don't you license that out to us, your antibody? We can put it on a car rather than wait for the pharma industry to pick it up as a biosimilar. So, because I don't know, so, one of the, after the CD19, Rahul had asked me what next. I said there are two diseases which you should focus on. One is obviously myeloma because that's already happening. But I said, as far as the pediatrician is concerned, focus on GD2. And that we've been working on that, but I think the preclinical results are not been very promising. But we would like to move forward, and my interest in the GD2 CAR has been that once it's been tried for glioblastoma, but then we can repurpose it for neuroblastoma. We already have a funded grant to do that work, but we need an antibody which works. So I'm sorry, this panel discussion is turning into a deal-making session.
Can I comment about?
Yeah, please go ahead.
So, the two families of antibodies, right? One is that 14G2A, which is the dinutuximab, and the other is the 3F8, which is a naxitamab family. So I don't think there is a problem with using any of the constructs on a CAR. But I think the way to look at CAR for GD2 CAR is one of two ways. You could say that in a country like India, where actually producing a CAR is cheaper than making an antibody, or easier than making an antibody, you should try to make a CAR, because if your CAR costs $30,000, the sticker price for naxitamab is $350,000, right? So you could create an immunotherapeutic for far cheaper, which is paradoxical. Whereas it would be flipped around in the US, the CAR would be much more expensive than the antibody. But the main problem with GD2 CAR is the confirmation that it is effective. And there is some skepticism because the GD2 CAR in the Italian group, those patients had not received antibody before, most of them. So then the argument the neuroblastoma community has is that you're getting the same results with chemoimmunotherapy. So why make a more expensive, more toxic product and more involved product than what you already can get off the shelf? But in India, it's not that, right? You don't have anything on the shelf. So the CAR that was successful is so-called third generation CAR, which has a caspase 9, but the caspase 9 was only activated in one patient out of the 30-odd patients. So I don't think you need the caspase 9. But of course, I can't speak for that group, whether the presence of the caspase 9 was the reason why it succeeded, or was it a patient selection? The current, because I have patients from Europe, and I refer those patients to the group in Rome, but what they're being told is that they're still selecting patients with low tumor burden. So there's still some ways to go, but that doesn't mean that you shouldn't do it, right? You should actually get a head start. And if that's, you have shown above all, which is fantastic, is the affordability of this agent. And it's amazing that you can make it for that cost. And therefore, I would encourage you to do it. But in the West, we still are not quite convinced about the GD CARs being useful.
So I think Dinesh is, sitting back there. You should probably talk about this. We can definitely look at, using this strategy on a CAR rather than as an antibody infusion. But depending on how things go forward. Chetan, you set up some amazing panel discussion. 2 deals
It's the end of the day. So
and of course, there's St. Jude's, which is such a fantastic organization for patients all over the world, right? That's a unique organization, which also is a big player in accessibility. So there's very few organizations like that.
It's the end of the day, so I don't want to be burnt at the stake for asking a question. No, but Anand brought up a relevant point. The patent laws in pharmaceutical world are very generous to the pharmacy company. They are 20 years from the date of initial filing. Now, they can be broken But to break them, you have to invest heavily in legal services. You have to show that a person who is skilled in the art would not consider the molecule you are bringing forward to be a challenge to the existing molecule. I know because I was in a patent law case about a decade ago with the Boko Hajia, where on opposite sides of the dais, where we had to show that the molecule which the company is bringing forward was not going to be a challenge to the existing molecule. But it's very hard process. So 20 years, Anand, is your answer, which is a very long time because you can refile. As Shakil correctly said, there are little tricks you can do, little innovations you can make. So it gets extended from 20 to 25. It's the date from when you file that last innovation.
If it's date of filing the first patent, then, I obviously have no idea about all the so-called discoveries that are made, but dinutuximab patent was filed, it was approved in 2010. I bet the patent was filed well before that. So I don't know any details, but worth exploring,
No, I know, I have learned over the years a sure shot tell sign of when a patent is about to expire. And that is when the drug company starts filing for pediatric trials. Once they're filing for pediatric trials, they are at the end of the line. They have run out of the adult market. Then they will open a pediatric indication.
Similar situation in neuroblastoma, right? Because these
Not
were
in neuroblastoma.
No, but I'm saying, I'm talking about the neuroblastoma world. Those patents were all filed for neuroblastoma. There's no other. They were not filed for any other indication. So there is an opportunity, I think. Again, I might be ignorant as to what's happening.
So, yeah. After Dr. Kurkure asks her question, Kala, if you have any questions, and then we'll just wind up in 2 minutes.
No, I have just a question to Kathleen Duffy about this BHAP program. Now, Kalashekar brought out the issue that you have a BLINA, but they don't have allogenic transplant. So don't you look at those institutions which have a very integrated program of being able to treat patients with BLINA as a bridge to transplant? Because you give BLINA to one institution and you don't have a backup of transplant, it's a waste. So then they are referred to other institute for transplant. There is a time lapse in which the disease can come back. So integrated program would be better. That's one of the way to look.
That point is not lost on us. When we started enrolling programs, the first 3 that we did work with all did have transplant capacity. As some of the long-term follow-up studies from like the BLAST study came out that showed similar outcomes in those populations for transplant versus non-transplant, we no longer had a strict requirement that the institutions that we worked with had an in-house transplant facility, but we did make sure that they had a referral network that was already set up in the same city. So in terms of institutional selection, that has been some input from St. Jude, some input from people who had directly reached out to Amgen, because all of the institutions who are part of our program expressed interest in drug access rather than us kind of coming to them and saying, hey, do you want to start a drug donation program? And so it's been a mix in terms of what type of capacity the different institutions have, but at a minimum, referral for transplant is something that we do consider.
In India, the transplant programs are heavily oriented for adult population and pediatric transplant. Tomorrow onwards, there is a meeting in Delhi for pediatric stem cell therapy and cellular therapy. Very few centers are coming up which are there with pediatric transplant orientation. So this needs to be looked at, because in a transplant program, how heavily you are inclined for the adult versus pediatrics makes a difference.
That's also one of the reasons that we have some of the effectiveness data as part of our hybrid study, because we knew that accessibility and transition to transplant was going to be different than what we were seeing in some of our populations in the United States. And so that will be part of what gets reported in our manuscript, is the proportion of patients that go to transplant and the outcomes between the different indications and those that were followed by transplant and not. Because I think one of the things that, as we've talked amongst all of the physicians involved, is really trying to identify characteristics going to help in patient selection process. And I think knowing some of that information sooner rather than later would be helpful.
Great. So indeed, a very interactive session, and we are running out of time. So I would like to invite Dr. Akanksha for the summary of this session.
So I think we are towards the end of the session. We have talked extensively about immunotherapy in probably all the pediatric cancers where there are trials which are ongoing. We have seen how the landscape of immunotherapy has expanded. I don't think I need to go in very much detail. We have discussed this throughout the day today. Very importantly, I think the evidence is very clear that immunotherapy is in some tumors definitely there in relapsed and refractory settings, and more it's coming in the upfront settings. Another important thing is all of us are learning how to also handle the toxicities of the immunotherapies, whether it's CAR-T or Blina or denatumab, all of them. So we are learning this as clinicians. And, I think there's a lot of interesting data coming up from the pediatric solid tumor. And I think we shall close the session now. We have talked a lot about immunotherapy. I think I have nothing much more to summarize. Thank you. Have a good evening.
Thank you everyone for joining. I thank the panelists and also the chairs for having a wonderful session, and the speakers. Thank you so much. Any announcements? So tomorrow we start at 8:30, same place.